Good morning, all of you. And today we start our Pulmocon 2023. And at the onset of this very program, I would like to express my heartfelt gratitude to our speakers, sponsors, and exhibitors for their invaluable contributions in making this event possible. Your dedication in advancing the field of pulmonary medicine is truly commendable. And finally, to our delegates who are the heart and soul of this conference, your passion, expertise, and commitment to improving respiratory health drive the success of this gathering. Your presence here reaffirms our shared dedication to bettering patient care and outcome. So, with these few words, I would like to welcome you all and start our proceedings for the program today. So first of all, we would like to start the program with a symposium on airway diseases. The airway diseases are the bread and butter of any pulmonologist, and so we start the session today with this topic. So first of all, for this session, I would like to bring up the expert panelists. First, I would like to welcome Dr. Ajay Sharkar, sir. So please take the chair in the front. Actually, this is great. Dr. Ajay Sarkar sir is a renowned pulmonologist and intensivist in Kolkata. His primary areas of interest are sepsis and related complications, pleural diseases, sleep-related disorders, and atypical mycobacterial infections. He has served as national faculties in Indian Society of Critical Care Medicine and also chairman of organizing committees of imaging and critical care in 2015. He has a number of publications in national and international journals to his credit, and currently he is associated with PLS Hospital, Kolkata. Now I would like to welcome our second panelist for the day, that is Dr. Sumit Roy Tapadar, sir. Dr. Sumit Roy Tapadar, sir, is he here? No. Okay, so we will start the program. I will first invite the speaker of the day. First speaker of the day, that is Dr. Supriya Sarkar, sir, to please come to the stage and give yours. Dr. Supriya Sarkar sir is Professor and Head Pulmonary Medicine and College of Medicine in Sagardatta Hospital, Kolkata, and he has published more than 50 articles in national and international journals. He has published a book which is a very interesting book, 101 Cases in Respiratory Medicine, and edited API monograms on TB and clinical approach to respiratory medicine. He is a regular speaker. So we will start with you, sir. Thank you.
এখানে এখানে কি আছে রে ভাই? এখানে উল্টো আছে। এই লাইটগুলো অফ না করলে কিছু করা যাবে না। হ্যাঁ, এই লাইটগুলো অফ করতে হবে দুটো বড়। এই না না এই যে স্পট লাইটগুলো। Respected Chairperson, I should thank Parthoda for inviting me and to have a talk, the first talk of the day in the Pulmocon, and my topic is treating asthma in adult, where we stand. Now, let me start with patient education, because patient education is the most important. Whenever you diagnose a case of asthma, first question, is it asthma? Is it curable? Why corticosteroid? Why inhaler? And is it addictive? This question often put to the doctor by the patient, and this is not the question, but patient will do whether to continue medicine when we have no symptoms. And patient will definitely stop medicines when there is no symptoms. So we have to explain everything to the patient, and this part is very important. Otherwise, patient will not take any medicines and patient will not be controllable. Another thing is important is that when we are demonstrating inhaler techniques, patient is yet in the phase of not accepting the disease. That's why he is not listening to your effort to make the inhaler techniques understandable to the patient. Next, avoid the precipitating cause. House dust, mite, other environmental factor, food allergens are now getting importance, smoking, obesity, etc. And how to lifestyle modification we have to do to control asthma. So patient prefers oral route and nebulization during emergency because they are very easy to take and we have to educate them for the inhaler therapy. In the inhaler, the DPI, in particularly in this part of the country where moisture is very high, multi-dose DPI will be preferable, but it is not acceptable to most of the patient and we give single dose DPI. And our preference is always MDI with spacer. And it needs lots of effort to make the patient understand the inhaler techniques. So there are many drugs available, mostly normal usual used are SABA, short-acting beta-2 agonist, long-acting beta-2 agonist, anticholinergic, sometimes we can use, and montelukast, and the most important drug is inhaled corticosteroid. Though adrenaline is now obsolete, but it may be necessary in some cases of brittle asthma. Formoterol has an extended duration of action like LABA, but it has a relatively rapid onset of action, and that's why formoterol is preferable than other long-acting beta-2 agonists. ICS formoterol reduces exacerbation risks, emergency visit, hospitalization, or mortality by 2/3 compared with SABA. The combination also reduces the use of oral corticosteroids, but as far as symptomatic relief, the formoterol is less effective than the short-acting beta-2 agonist. Now, this is the combination of ICS LABA. We know that corticosteroids increases the beta-2 receptor expression and coupling. On the other hand, LABA may have some anti-inflammatory effect, so there is a synergistic effect. Now, facet trial, it is a long back, and it shows that high-dose budesonide plus formoterol is most effective, but it has some toxic effects. On the other hand, lower dose budesonide formoterol is near equal effective. Now, what is low dose ICS, medium dose ICS, and high dose ICS? We should all know the budesonide 200 to 400 microgram is low dose, more than 400 to 800 is medium dose, and more than 800 is high dose, and all other has the inhaled corticosteroid has their classification dose. Now, GINA strategy report is a global evidence-based strategy, and the GINA strategy report is updated every year to torture our postgraduate students. Now, twice yearly cumulative review of new evidence are discussed in this global strategy, and I have some problem with these evidences. How those evidences are generated? It takes a lot of money and there must be some conflict of interest. On the other hand, the evidences generated in the other part of the world may not be applied in another part of the world. These are the two questions, and I frankly I do not believe those guidelines, but I have to talk on them. Another important thing is that patient goal and the doctor's goal may be different. Patient goal is to stop inhaler, and doctor's goal is to make the patient live a near normal life. And symptomatic control and exacerbation, there is again maybe discordance, particularly in brittle asthma. Some terminologies has been changed. The term controller has been replaced by maintenance treatment, and maintenance treatment means treatment prescribed for use on everyday or a regular scheduled basis as required. And reliever, the AIR, anti-inflammatory reliever, when in the reliever ICS is used. It may be ICS with SABA or it may be ICS with formoterol. SMART or MART therapy is the same combination used as a controller as well as a reliever. So there are two, and whenever asthma patient comes to you, we have to review, then assess, and after that adjust the treatment. This is the basic: review, assess and adjust. And there are two tracks of therapy suggested: track 1 and track 2 diplomacy. In track 1, reliever is ICS with the formoterol. As I am described, formoterol has some advantages, and in the track 2 it is SABA or LAMA is used along with ICS. This is the basic difference. So in step 1, step 2, prefer as needed ICS formoterol. In step 3, use low dose ICS formoterol as a maintenance therapy. In step 4, use medium dose ICS formoterol. And in step 5, you can have high dose ICS formoterol, add LAMA, or may refer the patient to Dr. Tarwar for phenotyping and biological therapy. In step 2, the track 2, the same here, the ICS LABA is used as a maintenance therapy, and ICS SABA or only SABA is used as a reliever therapy. So there are infrequent asthma symptoms. Here, as needed low dose ICS formoterol is used. In asthma symptom needs reliever twice a month or more. In those cases, again, as needed ICS formoterol is given. And in troublesome asthma, most days 4 to 5 per week, or waking up in the night due to asthma, here low dose maintenance therapy has to be given. And in severe cases where initial presentation is uncontrolled asthma, or in acute exacerbation, the medium dose ICS formoterol has to be given as MART. But here you can see evidence is weak, yet it has been recommended. Now this is the new concept that has been added, the step of treatment. So again, review, assess and adjust. Assessment is done for the inhaler technique, addition to treatment, continuing allergy exposure and multimorbidity. Spirometry before starting treatment, at 3 to 6 months following starting treatment, and then yearly or twice, too yearly. 3 questions that are basic: difficulty in sleeping due to asthma, daytime symptoms, and activity limitations. So there are some questionnaires: asthma control questionnaire 5, I am not going, and then 2 has been added, the amount of bronchodilator used, and also FEV1 pre-bronchodilator is taken as 6, SEQ 6 and 7. And similarly, asthma control test, there are 25 scores, and if its score is more than 20, it is well controlled, less than 20, it is not controlled. Why control of asthma is necessary? Good control improves patient quality of life, decreases airway inflammation, reduce the risk of exacerbations, reduce hospital admission, mortality, morbidity, and help to plan step down. There may be discordance between asthma control and risk of exacerbation, particularly in brittle asthma. What are the predictors of high exacerbations? High SABA use, other medications medical conditions like obesity, rhinosinusitis, GRD, food allergy, pregnancy, obesity, smoking, allergy exposure, air pollution, psychosocial factor, lung function. If the pre-bronchodilator FEV1 is less than 60% of predicted, or if there is high bronchodilator reversibility, high blood eosinophil count, elevated HFNO, elevated intubation, ever intubation, ICU admission, and more than one severe examination in the last 12 months. These are the predictor of high exacerbation risks. Now, asthma mimics COPD, left ventricular failure, upper airway cuff syndrome, gastroesophageal reflux disease, vocal cord. They can mimic like asthma, as well as they may coexist. When patient is not responding, please search them and treat them. And other factor, obesity is now said to be very important than the obstructive airway disease, depression, and hypersensitivity pneumonia. Recently, a lady came from UP, and she has a well-controlled asthma. And now it is not controlled with medicines. And patient occupation is that patient is dealing in National Library, in National Library and dealing with books, old books. So HSCT shows that there is centrilobular nodules, and the removal from this place is very important, because in the early stage hypersensitivity pneumonia is curable. Difficult to treat asthma, I have already discussed, and optimizing treatment, increasing the inhaled corticosteroid, additional LAMA, inhale. Now change of inhaler devices and change of inhaler formulation. These are the two important steps. Use of nasal corticosteroids, removal of the allergen precipitating factors, and pulmonary rehabilitation, particularly exercise, yoga, pranayama, etc., are very important. Next step will be discussed by my other speakers. Asthma exacerbations, I am not going into that, but I am giving one example. A 16-year girl with irregularly treated asthma. In asthma, what we are expecting, there will be hyperventilation, so the respiratory alkalosis. But that patient has the respiratory acidosis. Even normal carbon dioxide in acute exacerbation is a danger sign, so patient was intubated. And as the patient condition on the third day, there is a deterioration, and carbon dioxide was 129. Patient was referred to Kolkata. And what happens? This is the first X-ray, and patient is swollen with subcutaneous emphysema, and you can see it, but there are deep sulcus signs on both sides. So we introduce intercostal tube bilaterally. It is very difficult to identify the pneumothorax in a ventilator patient, particularly bilateral pneumothorax is very, very difficult. And believe me, the patient was extubated by 3 days and was discharged by 2 weeks. So other factor has to be looked for when patient is not responding. So it is a step down every 3 to 6 months. We have to decide whether we can step down. Now, SABA alone is not at all recommended. ICS should be used whenever SABA or LABA is used. Low dose ICS formoterol is the undisputable preference for maintenance as well as reliever therapy. MDI with spacer is the treatment of delivery system of choice. Proper demonstration of drug delivery device is mandatory at every visit, and preferably by doctor himself. Drug compliance, it should be remembered, drug compliance does not depend on age, sex, educational status, marital status, socio-economic condition, ethnicity, and geography. Take everybody similarly. It is not depend, and patient education, and patient education is the key of success. Thank you.
Thank you, Dr. Sarkar, for giving us an overview on asthma management. Without taking much time, I'll go to the next speaker who is going to talk on neutrophilic asthma, its clinical and inflammatory characteristics with management approach. And I would request all the speakers to stick to their time so that we'll have some time to discuss about topics, because there are many issues probably is left out so we can discuss. And there is a panel. I don't know where is the panelist, but I'll ask all the speaker to be a panelist and then we can discuss. Thank you.
Thank you, Dr. Sharkar, and thank you, Parthuda, for the invitation. So today, can I have the presentation mode? So today, it's a day for neutrophils and not eosinophils. But it's asthma, all right. So here's my topic. And the objectives of today's talk is to recognize neutrophilic endotype of asthma in clinical practice, demonstrate how the neutrophilic endotype of asthma is managed, just the mere guidelines, and I promise there's going to be no mechanisms today. It's just a clinical talk, so this is a typical patient of neutrophilic asthma, and I'm sure we have seen this patient in all our clinics sometimes or the other. So it's a 38-year-old male with asthma from her late 20s, non-atopic, never smoked, at least 15 ER on unscheduled specialist visits in the past 1 year. Courses of prednisone monthly. Symbicort is the combination inhaler that we use, 12 puffs at least on a day. Montelukast, theophylline. So we have most of the drugs that we usually prescribe patients as a cocktail whenever the patient comes to us with symptoms. So we looked for all the aspects that Dr. Supriya Sharkar talked about when we assess severe asthma patients. There was no ongoing exposure, HRCT normal, and cardiac consultation was normal. So what do we do with the patient? If we go through the GINA 22 guidelines, this is what it says, and it's very busy. I'm sure you're not being able to see what that is. So investigations for patient who does not respond to usual treatment, this is what GINA suspects, and GINA suggests also. The first para says consider CBC, CRP, IgG, AM, IgE fungal. So these are all markers of eosinophilic asthma. And the thing that I want to point out is when we are diagnosing neutrophilic asthma, it's always a negative diagnosis. What I mean by that is that if you do not have eosinophilic asthma, it means you have neutrophilic asthma, which is not true. So as we go through the presentation, we'll realize that and neutrophilic asthma is not a diagnosis of exclusion. You have to make it a diagnosis of inclusion. So coming back to the patient, the endotype of the patient is something that you can guess from here. The pre-bronchodilator FEV1 was 1.6, FVC 0.2, and there was 150 ml and 9% reversibility, which is not a completely reversible asthma, but because it's the ratio is low, this is a asthma patient, all right. So the investigations that we do first in our clinics is to do a total cell count, which is normal here, and absolute eosinophil count of 120 is again normal. Total IgE of 180 is within the normal range, and FeNO 27. So FeNO is exhaled nitric oxide that we measure to understand the adherence of the patient, and it's normal. So this is not Th2 or eosinophil driven disease, all right. So according to GINA, this means that it is a neutrophilic asthma or a non-Th2. Now, non-Th2 asthma is not only neutrophilic. Non-Th2 asthma can be possigranulocytic also. So if it's not Th2, it's either neutrophilic or possigranulocytic. And it's up to us to look for evidence and confirm that this is a neutrophilic asthma. So the way we have to diagnose neutrophilic asthma with the limited setting of not having an airway inflammatory lab going on somewhere would be to do a blood eosinophils and maybe to do a sputum eosinophil. But blood eosinophil is not a marker for neutrophilic asthma. Remember that, because the neutrophils could come from any source, any inflammation, any infection going on anywhere in the body. But if you have to prove that it's due to the asthma, then you need to do a sputum quantitative assay. And that's a take-home message for management diagnosis of neutrophilic asthma. So this is the test that we need to do to understand that neutrophilic asthma is not a diagnosis of exclusion. You have to confirm by doing the correct test, and that's sputum assay. And this is the man who popularized the sputum quantitative assay. There are at least 200 methodology papers. So when we do the test, we need to keep in mind that we do not try and say that we do not have this, we do not have that, so let's make a compromise. That's not going to work, because 150 or 200 methodology papers is not a joke. So here goes the process. You take the sample from the patient, a sputum sample, which is spontaneous or induced. It does not have to be induced always. If the patient has a spontaneous sample, you take the spontaneous sample, look into the sample through an inverted microscope to pick out the portions of the sample which are very, very densely populated by inflammatory cells. Now, when we select out these inflammatory cells, they are usually entrapped with the mucus in the sample. So we do give a sputolysin, that's a DTT, filter it through the nylon mesh, and then the filtrate is divided into two parts. The first part goes into the hemocytometer for doing a total cell count, and the other part we put into a cytospin where we get a monolayer cell, monolayer slide, which we stain and see through the differential count. These are the values for the healthy adults. So total cell count we usually pick the 90th percentile for getting the normals. So if the count is more than 9.7 cells per gram of sputum, then it's high. If it's more than 1.1 is just a statistical number. You can't have 1 and 1 by 100 cells. So it's 2%. If it's more than 2%, then it's eosinophilic, and if it's more than 65%, it's neutrophilic. So reiterating what I said, eosinophilic is more than 3% with a normal total cell count. Neutrophilic is more than 65% with or without an increased TCC, that's a total cell count. You could have a combined inflammation, and postinocytic is one that we miss if we do not do the tests. So the patient may have a postinocytic inflammation going on in the airways, and we assume that the asthma is not being controlled, and we add more and more of therapy which the patient is not doing well on. For example, if this patient that we saw, if we do not do a inflammometry, that's the measurement of inflammation in the sputum, you would think that this patient has got uncontrolled eosinophilic asthma, and you would add more and more of steroid. Visolone, go up on the dose, go up on the inhaled corticosteroid dose. And that is adding things which do not work in a certain patient. Coming back to the patient, we did a sputum quantitative assay because we have the facilities of doing so. The total cell count was 10 million cells per gram. So what's that? Is it increased or low? It's increased, right? So we talked about 9.7 being the cutoff value. 70% neutrophils, is it more or less? It's more. Okay, so the patient has, with a 2% eosinophils, mind it. So the patient has a neutrophilic inflammation going on in the airways. So how are we going to treat it? Not by corticosteroids, of course. It's going to be an antibiotic. So this is the strategy that we follow if the diagnosis is a neutrophilic bronchitis. If the total cell count is more than 25 and more than 65% neutrophils, antibiotics. If it's around 65 with a raised total cell count, it's antibiotics again. But if it's less than 10 and if the neutrophil counts are less than 65, antibiotics are not prescribed. So this is data from my lab. It shows that most of the people have a eosinophilic inflammation going on if we looked at the blood eosinophil count in the severe asthma patients. But the moment you do a sputum quantitative assay, you find that the eosinophilic counts have come down and the neutrophil counts have gone up. Now, why does this happen? How can we explain this phenomena of if we do the blood, we have a large number of eosinophils, but when we do the airways, the neutrophils are higher. So no pathogenesis today, so you can just take a look at it if you want. This brings me, I left that question open on purpose, so we'll discuss that a bit later. But let's look into this patient who is a smoker for 21 years, emphysema, mild bronchiectasis, 2 to 3 exacerbations a year, no pneumonias on high dose in combination inhalers. Look at the lung function. The first exacerbation brought down the lung function to 1.6, that's FEV1 to 1.6 from a 2.2, and the second exacerbation further went down the FEV1 of 1.2. So exacerbations with loss of lung function. Now when we did the sputum for these two exacerbations, the first exacerbation shows that the patient has a raised total cell count with a raised neutrophil count. So it's a neutrophilic asthma. And how did we treat? We treated with antibiotics and bronchodilators and with close monitoring, and the patient did well within 6 days. Now the second exacerbation was a eosinophilic exacerbation, as you can see from the numbers there of the sputum quantitative assay. And so how did we treat? We treated with prednisolone. So two exacerbations might have different endotypes going on. So according to the endotype, we need to treat the patient, treat the neutrophilic with antibiotics and not steroids, and treat the eosinophils by prednisone and not antibiotics. And another important point is that this is masking the eosinophils. So if you have a lot of neutrophils, and we express the terms by percentages, then this might happen. If we look at the absolute values, it may be different. But if we look at the percentages, because of the relative change in their numbers, neutrophilia can mask an eosinophilia. So we should always repeat a sputum assay 6 weeks after an exacerbation. Now this is why I left that question open. So neutrophilic bronchitis, that's neutrophilic asthma, is not caused only by asthma exposure or allergy. There is a whole list of neutrophilic bronchitis etiologies. And when I look at this list and think of my patients, I think steroid overdose is something that we all do nowadays. If the patient doesn't get relief from a certain dose, add more of corticosteroids. And that's what has happened. So corticosteroids should be given only after you have solid evidence of eosinophilic bronchitis. So a few words about the management options. We could do a non-pharmacologic management, which is stop smoking, weight loss, because one of the risk factors for neutrophilic asthma is thought to be obesity, non-specific antibiotics, macrolides, PDE inhibitors, and tiotropium. So these are not specifically directed towards neutrophils, so we call this a non-specific antibiotics therapy. And of course, tiotropium. What about biologics? I'm sure we are going to hear more of this. The names are a bit confusing sometimes for people who do not use them all the time. Tezepelumab is anti-TSLP. Golimumab is anti-TNF-alpha. Etanercept is also a TNF-alpha. And we do not yet have the other two in our bank. Brodalumab, that is IL-17 receptor, and risankizumab, that's IL-23. I did not go through the pathomechanisms, but if you want, I can show you the slide again and you'll understand why exactly where these biologics work. Now, the reason these biologics went away from fashion, like the TNF-alpha inhibitors, was because they did not work properly. And it was found that if you can phenotype your patients correctly, that is, some of the polygranulocytic people responded to anti-TNF alpha because anti-TNF alpha worked on the muscles. So it works on the twitchiness of the airways, which is asthma. And if you could give etanercept or maybe the other anti-TNF alpha to these patients, they might respond. So I'll summarize, and I have a lot of time for questions if you want to ask me. Neutrophilic asthma can be a challenge to identify. Guidelines diagnose this endotype from a negative perspective, which should not be the case. We should all be able to have access to sputum quantitative assay, which is the only test to identify neutrophilic asthma accurately. Clinically, it's different, but if you need to confirm, then we need to do the test sputum quantitative assay. I forgot to mention that yesterday I saw a report of sputum quantitative assay. It says done from a lab outside. I'm not going to take the name of the lab, but the report says sputum eosinophils present, and that's it. So what does it mean? Sputum eosinophils present means nothing. It's going to be there in a normal sample as well. So be careful of these tests when we prescribe these tests. Send it to the correct person with the correct technology. So management is based mainly on non-specific strategies, and we are scared to give biologics because if we kill all these neutrophils in our body, then what happens to the infection? You are taking away the firefighters and putting the patient on fire, so that's not done. So biologics are still to find its place in clinical practice. Thank you very much.
Thank you, Dr. Dasgupta, for giving a clear view when to suspect neutrophilic asthma and what needs to be done in that situation vis-a-vis eosinophilic asthma. And we'll have few questions and we'll discuss later on after all the speakers finishes their talk. Next speaker is our, I think, two of Dr. Abra Bansal and Dr. Srijita Sen. Oh, Dr. Partha Sarathi, he's take the. Thank you, Partha.
Thank you, Chairman, sir. I've been dragged into this business. So what I'm going to talk today about the OAD unclassified. This is a fascinating term, and I felt very interested to elaborate unclassified OAD. I just want to ask you all, how many of you see patients whom you cannot classify clearly? Just raise your hands.
Before that, Partha, I'll say that the trend is writing OAD. Obstructive airway
there is a
disease,
reason.
because to avoid the
Confusion.
insurance claim,
Okay.
they are being declining if you say COPD or CAD.
Okay.
And if you say OAD, then
There is a good tip. So you write OAD, don't write COPD. It is an umbrella cover for everything. So I find a lot of hands going up. So I am sure that all of you find patients whom you cannot clearly classify into one group, either asthma or COPD. Then last night it was my duty to start this preparation. So I looked at my good friend Google and I asked him, what is obstructive airway disease? And it replied, a common lung disease causing restricted airflow and breathing problem. I said, okay, although this is meant for people, it is also meant same for me. Thank you, Google. The next question I thought I would ask, what are the causes of the obstructive? What are the obstructive airway diseases? The answer was asthma, COPD, bronchiectasis, and cystic fibrosis. Fine, I agree. But I thought that bronchiectasis and cystic fibrosis, they are distinct, entities whom we can diagnose, segregate. So I am left with asthma and COPD. And this is a major bulk of our obstructive airway disease patients. And is there anything beyond asthma and COPD in day-to-day practice? So I struggled in fact to find unclassified obstructive airway disease or anything beyond COPD and asthma, and I didn't find any good response. A lot of literature on different areas, but nothing specific. Asthma, COPD, and unclassified airflow. People are talking about COPD a lot, but nobody's talking about asthma, COPD overlap, but not about. You can see my struggle. A lot of questions been asked to Google, and finally I thought that well, I have to make my own way. Meanwhile, I looked at one single letter to editor, which was very interesting. The author writes, J.B. Martinez. He writes that incorporation of a clear concept and the use of precise terminology are fundamental requirements to ensure good communication among health professionals as well as proper care of patients. it came very close to my heart because I understand when I was a student, I was struggling to understand why COPD is this, why the definition is just 3 months for over 3 years, chronic cough without bronchiectasis. Things were quite difficult for us at that time to understand. The author goes on, airway diseases have always been fertile ground for use of incorrect terms and the proliferation of nebulous ideas. It gives a scope for idea for me also. Although it was to be expected that these problems would be reduced over time, conceptual vices remain, especially among physicians who are unfamiliar with our specialty. This is, I believe, is a very good comment. And he notes that there are certain conditions which cause persistent airflow limitations but not COPD. And we all know that severe asthma, bronchiectasis, tracheal stenosis, sarcoidosis, lymphangiomatosis, then Langerhans histiocytosis, bronchiolitis obliterans, they can cause persistent airflow limitations. So I'm not going to read out the summary. I'm passing straight to my realizations. What I was realizing last night, I was scratching my hair. I was thinking there is no unclassifiable or unclassified airway disease altogether. Then I thought people did not think about it. They didn't bother to think about it. Although I find such cases quite often. Then the next thought is people know about this, but they do not like to traverse the path because it is not elaborated. Better drop it. Better stay between asthma and COPD and go on doing practice. Then I thought, okay, no, this cannot happen. There are so many experts. The next thought was the experts have tried to avert the question recently, making airway disease a COPD. All airway disease is COPD if the FEV1 by FVC ratio was less than 0.7. This was in 2015 or 2014 when the gold guideline came up with this idea without bothering the reversibility. And to my mind, reversibility is a major question because we find a lot of patients have got reversibility, which is significant. And if the patient has obstruction, if you can relieve the obstruction, it is good. And this relief of obstruction is a definite sign of obstruction. Why can't you say reversibility is a sign of obstructive airway disease? Unfortunately, that is not given the adequate stress. And then I decided that our definition of obstructive airway disease is immature or altogether absent. So the Google is not responding. It's not a flaw of Google, and we need to think and for defining and classifying airway disease altogether and afresh. So this is a question I asked you at the beginning, and with this I request my colleague, our research fellow, Sijita, to present our experience. Sijita, please.
Thank you, sir. Good morning, everyone. So today I am going to talk about a spirometric appraisal of the unclassified OADs, and I am going to bring both the salbutamol and glycopyrronium reversibility in the picture. So to start with, we have classified the OAD patients on the basis of post salbutamol FEV1 reversibility and FEV1 by FVC ratio into three groups: asthma, COPD, and the unclassified. So here are the three groups and their respective spirometric criteria. Now when we come to the unclassified group, we have seen that on the basis of the spirometric variations, we can further classify them into 5 subclasses. So these are the 5 subgroups and the respective spirometric variations. So now let's come to the way in which we have screened for the unclassified OADs. We have took all the suspected OAD patients from the OPD on consent and then subjected to a serial reversibility test, first with salbutamol followed by GP. And then on the basis of the salbutamol reversibility, we have classified OADs into asthma, COPD, and the unclassified. Further, on the basis of the spirometric variations, we have subdivided the unclassified group into 5 subclasses. And finally, we went for the statistical part using the GraphPad prism. So in the results section, we can see that a total of 1580 OAD patients have been recruited, among which 329 are the asthma patients, 641 are the COPD patients, and the remaining 610 are the are the unclassified patients. When we come to the unclassified group, we can see that group 1 has the highest patient number, that is 324. This is the group where we can see no obstruction, but the reversibility is less than 12% and 200 ml. Following this is group 4 with the patient number of 204. So here we can see that there is an obvious obstruction, but the reversibility is more than equals to 12% and less than 200 ml. So this group shows almost a preserved lung function with the ratio being low, and thus we can refer to them as the pre-COPD patients. So this slide shows the reversibility status of the unclassified OADs. So here the shades of red represent the salbutamol reversibility status, and the shades of blue represent the GP reversibility status. The dark red is the salbutamol reversible patients who show a reversibility of more than equals to 200 ml. The dark blue show the GP reversible patients who show a reversibility of more than equals to 100 ml. And here we have taken only the absolute values of the reversibility. So we can see that the salbutamol reversibility is not present in 3 of the 5 groups, but the GP reversibility is universal among all the 5 groups, ranging from 13% to approximately 25%. Generally, we don't bother about the reversibility to this class of bronchodilator called the antimuscarinic agent. So let's have a quick glance at the demographic details of the OADs. So here we can see that group 4 belongs to the highest age group, followed by the COPD patients, and the exact reverse pattern can be seen for the BMI, that group 4 has the lowest BMI followed by COPD. And in the case of the sex ratio, we can see that details all of the cases, the males are OADs than the females. So we looked at the spirometric details for the overall unclassified group, and here we can see that in case of the absolute values, the FEV1 reversibility shows a significant change post salbutamol, and the reversibility post GP, which was highly expected. And when we looked at the percentage predicted values, we can see that FVC and FEV1 reversibility showed a significant change in between the two classes of bronchodilators. So next we further moved into the spirometric details of the subgroups of the unclassified group. The important thing we saw here that the combined reversibility, which we get by the summation of the salbutamol reversibility and the add-on GP reversibility, is almost more than equals to 100 ml for all the 5 groups. So we can say that a minimal perceivable change of more than equals to 100 ml is seen if both the bronchodilators are used together. So to sum it up, we can say that the unclassified group forms a large part for the OADs, and on the basis of the spirometric criteria, we can further subdivide them into 5 subclasses. Salbutamol reversibility is not present in all the patients of the groups, but we see the GP reversibility is almost universal among all the patients, and minimal perceived reversibility of more than equals to 100 ml is seen if both the bronchodilators are used. So we can say that the absence of the salbutamol reversibility does not mean the end of the game, and we should look at this unclassified group of OADs and focus on both the salbutamol and GP reversibilities. So lastly, I want to thank my guide, Dr. P.S. Bhattacharya, for giving me a chance to present my work on this stage. Thank you, everybody.
Thank you, Sujita. So you have realized that there is a huge chunk of patients, roughly 39% in our referral OPD practice, have got unclassified OAD. All these patients had symptoms. The diagnosis of OAD or obstructive airway disease was initially based upon the clinical symptoms. If the patients have got at least 4 of the 5 symptoms as cough, shortness of breath, wheeze, expectorations, and tightness of chest, 4 out of 5, we considered them as patients of obstructive airway disease. So that was a criteria. Second important thing is projected is that all this patient underwent a serial reversibility test. Usually people stop after doing the salbutamol reversibility, but this glycopyridine reversibility is our sort of evolution. We have started doing it, we have published it, and this is a very good adjunct to salbutamol reversibility. This gives an idea how far an antimuscarinic agent will be working on this particular patients. So forget that glycopyridine reversibility, even if you stay with a salbutamol reversibility and try to classify the patient, you find a lot of patients are unclassified, quote unquote. So with this, it's
Thank
not over.
you.
No, there were slides.
Oh,
Why did you change?
you haven't finished.
No, it
Yeah.
is not finished. It's the same story continued. So anyway, so we looked at it a little thoroughly, and I will show you the results. I commented that people haven't thought about it. It is strong. It cannot be so. So what I realized that people thought about it, and people thought in a different way. We are possibly going in a different way. And it's like a big elephant where somebody is touching the tail, somebody is touching the ear, somebody is holding the one of the foot, one of the limbs, and okay. So it looks different. Please go down. Another very important, interesting observation is that all this group has got a good chunk of them showing GP reversibility. Next. Yeah. So this is a slide where she has shown that 610 patients, or 38.61% of the patients, are unclassified. In this reversibility, the two reversibility parameters are different. It is 200 ml plus 12% for salbutamol reversibility, and it is 100 ml for glycopyrunia reversibility. Why? Because that is the minimum perceptible change by a patient. If you treat a patient with a bronchodilator and can improve the FEV1 by 100 ml, the patient will feel relief. So that is a clinical criteria. We have taken the criteria for glycopyrronium because we have observed that it cannot go same as the salbutamol in terms of the quantity of reversibility. So these are the 5 groups. If you divide these 5 groups, in the first 3, the FEV1 by FVC ratio is more than 0.7. And this group has got change in reversibility, but also in change in reversibility, but we have not documented change in FEV1. So what is it? FEV1 by FVC more than 0.7 is taken as normal, although it is debated. But with this normal ratio, reversibility difference can make diagnosis of obstructive airway disease, quote unquote, unclassified. Are they PRISM? They do not fall in the diagnosis of PRISM or diagnostic criteria of PRISM. PRISM is preserved ratio impaired spirometry. This is one group been advocated in 2014 as a obstructive airway disease, and this group is different altogether from PRISM. So I have given a query before it. And the 4th and the 5th group shows FEV1 FVC ratio less than 0.7, and there is also change in reversibility. So are they COPD or are they query pre-COPD? The definition of pre-COPD is also different. Coming to this last 4 groups, if we think that they are COPD or pre-COPD, or if they are COPD, they form about 13.5% of the total patients. So let me go a little bit into PRISM, and this is one big database presented where over 18,000 patients were screened, and I'm quickly reading the current knowledge about PRISM. It is a spirometric pattern associated with respiratory symptoms and increased mortality. Individuals with PRISM represent a heterogeneous group of diseases. It is possibly underdiagnosed and underappreciated. It is likely more prevalent in patients in academic medical centers and in larger cohorts of medically complex patients. And this paper, it just gives a statistics, but it says, it adds to the knowledge by saying that PRISM was more prevalent in our spirometry database compared to previously reported prevalence in general population. It remained very stable in several analysis groups in their study. Individuals with PRISM represent a heterogeneous population that cannot be fully explained by obesity, interstitial lung disease, of or difference in race. So there are a lot of things in PRISM itself. We have not gone into details of it. We have just shown you the spirometry, and we have shown that they could be PRISM. And we have pointed out that definition of PRISM is also inadequate or incomplete. This is a very interesting paper. Incidentally, I thought that I should project that the ratio of FEV1 by FVC and its association with respiratory symptoms. And it says that the odds for any respiratory symptom continuously decreases with a higher FEV1 by FVC ratio. That means if you have got a FEV1 by FVC ratio of 0.8 or 0.85, the chance of symptoms is low. If it is less, it is more. And more it is lower, the symptoms will be more. Okay. And these results indicate that optimal threshold associated with respiratory symptoms may be higher than 0.7. And this should be further investigated in prospective longitudinal studies. That's what we have seen, that most of our patients have got a FEV1 by FVC ratio less than 0.7. It's a very interesting letter to the editor, not going into details, and I'll end with this particular small letter to editor, where unraveling young COPD and pre-COPD in general population. See, people have not yet defined what is pre-COPD and what is young COPD. And this EpiScan 2 study, it takes the pre-COPD was defined as a presence of emphysema more than 5% and or bronchial thickening. So it is CT scan based. Bronchial thickening by computerized tomography, scan and or diffusion capacity of lung for carbon monoxide less than 80% of the predicted in subjects with respiratory symptoms, and post bronchodilator forced expiratory volume 1 second by forced vital capacity more than 0.7. So essentially that more than 0.7 ratio has been taken for diagnosis of pre-COPD. So we have to work a lot on it. Thank you very much. This is just eye-opening for us. It is a byproduct of our research on glycopyrronium reversibility. I thought it would be interesting for this audience to be presented. Thank you, sir.
Thank you, Partho, for excellent work on these areas, and you have given a classification for unclassified group. Thank you. Thank you. And next speaker is none other than Dr. Talwar, and he will be talking on treatment of OAD beyond bronchodilator and ICS. Obviously, it will be a biologics.
It's about role and room of biologicals. And I think first of all, I would like to thank Pathasati for inviting me, not for this Pulmocon, but definitely something very, very intriguing and a research-oriented product of his work, which has been so nicely projected that I'm just going back 25 years ago when we started our labs at Metro hospitals, and salbutamol reversibility was not coming in all patients. So I said, Duolin had come at that time. I said, instead of salbutamol, use Duolin for reversibility for all of them. And believe me, since then, our lab has a standard of using both of them actually. So they use in combination. And the point he has brought is so well that when we call it as a prism, we really actually do not know what we are talking about. Absolutely. It can be a patient of asthma which is perfectly normal and not yet detected. It can be a COPD patient like pre-COPD, young COPD, so many terminologies. I think it all boils down to one thing, that our knowledge in obstructive airway diseases is far from clear and far from what we can say is the end of it. We need to learn much more, and I think we are moving towards what is called as the treatable trait and bronchodilator reversibility, be it to salbutamol, be it to glycopyrronium or ipratropium, is a reversibility and is a treatable trait. And I think that's the way forward. And to top it up, I think Angira brought this subject so well that, you know, it's ultimately the neutrophils, the eosinophils, no cells who are going to decide your management. So that is also a treatable trait. Only problem is all these treatable traits are very fluid. They keep changing over a period of time, span of months, span of years. And then you keep changing your tracks as per the patient's trait. And I think that's the most important thing. And when Partha wrote that it is beyond the inhalers in obstructive airway diseases, so I think he wanted me to expand a little more beyond asthma to see that when it is so called as unclassifiable, will you be able to use biologicals or not? And my answer at the beginning itself is yes. We do not distinguish at that point of time because we know if there is an eosinophil and there is no other cause for that eosinophil to play the dirty business in the airways, then if you target that, you will get the response. And targeted therapy, obviously, for us at present, will not be of choice to give steroids, but to look for, of course, the room beyond the biologicals. So I see a lot of young brain. Always, I have changed the presentation from what I did to this distinguished gathering about 2 months ago or 3 months ago. What is a biological? So we keep talking about biologicals, and we know that these are the products which we are using to treat the patients, but it's not necessarily that. It is a product which is also used to diagnose as well as prevent the diseases. And the most important point about biological is it is obtained from living organisms, and in contrast to drugs, it's not a chemical. And primarily, the entire science of biotechnology and biosimilars is all revolving around what is called as biologicals. And this will be a war in next 10 years where you will have a biological for almost each and every condition, because the moment you understand the pathophysiology, you understand the cells, you understand the cytokines, you will be able to achieve what you want to achieve by targeting that molecule. And that's all the story about the biologicals. The story starts with using what is called as monoclonal antibodies. And the first question which comes to mind is, what is a monoclonal antibody? So monoclonal antibody is an antibody which is formed as a monospecific. So it's specific target against one particular thing. It is not a immunoglobulin IgG. You can go and hit across anything. No, it's specific. So it is monospecific. It is against one particular cell or a one particular cellular cytokine. And for that, you need to produce it from a single cell. And cloning that single cell to produce that antibody is what is the answer for a monoclonal antibody. It can be totally human, in which 100% antibody is formed from the human protein resource. And that is called a map, basically, and it's a human map. So UMAP is something which you call as a total human monoclonal antibody. And I'm only going to give you one example today is dupilumab, which is an actually total human monoclonal antibody. What are others? So others are which contain a variable extent of porcine protein material. So you do get from the rat. And how much it gets vis-a-vis the human antibody determines the name. So if you get just about 10%, you call them ZooMaps. And we have plenty of ZooMaps. Mepolizumab, omalizumab, benralizumab. All these are ZooMaps because 10% protein content comes from the rat. Then there is one in which there is a huge amount of protein, about 40% from the animal. And that is called ZUMAB, XUMAB. You will remember your rituximab for that matter because it contains more than 40% of animal protein in it. Implication, more animal protein, more anaphylaxis. So that's why rituximab typically we give under close guidance, while the drugs like mepolizumab, omalizumab, benralizumab, dupilumab, all are given at home by nurses now. There are no need to be administered in our offices, in our clinics, in our ER rooms. So this is the spectrum of biologicals which is available, and I think very nicely Angira brought a point that there are many more which are on the process. I'm not going to discuss about them, but we do understand that some of them which are available are the ones which are shown here. But you can see clearly that IL-4, IL-13 and IL-5 are the three major cytokines which are at the moment are in the market, ready to use in clinical practice, and lots of us are still using it. Maybe one or two are not yet available, but would be. And of course, some of the new ones, which are the new kids in the block, are also in the offering. This is the same picture which Angira skipped it. I do not know whether I have that much of patience to skip it or not, because this is the most important picture for you to understand that why and which biological you need to use. She talked about type 2 inflammation and non-type 2, so I won't go into that. But what it means is anything which injures the respiratory epithelium has to first encounter the epithelial released cytokine, which is TSLP. Once that is done, whether it is a pollutant, a virus, or an allergen, it will set a different cascade down into the airway submucosa, leading to various cells and cytokines into either type 2 or non-type 2. In the type 2, it will go into type 2 cells and of course innate lymphoid cell 2, which are the primary drivers for two kind of responses. One IgE mediated, which is called atopy, and second, which is eosinophil mediated, which is called eosinophilic. So type 2 inflammation, two types. The other one, which actually stimulates the type 1 cells, Th1 cells, release the cytokines like IL-17, IL-33, and get into a different pathway altogether. And that picture also very nicely shown again that there are already work on progress on these molecules, and there won't be many years. I don't think so we will be surviving the end of this decade without getting them onto place and into clinical practice. So we will be able to target them also. So when we choose a biologicals in severe asthma for type 2, we need to identify these in our clinical practice. It's not always easy, but we always go by clinical features and combine it with certain biomarkers which are available to it. So the first question is, what are those clinical features? So the onset of asthma is the most important surrogate marker, whether it is type 2 or non-type 2. Angira showed you that little more elderly people will be more likely to have non-type 2, while young, childhood onset, adult early onset asthmatics would be the patients who will be type 2. Now here I want all of you to understand that if today I write a patient diagnosis of severe asthma and he is at 65 years of age, don't pre prejudice, don't go prejudiced against that patient that he is 65, he will be having a non-type 2. Because onset of severe asthma and onset of asthma are two different things. A patient who is at 65 years having diagnosed as severe asthma gives you a history that he has been suffering from asthma from childhood, means that he is a type 2 asthma. He is not a type 1 asthma or non-type 2 asthma. We have failed to distinguish between onset of asthma and onset of severe asthma, which is invariably 30 to 40 years, even all across the world. Another features like allergic comorbidities are very important. I think everybody says that if the patient sneezes in your table, you know that what he has allergic rhinitis. And we know allergic rhinitis is predominantly IgE mediated atopic allergic rhinitis. Similarly, atopic dermatitis, chronic sinusitis, nasal polyposis, ABPA, EGPA, HES, many things which are driven by the eosinophils. But the bottom line is type 2 inflammation. Can I have a water, please? Type 2 inflammation is what is steroid responsive, exclusively steroid responsive. You give them steroids, they become all right. You stop the steroids, they relapse back. And that's what is distinguishing it from a type 2 asthma. She showed you the case of non-type 2 asthma where we kept on giving steroids, nothing happened, showing that this is not steroid responsive. Something is wrong here. You really need to work on that. The biomarkers, very simple few biomarkers. Blood eosinophil 300 or more than 300, FeNO 20 or more than 20, sputum eosinophil 2 or more than 2%. But remember, biomarkers are fluid. They are not the same every day. So if you test it on day 1, you may get a different response. And when you test it 3 months down the line, it may be different. So they need to be repeated at least 3 times in a year before labeling it non-type 2 asthma. And this is the scheme of various monoclonal antibodies. And you can imagine why I showed that slide to you. That anything which blocks the IL-5 is an IL-5 blocker. 3 of them, benralizumab, mepolizumab, and reslizumab. Then anything which blocks the IgE is omalizumab. And the one which blocks IL-13, IL-4 is actually the dupilumab. But the new one, which is the TSLP, that epithelial cytokine inhibitor, is tezepelumab, which again Angira spoke about it. But we have many more in the offering. But very important to remember, only one of them is for IV use. Anybody can answer which is for IV use? Good. Which are the ones which are given twice a month? Very good answer. Anybody now? Good. Very nice. Also resilizumab. 2 of them. And also omalizumab. Many of them can. Omali, of course, can be once a month also. So this is omalizumab, humanized 10% animal protein, monoclonal antibody, all hue and cry about its allergic reactions when it was launched in 2009. Now it is given at home because we have realized that it is safe. And what it does is, it goes and occupies those 2 receptors which are there on the mast cells, and now it does not allow the mast cells to degranulate, release the histamine, and cause the histamine related bronchoconstriction and airway inflammation. So you can use it whenever there are other atopic markers also, like allergic rhinitis I told you, also sinusitis and idiopathic urticarias. And sometimes you combine it with immunotherapy when the patients are not doing very well on alone immunotherapy. These are the ones which are anti-IL-5. Both of them are available. The only difference between the two is one is a receptor antibody and the another is a direct neutralizes interleukin 5. So which is the antibody one? Which is the antibody one? Which blocks the IL-5 receptor site? Everybody knows benralizumab. So by doing that, it cross-linking also to the cell, which is cytotoxic cell, and causes complete degranulation and death of the eosinophil. And that's why benralizumab, after single administration, causes complete disappearance of eosinophils from the peripheral blood. Does that same apply to the airways? Perhaps not, because airways do not get completely repleted. It's only on the blood. Now, this is the picture which, there are no direct comparisons. Most of the people keep asking me, which one is potent, which one is not potent. So this is the data driven from all clinical trials, phase 3 clinical trials of these 3 drugs put together. And very nicely it shows you Mepo and Benrali have got a very good reduction potential on oral corticosteroids as well as exacerbations. Lung functions are definitely much more improved with benralizumab, and overall response in highly eosinophilic patients is perhaps better with benralizumab. Otherwise, Mepo and Benrali are the same. And of course, O'Malley has been primarily tried to show reduction in exacerbations, some reduction in oral corticosteroids, some improvement in lung functions, but not as spectacular as you get it with anti-IL-5 drugs. But the comorbidity will determine which biologic to use. And as I told you, in urticaria, omalizumab. In sinusitis with nasal polyposis, omali versus mepo. And of course, oral steroid dependence pushes everything towards benralizumab. Are they safe to us also? These are the two papers which we have published on omalizumab as well as on benralizumab. On MEPO, the paper is under publication at the moment, but it does indicate one thing: all of are safe and effective, even in Indian population. So how do we choose them? This picture has changed over the new data which has come in. You can see that omalizumab, particularly people who have childhood onset asthma, IgE level less than 700, FeNO level of more than 20. Associated comorbidities: allergic rhinitis, chronic idiopathic urticaria, food allergy, particularly peanut allergy, and chronic rhinosinusitis with nasal polyposis. You choose mepolizumab when the onset of asthma is little late or adult latehood. It is overlap phenotype in which even IgE may be high, but eosinophils also are high. And they are associated with comorbidities which are associated with eosinophils, which are chronic sinusitis with nasal polyposis, EGPA, and HES. You choose benralizumab, particularly in adult and late onset asthma, when they are oral corticosteroid dependent, which is with the dose of about 10 milligram of prednisolone per day. So to get 10 milligram per day to zero, my choice would be always a benralizumab. And if the comorbidities are like nasal polyposis, airway mucus impaction, bronchiolitis, signs on HRCT, then already the data is to suggest benralizumab does much better in them. Can we achieve anything better than that? And this is, I think, the slide you have to take home today. That we are talking about remission now. Can there be a day when we can tell our patient that yes, you will be living an asthma life without asthma, which we have been always telling the patients that it's not possible. Our rheumatologist colleagues have already declared to their rheumatoid arthritis patients that you are in clinical remission, you are without treatment, your rheumatoid factor will be positive, your anti-CCCP will be positive, but years and years after your treatment with rituximab, you are in complete clinical remission and live normally. Can we tell that to our asthma patients? That your bronchodilator reversibility will remain, your tendency to show that asthmatic response of the airways will remain the same, but you won't need any treatment. You will be considered as in clinical remission. The data has come from the mepolizumab trials, which shows that if a patient is exacerbation free, OCS use free, and the patient is having a very good symptom control over 1 year after the therapy, you call it clinical remission on treatment. But what we have to achieve is clinical remission without treatment. And that data has come with benralizumab in Shamal study, which has been produced in the ERS it's in this year only, which shows that 63% of patients after 1 year of benralizumab who were severe asthmatics, at 1 year, the only treatment they needed is AIR, which Dr. Sarkar showed, is for step 1 and step 2 asthma. Anti-inflammatory inhaler on an SOS basis. That's the kind of response if you are able to maintain without benralizumab after 3 years or 5 years will be something which we are looking for the patients of asthma. I do not know how much it will go without biologicals, but we have achieved it on biologicals. At least we have produced these patients who were on step 5 to somewhere in step 1 and step 2 within 1 year of using biologics, because the cytokines and the cells have been taken care of. There are many other factors. This is the last slide, that how we choose biologicals. And this is very beautifully dealt with in similar circumstances in the rest of the world. These are called practical considerations. I showed you those comorbidities, this, that, everything, data, which is stronger, which is not stronger. But at the end of the day, the guidelines do matter. If I have to actually venture out to use a drug in a non-guideline based treatment, I'll definitely see and think second time about it. Availability. I might be having a patient of very bad atopic dermatitis, but I don't have a dupilumab to use it. And if I think that anti-IL-5s will work, they don't. So it will be a wastage. So we really need to look that those which have been shown to have effect, if not available, no point in using it. Cost is very important. Whether your health insurance covers it or not is very important. Some of them cover only omalizumab, some of them cover all three of them available to us, and some of them do not cover actually benralizumab. So you need to look into it. And of course, a lot of administration factors. As we said that twice a month versus once in 2 months makes a lot of difference to the patient. And finally, keep in mind predictors of response, because failures on biological therapies are not easy for the patients to digest, because they have spent the money and they have spent the time and they have invested in you and your choices and your advices. So they better be correct on the first time, second time, every time. Thank you very much.
Excellent.
And this is the last news for COPD and biologicals. Till now, all biologicals failed. But this is the data from ATS this year. So in the month of May this year, dupilumab is the one which actually met in those COPD patients with eosinophilia count of 300 and above by meeting both the primary endpoints and all the 12 endpoints which are the secondary endpoints. If they replicate this in the second trial, which is on the way and perhaps will be introduced in the early part of the next year, it will be the drug which will be approved for first biological for COPD. And if that happens, I think everybody will go back and pat Angira as well as Parthasarthi that it is the treatable trait which is going to matter now, and not the COPD, not the asthma. It is the eosinophil which will be the driver, and it will be the driver for us to target the treatment and give the appropriate treatment to our patients. Thank you very much.
Thank you. I would request all the speakers to come to the podium for few questions answer session, and I'll invite questions from the audience as well. So we have limited time, so I'll go quickly all the four speakers one after another. For Dr. Professor Sarkar, just your topic was where do you stand asthma? Just my question is, many a times people are asking, is asthma curable at this stage? And what is your opinion whether asthma can be cured or not?
So till now, I always used to say that it's a lifelong disease. You might have remission for some time and you might be actually, but ultimately it will not go away. But the data which particularly is coming up now, I think that it won't be far away when we will be chasing this, what we call as cure. But still, I will say that it will take another decade to reach there to talk about it and make a
Yeah,
good comment about
and
it.
Dr. Sarkar rightly pointed out that many times asthma, when they get better, they stop using, medicine. So my way of telling them that it's just you are wearing specs. Do you think that you are looking very good? Can you take your specs out? Because immediately you will realize that you won't see or you will be blurred. Similarly, asthma is like that. Your inhaler probably need to continue for a long time. And many a times we need to check our eyes, even with specs, whether the power is going down or up or not. Similarly, the asthma, medicines might go down or up, or that's the way I'm doing. But it's just a sharing with everyone. Because it's many a times I find that they stop using because, sir, আমি তো ভালো আছি. Why should I bother using that?
I respond to this like that. The asthma is like diabetes, hypertension. And some cases there may be cure. We can achieve cure, but most of the cases you have to continue your inhaler therapy, and thereby you can live normal life. That is the most important. And we are giving there is a social stigma, so we are giving inhaler twice in the morning and night. So you can use spacer, and you have not to carry it along with you. So there is no, and now gradually the social stigma regarding this inhaler therapy, and patients are now accepting inhaler therapy.
Yeah.
Well,
Just
but repeatedly we have to teach them about the technique of inhaler, and then patient will accept it.
yeah, that's okay. No, question is sometimes they might ask, I'm doing fine for last 10 years. I didn't have any acute exacerbation and I'm just using once a day and I'm doing fine. Do you think that at that point of time one can try just stopping medicine and see how it goes? And what are the criteria? Is there any criteria or is just your intuition that, oh, fine, you can stop it?
Now there is the first thing we have to achieve control. And after achieving control, if you can
So that
maintain it
has been done.
three to six, then we have to step down. And it should be a gradual process. And in the step 1 and step 2, as required ICS formatrol is already in the guideline. So we can have this as needed ICS formatrol. When patient is well controlled and the symptoms are less than twice in a week, then we can have this guideline that we can give the ICS formatrol as needed basis.
Yes.
Sir, sir has mentioned it absolutely correctly that even ERS tells us that 3 to 6 months of stable disease we can consider a step down. But what we tend to forget in our country, which we often see in our practice, is there are multiple seasons in a year. And most often our asthmatics who are on the lowest possible dose tend to exacerbate in another season. So hypothetically, if my patient is an exacerbate in the winters, he's coming to me in the summers asymptomatic, and he fits the 3 month window period and I stop his inhalers, he's going to come with a far worse exacerbation in the winter month. So
Yeah.
I personally would want a 12-month period of stable symptoms without escalation of any treatment before I would tell him to be off the inhaler and be only on SOS use.
I think that's a very good point, actually. You have to ask the patient which is the worst part of the year when you have the attacks. And if that passes peacefully with whatever medication, that is the effective medication. If we use it for even biologics. Sometimes they come back after 3 months and tell me, I'm doing so good, I am absolutely all right. Which was your worst month? October. It has not yet come. Let it come, then we'll see.
There are risk factors I have also already mentioned in
Yeah.
the slides,
Yeah.
and those risk factors should be important. And when these risk factors are present, then
Very
we cannot
important.
stop.
Yeah.
I think
Just
Gina has not
coming to
highlighted that
neutrophilic
issue,
asthma.
highlighted very significantly. We forget that point actually. His slide was so beautifully showing all those risk factors which you cannot go on AIR SOS. These are the ones FEV1 less than 60%, pregnant ladies. They are talking about previous hospitalization, previous ICU admission, previous being on ventilator, patients who are smokers. I think that list has to be in our mind before deciding that this patient should go on AIR, SOS, that is step 1, step 2 treatment, or this patient should be counseled that you can actually get worse if you go into those stages. But I think Gina is very cleverly trying to. I think you were correct when you said that there are lots of other things,
Yeah.
200 countries. But the issue is when they talk about track 1 and track 2, they do talk about it that don't choose track 1 if you have all these risk factors which you have spoken about. But then they do not talk about in the rest of the text at all, because they have to cater to 200 countries. They have to cater to maybe millions of practitioners, which are GPs primarily. For them, the message should be at least give something to
Give
them.
something.
But for us, that message is not there.
Exactly. That, guideline is like that. It's not for the expert. It's for the general physicians here, mostly. I'm coming to the neutrophilic asthma. You have said everything about neutrophilic and have covered that treatment is very limited. But one area, do you think that is there any role of bronchial thermoplasty in?
Okay, so when we choose or select a treatment for a patient who requires one of the high-end treatments, The most important thing to do is to do a correct and accurate endotyping. So, fundamentally, there can be three components of airway diseases. One is the airflow obstruction, which we detect by spirometry. The second is airway inflammation, which we do a sputum quantitative assay. And the third is bronchial hyperresponsiveness. So, patients who have controlled airflow obstruction or minimal mild airflow obstruction, controlled airway inflammation, so which means that the triggers of the disease have been taken care of, and what remains is the twitchiness of the airways. So if that is the phenotype of the patient we are looking at, this is the patient which requires bronchial thermoplasty, or maybe one of the the biologics, the TN-alpha, which takes care of only the twitchiness and not anything to do with the airway inflammation.
Yeah.
Can you add something?
Yeah.
Okay. So the problem with the bronchial thermoplasty trials are they were all done in 2005 to 2011. There was no concept of phenotyping. There was no concept of endotyping. Only biological which was available at that point of time was omalizumab, and they did not look into the phenotypes at all. So that's the problem that even today, after so many years of it being available, they could not pinpoint which are the ideal candidates for bronchial thermoplasty. And any patient who walks in with severe asthma and gets a bronchial thermoplasty done, then obviously it will be
Failure.
backstabbing and it will be like total failure. So till now, it was not done. And if the company would have persisted and company would have done a good clinical trial on that, maybe they would have come up with an answer that whether posigranulocytic or a neutrophil or a failed eosinophilic, which is the right candidate for that. They never did that actually. So that's the biggest challenge with the bronchial thermoplasty.
So this is one area one can, research that it's a
But
group.
it's very expensive.
Very expensive and nobody is interested in anymore because BT has been withdrawn already.
Okay. So coming to biologics, yeah.
On achieving the clinical remission of asthma by biologics and maintenance of that clinical remission by allergen specific immunotherapy where applicable.
Okay, so I think this is a very good solution that you achieve the remission with biologics and maintain it with the AIT, right? That's what you are saying. So if it's really an atopic or an overlap group, you might actually do it and it would be much cheaper actually, right? So many autoimmune diseases, we maintain the remission by giving once in 6 months rituximab, sometimes now going to once in a year rituximab. So if I have to give benralizumab once in a year to the patient, even that will be very good, but it will be very expensive. AIT would be very good. So those patients on, and that is why I showed you that in omalizumab, adding omalizumab to a patient on AIT and then continuing AIT and stopping the omalizumab is one of the very, very, I would say that cheaper option for maintaining that kind of a remission. Very, very, very beautiful question, I suppose. But this also needs to be worked up into our daily practice to see how it works. But yes, this is perfectly possible and plausible.
So I would like to ask
Yeah.
Deepak one question, and that's what are the unanswered questions in biologics now?
So I think there are so many cytokines in cascade that targeting one invariably leaves room for others to play a little more. And unless and until you stop the cascade completely, you cannot say that this is going to completely take care of everything.
So your anti-TSLP is on that.
TSLP would be one of the, I think, the biggest game changer which we think it is going to be, because you are blocking on the top of it, and then of course, but then see this molecule has to stand the test of the time, because at the moment it is still just approved in US. EMA approval is still awaited, and we are looking for it at the end of next year to get it in India.
So
Yes,
when
Shushmita, I knew that.
Deepak, yeah, you have.
Spoke about dupilumab looks like one glove fits everything as time comes. But what about ipecaculimab in COPD? There's a lot of trials going on right now in India with it.
What, dupilumab?
No, ipecaculimab.
Yeah, ipitukimab. Yes. which is a IL-33 inhibitor,
Yes.
isn't it?
Yes.
Yes, I think this is the promising molecule for COPD, those who are non-eosinophilic actually. So this is again one of the molecule. So I think Sushmita, maybe 5 years down the line, there will be 2 to 3 biologics for treat COPD also.
Basically, it'll be biologics from one end of the spectrum to the other.
Absolutely,
Right.
absolutely.
I just wonder who's going to be able to afford it.
I think if the biosimilars finally come, I didn't discuss that with everybody, but biosimilars is the way forward. Even USA is not able to afford this.
Yeah.
So the moment patents go, biosimilars will be there. Now, if the biosimilars are actually brought at a lower cost, then things are going to completely revolutionize it. And not only our specialty, I think in every specialty. Because if you look at the rheumatologist, how much of biosimilars they are using? Look at our bone specialist, how much of the biosimilar they are using. Why won't we be, actually?
Medicine is changing its pendulum from, uh, the guideline medicine to personalized medicine to precision medicine. And this is the, biologics which is going, or monoclonal antibody is going towards the precision medicine. And it's from cancer to sepsis to your asthma, COPD, everywhere. I think future is there.
Yeah.
And
So
we
I
are,
want to make one point clear here is that many of us think biosimilars are similar to biologics, but they are not biologics, and it has been generated like that. That's wrong, actually. Biosimilars are biologicals, but made by non-patented firm. So if Novartis is not making omalizumab and somebody else is making, that is actually a biosimilar. So it is like formoterol budesonide. If it is not being made by AstraZeneca and it is made by Cipla, it's actually the same equation here. So if both of them work, the biosimilars will also work. There is no doubt about it. Many people think it is a similar to biologic, but it is not biologic because the name is biosimilar. No, the biosimilar name has been given only because of the patent. The moment the patent goes, you can make that. It will be exactly same, but since it is not going to come from that company, you have to give a different name. So that's the biosimilar name given.
just one last questions to both Dr. Dasgupta and Dr. Talwar. Neutrophilic asthma, we all know that biologics has got limited role, or perhaps we don't use right now. But the granulocyte macrophage colony stimulating factor, it's a factor which is controlling neutrophil. It's mobilization, activations, everything. So can we use inhibitor? It's available, that inhibitor. Can we use that for controlling neutrophilic asthma?
And the problem with neutrophilic asthma is that neutrophils function is very important in the body because they are the, like I said, they are the firefighters whom you cannot take away when the system is on fire. So when we use an anti-neutrophil antibody, we have to understand when these neutrophils are working. Now, one way this can be done is that if we do a sputum analysis and we find that there are cells, but there are no symptoms of the patient, it means that the cells are just sitting there inactive and not doing anything. One example was cited by Dr. Talwar a minute ago, saying that there were eosinophils in the airways, but it does not mean that those eosinophils are functional. So if you see granulocytes, the granules of the eosinophil being present in the sputum sample, it means that the things are activated. Similarly to neutrophils, unless they're activated, it makes no sense. So if we give an inhibitor to any of the components of a neutrophil, that whether that is going to work or not is again depending on if the cell is activated or not.
A chunk of status asthmaticus in elderly or adult belongs to neutrophilic asthma, and you
But
cannot
we
use them
test.
steroid because they are already been on steroid for long duration. And as you have mentioned, that steroid user is one of the precipitating factor for neutrophilic asthma.
And so we're
In
not
that
treating those.
group of patients, so you have no other options because you have to treat that patient. So what is your
If
opinion?
it's symptomatic, it's different. If it's asymptomatic, it's
No,
different.
it's symptomatic one.
So in this particular clinical situation, it's symptomatic. So if it's symptomatic, we give antibiotics, and if neutrophilic, of course. And then again, there are several questions that we have answered before. If it's a recurrent neutrophilic, you could use a long-term antibiotic. You can use it for a few months, like we do for bronchiectasis. So yeah.
But look at GINA 23, politically correct, type 2 low asthma, two choices given. If the patient is on maintenance oral corticosteroids, use dupilumab. And if the patient is not on OCS maintenance but T2 low, use tezepelumab. On one hand, they are not talking about so many things, but they were too happy to jump into the bandwagon in 23 itself when the data was yet coming in for both the molecules that they have been brought already as a choice for non-type 2 asthma. But anyways, I think the bottom line is signal is coming up that these two molecules may work in type 2 low asthma also.
Thank you. Is there any question from the floor? Otherwise, we are already late by 15 minutes. So, oh, just Partha, is there one question for you? Because you have classified one thing, but I was just wondering what is the difference between ACO and this unclassified? Because that group, I was thinking that there are.
I got your question. It's a very difficult question. I looked at ACO seriously. There are 16 definitions and it's utter confusions. So I think we shouldn't talk about ECHO, rather go for unclassified quote unquote and try your own style.
Thank you. And if there is no question, then I'm going to
I
finish.
have one thing to tell. Okay, sir.
Yes, yes.
The neutrophilic and paucicellular asthma is recent coming and it is not yet digested by us. But I think I should conclude this remark is that lifestyle modification and avoidance of the things and the inhaler technique is very important for the management of asthma.
Thank you, all the speakers and also the audience for patient sharing. Thank you very much.
On behalf of Pulmocon 2023, it is my pleasure to welcome all the respected delegates and dignitaries to the inauguration ceremony of our conference. I would like to hand over this to Dr. Abhishek Kaur sir for further proceedings of the ceremony. Thank you.
So, dear esteemed guests, on behalf of the organizing committee, it is my great privilege to extend a warm and enthusiastic welcome to each and every one of you at Pulmocon 2023. As the secretary of this prestigious event, I am deeply honored to witness the coming together of the brightest minds in the field of pulmonary medicine. Your presence here today reflects your dedication in the advancement of the field, and thank you for joining us at Pulmocon. So now we will start together the inauguration ceremony. For that, I will invite the guests to the stage. First of all, I would like to welcome Dr. Arunalok Chakrabarty, sir. So please come to the stage and have your seat. And I would request our PhD fellow, Ms. Devkonna De, to please welcome sir with a bouquet. Next, I would like to welcome Dr. Samiran Panda, sir. And I would like to ask Ms. Shayanti to please welcome sir with a flower bouquet. Next, I would like to welcome Dr. Deepak Talwar, sir, to the stage, sir. Please come. and have your seat, sir. And I will like to request Miss Srijita to please welcome sir with a flower bouquet. Next, I would like to welcome Dr. ML Gupta, sir. So please come to the stage. And I would like to ask Miss Shayani to please welcome sir with a flower bouquet. Next, I would like to welcome our organizing president, Dr. Thiman Ganguly, sir, to please come to the stage and have your seat, sir. And I would ask Miss Srijita to please welcome sir with a flower bouquet. And last but not the least, I would ask Dr. Parthasarthi Bhattacharya, sir, please come and have his seat. And I would like to ask Miss Shayanti to please welcome sir with a flower bouquet. So at the outset, I would like to ask all our guests to please proceed in front of the stage for igniting the lamp and formally announce the inauguration of the conference. Uh, so, as part of the inauguration ceremony, we have one oration today. And for that, we have Dr. Arunalok Chakraborty sir among us. Dr. Arunalok Chakraborty sir started his medical career from Calcutta Medical College and went on to pursue his postgraduate degree in microbiology from PGIMER Chandigarh. He joined the faculty there and became a full-time professor since 2005, and he is currently the director of Dudhpari Barfani Hospital and Research Center in Haridwar. His sustained efforts at diagnostic and research excellency in fungal infections made his laboratory at PGIMER known as one of the best diagnostic mycology centers in Southeast Asia, recognized as Center of Advanced Research in Medical Mycology and National Reference Lab in Medical Mycology. WHO has recognized a center as WHO Collaborating Center for Reference and Research on Fungi of Medical Importance. He also initiated the National Culture Collection of Pathogenic Fungi and Nodal Center for Antifungal Resistance Surveillance in India. In a career involving 41 years of research experience, he has extensively contributed in broadening our horizon of knowledge in the field of fungal diseases. Under his able guidance, Many budding scientists and researchers have completed their thesis. To his credit, he has published 56 postgraduate and PhD theses till date. He has published 487 papers in the field of medical mycology in international and national journals and delivered over 100 medical conferences and societies lectures. He is the editor of two books, namely Fungal Infections in Asia and Clinical Practice of Medical Mycology in Asia. Three recently discovered fungi were even named after him, honoring his contribution to medical mycology. His leadership also extends to national and international mycology societies. He is the past president of International Society for Human and Animal Mycology, chair of Asian Fungal Network under International Society for Human and Animal Mycology, and chair of Fungal Infections Study Forum, and has been a member of WHO's expert group on priority fungal pathogens since 2020. International Society of Human and Animal Mycology has even recognized him as global opinion leader in the field of medical mycology. He is the editor of a renowned journal, Medical Mycology, and also in editorial posts in various other journals of repute. For capacity building in the field of fungal infections, he has conducted 24 national training courses on diagnostic medical mycology, conventional and molecular techniques over last 11 years as chief resource person. He received multiple awards from national societies and academies of India. To name a few are, he received the recently Haripada Kundarani Memorial Award for Lifetime Excellency in Professional Service from Medical College, Kolkata. He has also been honored by American Society for Microbiology by the ASM Moselio Schechter Award for exemplary leadership and commitment towards the substantial furthering the microbiology profession in research, education and technology in the developing world. We are very happy and honored to have you among us, sir. And now I would like to request Dr. Dhiman Ganguly, sir, to please felicitate Dr. Arunalok Chakraborty, sir. We have another distinguished person among us today, Dr. Samiran Panda, sir. He is Dr. A.S. Painter, Distinguished Scientist Chair of Indian Council of Medical Research, and he is also currently the Editor-in-Chief of Indian Journal of Medical Research. Dr. Panda's journey in the world of medical research started in 1991 when he joined the National Institute of Cholera and Enteric Diseases in Kolkata. It is one of the 27 institutes spread across under India under the umbrella of ICMR. Dr. Panda is an alumnus of the Calcutta National Medical College School of Tropical Medicine, Christian Medical College, Vellore, and University of California, Los Angeles, and carries with him a rich experience of research, evaluation, and intervention development. He worked as a short-term consultant for the WHO in delivery of antiretroviral therapy for people who inject drugs and their partners in resource-poor settings. Furthermore, he played a key role in supporting bilateral and multilateral development partners in designing and implementing evidence-based interventions with active involvement of key population groups in countries like Bangladesh, Myanmar, Nepal, and China. A recipient of the ICMR Award in 1995 for commendable research in the field of communicable diseases, Dr. Samiran Panda was awarded Fogarty International Fellowship for the period of 95 to 96. He was elected as a Fellow of the West Bengal Academy of Science and Technology in the year 2020. He has published several seminal journal articles and book chapters. And presently, he is serving as the editor-in-chief of the Indian Journal of Medical Research and mentoring young researchers and pursuing the completion and writing up of results of the research projects he is involved in. We are happy to have you amongst us, sir. I welcome you to take. I ask Dr. Parthasarthi Bhattacharya sir to please felicitate Dr. Samiran Panda sir. Dr. Samiran Panda sir will give the APC Roy Oration Award, which will be held tomorrow. Next, coming to the next distinguished faculty we have among us, Dr. Deepak Talwar sir, a renowned figure in the field of pulmonology in the whole country, and he is among the first batch of DM pulmonary medicine in the country. He established the Metro Center for Respiratory Diseases in Noida, which is the advanced respiratory setup in India, and he also runs a successful DNB course there. He is an astute clinician, a wonderful organizer, a great team leader, and a very respected teacher. He has many awards, honors, and fellowship awards under his name in his 30 years of medical experience. He has over 100 publications in various national and international journals and is a renowned faculty and a very sought after faculty, I would rather say, in all of the conferences held across India. I would now request Dr. Dhiman Ganguly sir to please felicitate Dr. Deepak Talwar sir. Next we have Dr. Manohar Lal Gupta sir. Dr. M.L. Gupta sir is a retired professor and head of the Department of Respiratory Medicine of SMS Medical College, Jaipur. He has extensive experience in home and abroad in different facets of pulmonary medicine. He has been a very successful and highly revered teacher and has mentored many successful pulmonologists of the country. He has several awards to his credit and authored multiple books and chapters in various textbooks. He has over 100 publications to his credit and is an eminent faculty of many national conferences and member of several national and international professional societies. Presently, he is heading the Department of Pulmonary and Sleep Medicine at Santokpa Durlabji Memorial Hospital, Jaipur, and runs a very successful DNB course there. I would request Dr. Parthasarthi Bhattacharya sir to please felicitate Dr. M.L. Gupta sir. Now I would request our honorable guests to please inaugurate the souvenir for Pulmocon 2023. The Institute of Pulmocare and Research, born in the year 2000 with the motto of research, education, and patient care. In the last 23 years of its existence, we have marked our activity in all fields. Multiple research projects have been completed, numerous research publications in various journals of repute. We have done a few patent applications and a few innovations in the field of science and technology have our name in it. In education front, we have done regular scientific meetings, classes and courses, both certificate and diploma courses. Few of our courses have been affiliated to the Netaji Subhas Open University, West Bengal. This year, 2 of our students will get the certificate for completing the course. So, certificate আছে তো? I would like to request Dr. Arunalok Chakrabarti sir to please give the certificate of completion for to Miss Dia Shingoroy for certificate course for community respiratory care assistance. Next, we have another candidate, Mr. Akash Ghosh. May I request Dr. Samiran Panda sir to please hand him the certificate. His certificate is completed the certificate course for assisting respiratory specialist in clinical practice. Now I would request Dr. Arunalok Chakraborty sir to come and please say a few words of encouragement to us.
Dignitaries on the dais and dignitaries in front of me. Good morning, everyone. It's an honor for me to come again to my hometown, Calcutta. I always love whenever I come here. Only thing is that in case of this pulmonary medicine, I feel that my own interest area is the fungal infection area, where there should be much more development which is expected, but somehow I could not find much development coming up in this city. Hopefully, Dr. Partha Bhattacharya would do something, because I can say that in case of pulmonary medicine, one of the big important study which have been conducted at our institute on the area of allergic bronchopulmonary aspergillosis. I was expecting at least what is the magnitude of the problem in Calcutta should be known to us. And that way I requested Dr. Bhattacharya to conduct such type of studies which would really help us to know about in Calcutta. But whatever it is, this is my own area where I was trying to have something from him or from this Pulmocare Institute to have a leadership in case of this area. I know that the other area in asthma and other field, they have done excellent work. I congratulate him and his team for doing such important work. With this, I like to again congratulate for holding this meeting and bringing every year. I have heard that this meeting is happened where the people in the field of pulmonary disease, they have the chance of interaction. With this, I like to thank you for again bringing me here. Thank you very much.
Thank you, sir. We will definitely try to accommodate all the ideas that you have given us for further research. Next, I would like to welcome Dr. Samiran Panda, sir. Please come and please share a few words of insight with us.
Good morning and good afternoon. The most interesting thing is that I've been asked to say a few words, which is very reassuring for me, because I remember something which was told by Mark Twain. The human brain starts functioning the moment you are born and never stops until you stand to speak in the public. So and it happens with me all the time. I don't know why. I always wondered about people who do not go through that symptom, but I do. Every time I'm asked, to speak a few words or a 20 minutes or 30 minutes lecture, it's the same all the time. And that's why I thank you first to say a few words. Thanks also to the organizing secretaries, Dr. Partha Bhattacharya, who actually invited me, actually made a phone call first and saying that, we want to felicitate you by conferring an award on you. And then I thought, okay, so why are they selecting me? The onus is on them. I need not to justify. Because over the last 3 years or so, I'm sure all of you have seen, a few people amongst whom I was there who are full of uncertainties rather than certainty. We were facing a pandemic. We all assumed that the existing knowledge with us would help us, and that was not to be. So the incremental accumulation of knowledge which was there with us, it did not help us. But what helped us is our attitude to generate knowledge through a process which was not very easy all the time. The 21st All India Update in Pulmonary Medicine, organized and which is happening now under the title Pulmocon 2023. I really thank you for inviting me so that I could come and listen to a few presentations this morning, and also to meet people whom I know, some of you, not all of you. And always it's a pleasure to interact with people, because the more we interact, we realize that the knowledge that we have, that's so limited. Because somebody said that with knowing, with having more knowledge, we also become very aware about what is unknown. So it's a never-ending process. But in order to be in this whole exercise of efforts towards knowing, it's essential for us to interact, to share our knowledge, and also to share our ignorance, that this much we know and this much we don't know. Thanks a lot for this excellent event which has been organized. And I could see that the young minds are there, and young workers, researchers, doctors, healthcare workers from different backgrounds. I have all my best wishes for the young ones, and I hope that this will go on for number of years, by which at least we can contribute something to the incremental accumulation of knowledge. Thanks a lot.
Thank you, sir. Now I would like to call upon Dr. Deepak Talwar, sir, to say a few words.
Thank you, everyone. And I'm at complete loss of words, actually. So I do not know what to say. But I will just tell you how I met Parthasarathi, because I left PGI, I think, after my DM in 91. Me and Randeep were there, so I was the one who left. And I think I was almost in oblivion, because at that point of time, respiratory medicine was having a very tough time. And when I came back, that was about, I think, 98 or 99, I went back to Dr. Jindal and said that, sir, if you are not in PGI, if you are not in AIMS, what do you do? Because you have been taught and trained to be an educator, a researcher, and of course a person who is being looked at as an epitome of knowledge. How to happen? There's no opportunity. What can I do? He said, what do you plan to do? I said, I have nothing but a private place to work. So he said, you can create a similar kind of thing there itself. I said, that's impossible. Think of it. Before 2000, before the turn of this century, was there any opportunity in the private to work as an educator, researcher, and being a teacher? There was nothing. So I started my crusade, and then what Dr. Jindal came and Dr. Behra came and told me, look at this young boy who has just left PGI and gone to Calcutta, how much of work he's doing and the research he's doing. I said, sir, I do not know who is he. He said, you must meet him. I said, okay, then the next annual PGI meet, I will definitely make it a point to come and meet him, and I met him there. And when I heard him, he floored not only me and Randeep, but everybody else around, that you can still work wherever you are, whichever capacity you are. And education and research is not the responsibility of government institutes. It is a responsibility of each and every one of us. And I'm very happy that he was able to not only enthuse me, inspire me to bring my department to this level, where I could have never ever thought about it and nobody ever even imagined about it. Thank you. Thank you for my inspiration, Partho, and continue to inspire the young generation on a similar platform with a similar kind of exposure giving to them and actually enthusing them to not only be a practitioner but must be a practitioner with an educator and a researcher. Thank you.
Thank you, sir, for sharing your experience in this field. And next, I would like to invite Dr. M.L. Gupta, sir, to please share a few words of insight with us.
Dignitaries on the dais, and good afternoon to all of you. And I'm thankful to Dr. Partho, his energetic team, for inviting me for this event. I've been coming to this Pulmocon for many years. Sometime due to some or other reason I may miss, but I have attended most of the meets in last 7-10 years. And I have found his meets or his events different from other meets. First thing is the simplicity of the program that I very much like. Second, the content of the event are very, very rich. In most of the big conferences you go, at the end of the day you find nothing. But here, every time I comes, I learns one or other things. Third is the integration, which our most of the conferences are not doing. Last time I saw one electric engineer from some regional IIT was there delivering his talk. Other time there was some person from Baba Atomic Energy. I don't remember the name. If you see the most of the techniques which we are using in the medical practice, they are invented by the engineering side. And in most of the conferences, probably we ignore them. We do not take the cooperation of them. And probably his integration of those subgroup of the scientists which are our backbone. That is a very innovative thing which I have not seen any other things. In last just I wish Dr. Partho and his team a great success, great height in the coming future. And again I thanks the organization, Dr. Partho, for inviting me. Thank you.
Thank you, sir. Next, I would like to invite Dr. Dhiman Ganguly, sir. It's always a treat to hear him, and so I request him to say a few words.
Good afternoon, friends and colleagues. If a program is running for 21 years continuously, it denotes two things. Firstly, there is a demand for this kind of program among physicians and PG students. And secondly, Institute of Pulmocare has been blessed by the support and enthusiasm both of the audience who come here every year to listen to this program and to distinguished faculty that we invite every year. And we have never, I hardly remember anybody saying no to our invitation. You see, they usually come whenever they are invited. So it's a wonderful achievement both for the Institute of Pulmocare and for the audience and the faculty. And I hope, like other years, this year also we will have a very successful academic program, and the audience who spend all the time here over the weekend will have their money's worth from the academic program. And I would like to have a personal comment about Dr. Panda, who said that Mark Twain said that as soon as you start speaking, your brain stops functioning. There is something very similar Rabindranath wrote. তোদের এত কি বলিবার আছে ভেবে অবাক হই. I wonder how you have so much to say, you see, under circumstances where there is very little to say. A little while ago we were listening to a series of talks on mechanics of breathing in asthma and molecular biology of asthma. You see, it reminds me of economics. People get Nobel Prizes every year researching on poverty. The poverty remains where it was. In fact, it's worse than what it was 50 years ago. But they keep winning Nobel Prizes by researching. I can give you two examples right now in research in pulmonology. Activated protein C. It came up in the horizon, illuminated the whole horizon for a few years, and then disappears permanently. And the second one is bronchial thromboplasty. We heard so much about it. People wrote books, and it's disappeared. So things come and go. That's the idea of research, really. So I hope whatever has been said and done in this conference will stay for some time, at least, to entertain us temporarily. Thank you very much for listening to me, and I hope a grand success for Pulmocon 21. Thank you.
Thank you, sir, for your words of encouragement. Now we would have the Professor Dr. Esen De oration. Before the oration, I would like to yes, yes, sir. So before the oration, I would like to share a few in a story behind this oration. Let's first know who is Dr. Shambhunath De. Dr. Shambhunath De was born in Hooghly district, West Bengal, and after his preliminary studies and doing his graduation from Calcutta Medical College, he joined in 1947 as a PhD research scholar in the Department of Morbid Anatomy, University College Hospital Medical School, London. Obtained his PhD in pathology in 1949, and after his return to country, he worked on pathogenesis of cholera, then considered a pandemic disease, and started publishing his findings. In 1955, he became the head of pathology and bacteriology division of the Calcutta Medical College, which he continued until his retirement. Dr. De made significant contributions to our recent understanding of cholera and related diarrheal diseases, followed by discovery of Vibrio cholerae in 1884 by Robert Koch. Many works have been carried out all over the world to answer many questions related with its pathogenesis and mode of transmission in causing outbreaks. In 1959, Dr. Shambhunath De was the first to demonstrate that cholera bacteria secrete enterotoxin. This discovery eventually promoted research to find a treatment aimed directly at neutralizing the cholera enterotoxin. These famous findings of Dr. Shambhunath De came out from the work he carried out at the Neel Ratan Sarkar Medical College, Calcutta Medical College, and Bose Institute, Kolkata, in extreme modest laboratory settings. Using research methodology that was very simple, easy to perform, and inexpensive, he set the highest standards of excellency in novel experimental design and execution. The oral rehydration therapy that we use today for replenishing the massive fluid loss in cholera patients has saved innumerable lives, should be considered as a direct outcome of this discovery of cholera toxin. Post-retirement, in 1973, from Calcutta Medical College, he showed no interest in higher positions but continued his research at the Bose Institute, Calcutta. De's desire to purify the cholera toxin did not progress any further as the protein purification technology was not well established in his research settings. In 1978, the Nobel Foundation invited Dr. De to participate in the 43rd Nobel Symposium on Cholera and Related Diarrheas. Dr. De died on April 15, 1985 at the age of 70. His life's ambition was to make the world a better place to live in through his dedicated, selfless services in medical science. Nobel laureate Professor Joshua Lederberg had nominated Dr. Shambhunath Dey for the Nobel Prize more than once. Dr. Lederberg said, "Our appreciation of Dey must then extend beyond the humanitarian consequences of his discovery. He is also an exemplar and inspiration for a boldness of challenge to the established wisdom, a style of thought that should be more aggressively taught by example as well as precept." And yet, Dr. Dey was never elected a fellow of any Indian academy and never received any major award. Professor Padmanabhan Balram pointed out in an editorial in Current Science, Dey died in 1985 unhonored and unsung in India's scientific circles. Dr. Dey received no major award in India during his lifetime, and our academies did not see it fit to elect him to their fellowships, must rank as one of the most glaring omissions of the current time. Dey's heroic story of persistence, dedication, and achievement should serve as an inspiration to the many who are increasingly bewildered by the current fashion of mega projects surrounded by fanfare and publicity, and most often surprisingly little discernible scientific output. We wish to bring his name to light in his birth centenary and after 37 years of his passing away. So, we initiated a memorial oration in his name in our annual update from 2009 onwards. This year, Dr. Arunalok Chakraborty will deliver the oration in the name of Dr. Shambhunath Dey. Let the life and work of Dr. Shambhunath Dey inspire us and make us strive to bring glory and confidence to our efforts in healthcare and research. Now I invite Dr. Arunalok Chakraborty sir to please come and start the oration.
Thank you very much. Good afternoon, ladies and gentlemen. I would rather say my field choice in case of microbiology, it came from this particular person. I never knew. I was a student of Calcutta Medical College. It was Dr. H.K. Pal, who was the head of microbiology department. He said, "Do you know that there was a person called Dr. Shambhunath Dey?" I said, "Nobody has taught us in this aspect." And, he discussed with me. Then there is B.P. Chatterjee, who was the head at the tropical medicine. He showed that how Dr. Dey had developed that time in rabbit ileal loop for demonstrating this toxin in case of cholera. I would say that was one of the most important pathogenesis study in the field of medicine. Before that, a lot of people have tried to look into how cholera spreads, but he was one of the person who really showed the toxin, how it works. And it's a great honor. I thank Dr. Bhattacharya for giving me this opportunity, though his work is not in the field of pulmonary medicine, but bringing him in case of Calcutta into this glory. I wish we can work like him and develop certain important breakthrough in the field of any of our medicine where we don't know. I thought that I will take up a challenge in this particular oration is that pulmonary mycosis, which is a chameleon and difficult to diagnose. Friends, in case of pulmonary mycosis, it's really difficult because no specific symptoms and signs. Many of the disease from TB, from lung cancer, from bacterial pneumonia, many of them can mimic the same factor. But honestly, we are seeing there is an increase in number of these cases which are there, which we are not able to diagnose. And by the time we diagnose, that patient is already in a very difficult to survive. And most of the fungus which enters the body, they enters through the lung, except few in case of the gut. And if you see, there are host of numbers, endemic mycosis, opportunist mycosis. I'm not going to discuss each of them, but what I like to emphasize you on, like suppose if you see in case of histopathology, acute pyogenic reaction. Until unless you show the fungus, you will not able to say whether it is mycosis. It can be a bacterial pneumonia that is there. Similarly, if you see mixed suppurative and granulomatous disease, which can be just tuberculosis. We used to know at least the fungal infection used to occur in case of immunosuppressed host. Okay, then we start thinking, suppose a patient of hematologic malignancy undergoing chemotherapy, we'll start thinking whether there is presence of fungus there or not. But what we are seeing is that now several non-neutropenic hosts, whether patient staying in ICU for a long time, whether patient is uncontrolled diabetes, whether the patient is having got cirrhosis, they all are new agents which are coming into this field. And this problem comes into in case of diagnosis. You know, whenever we used to suspect fungal infection, we are taught that if you have got a halo sign, air crescent sign, start thinking it's a fungal infection. Because, you know, when it enters the lung and in a neutropenic host, it can enter the blood vessel and produce those particular signs which we see in case of radiology. But what will happen in case of non-neutropenic? Non-neutropenic, because they cannot enter the blood vessel, they will have only in case of bronchial or in case of alveoli. So that would having more non-specific symptoms like localized bronchiectasis, tree in bird appearance, ground glass opacities. So it's a real difficulty. Even what it has been seen in case of this classical group, 1/3 of the patient can have atypical images like micronodule or tree in bird. When we had this particular pandemic for last 2-3 years, there was a problem came as the COVID associated pulmonary aspergillosis. Just look into these two pictures. One is having aspergillosis, other is not having aspergillosis. Can you distinguish? There was the problem, so imaging is not helping us in case of diagnosis. But at the same time, since our study in case of fungal disease, it has said that you need early diagnosis and prompt therapy. And if you delay the therapy, mortality increases. So ultimately, if you cannot diagnose, what clinician will do? A patient who is not responding to antibacterial for 3 days, start antifungal. Because they like to sleep after starting the antifungal. But what it happened is that if you see, inappropriate antifungal therapy is nearly 50%. And antifungal, which is costly, toxic, have every problem in it, and we are starting this antifungal without any proper diagnosis. But when I did this meta-analysis, I found that diagnostic stewardship can minimize the cost, can help less antifungal consumption, mortality coming down, and length of stay also is coming down. So friends, let me try for some of the leads which can help you in case of diagnosis. First important thing I would say, think about fungus in your patient. That is the most important thing, otherwise you will not able to see it. Which patient group, when to suspect, can we improve the conventional diagnosis, which biomarker can help in diagnosis, any molecular technique or point of care test can help, and moreover, the problem in case of low middle income country, we have got less diagnosis. Take it this case, 57-year-old man, after liver transplant, he had a bout of CMV viremia. He had been managed this CMV viremia, and then he had come to this ID clinic. He is well, put on weight, and almost ready to go back to work. Physical examination, no abnormality detected. Just when he was leaving the room, he says, "Doctor, I have got little pain here, worse when I breathe in." So what do you do? You do the chest X-ray. Chest X-ray, nothing detected. But when you did the CT, you see there is something is there. And when BL sample had been collected, it yielded Aspergillus fumigatus. So friends, this concept, until unless you think about that CME really preclude for development of invasive aspergillosis. There are several studies which showed that compared to non-CMV or CMV, there is a big difference in case of invasive aspergillosis. Even in case of ICU, the same thing had been shown in this aspect. Another interesting example. This is a 29-year-old female AML patient underwent first course chemotherapy. She was on prophylactic fluconazole. On 7th day, she developed the fever. She had the onset of fever. And that time, when serum galactomannan had been looked into, it was shown to be 0.82 because patient was already on antibiotic, but still fever is not coming down. So started looking into the possibility of fungal infection. There was pleural thickening, so never thought of fungal disease. Peptides which have been started, then along with vancomycin added. On 12th day, ill-defined nodule had been seen in the right upper lobe. So because of that, and then galactomannan has gone 1.5, so voriconazole started. Sputum yielded Aspergillus teres, and serum galactomannan has further gone up. So in this patient, thought to be that there is some problem is there, but 19th day onwards, serum galactomannan started falling. So it was thought that at least patient is responding, but chest CT showed worsening of the right upper lobe. So the question is whether we are handling with a voriconazole resistant Aspergillus teres or is something else like mucormycosis which is not being treated with voriconazole, or is the patient with tuberculosis because it was in the right apex. Now, one astute clinician, I'm saying you, we never thought about it. He thought that can it be case of pulmonary inflammatory immune reconstitution syndrome. You know, this patient was treated 3 courses on 3 days with IV methylprednisolone, and the patient immediately responded. And ultimately, patient could be discharged with oral voriconazole. So this is again, I am saying you, suspicion is important, and that would be really help us in case of diagnosis. So when to suspect a fungal disease, one of course, if you have got a traditional risk group, other new risk group which had come up, non-resolving lung infiltrate, fever despite giving antibacterials, new cough, chest pain, hemoptysis, may have associated skin, bone or CNS inflammation. Sometimes you don't take this history. This history is very important if there is any travel in an endemic area. Look at, these are the cases of coccidiomycosis which have been diagnosed in India, confirmed and confidently. But if you see some of the cases diagnosed after 4 years of the patient having symptoms. One of the case 9 years, I don't know how the patient survived in spite of having this infection. The main problem is nobody has taken the history. The patient, all of them had gone to Arizona or Phoenix area, Las Vegas. And because of this, they have come with this cocci. So this is one important thing which you need to know. In case of the classical risk group, we know that in case of AML, where the incidence is much higher, and in case of the transplant group, solid organ transplant group, we have seen that especially in case of lung and heart transplant, we are seeing much more pulmonary aspergillosis. Allogenic stem cell transplant. When I tried to look into Indian data, I found that Indian data is the highest in case of infection compared to the rest of the world, and invasive aspergillosis is more common. Another issue is coming up. Earlier we used to use the fluconazole as the prophylaxis, but as with the increase in the mold infection, people started mold active prophylaxis. But mold active prophylaxis had brought into the picture of mucormycosis, aspergillosis, especially drug-resistant one, fusarium, scedosporium infection. There are several uncommon fungi which are now coming up. I know it is difficult to remember all the names of the fungi, but if you see this is in classical risk group, these are very high in number. So what about the non-classical risk group in case of ICU? When we tried to first look into what are the world literature, I found that there is a lot of variation, 0.2% to even 19%. So we conducted a study across our country in multi-center where we found that our incidence of pulmonary aspergillosis is much higher in case of ICU. And you see that, yes, we have more pulmonary aspergillosis, but then also mucormycosis in 1/4 of the patients. And if you see this 81% where lung is involved, and here Aspergillus flavus is equally involved to fumigators. And this is very important. You know, Aspergillus flavus is more resistant to amphotericin B. So you have to think about which drug to be given in this scenario. As already been discussed by Dr. Talwar has mentioned about the biologicals. Biologicals has also brought out another area where fungal infection coming up. Even these checkpoint inhibitors in case of malignancy, that is also bringing new fungal infection in this group. Cirrhosis, when we try to look into what is the meta-analysis or pooled analysis, pooled output, we found that pulmonary aspergillosis in 3% and 4% in those who are ICU treated. In case of COPD, we found it is from 1.2 to 4% infection which have been there. You know, in case of the ICU patient, earlier we used to have, yes, in case of neutropenic host, then we started getting in case of the patients who are having at least staying in ICU for a long time. But now we are seeing respiratory virus is being associated with this, especially two viruses. One is the influenza association, another is the COVID association, that is in case of pulmonary aspergillosis. What it happens, you know, with this respiratory virus, first when it attacks the macrophage, there are a lot of cytokine is produced. It is called cytokine storm, and because of this, inflammatory cells come there. And when this fungus come into this picture now, by that time already macrophage is damaged. And because of that, there is no inflammatory cells which is coming up because of the absence of interleukin surge, and fungus get the opportunity to enter in the blood vessel and causing the disease. So there is, till now, we don't have much data in India in both influenza and in case of COVID associated pulmonary aspergillosis. But what it had been shown in world literature, 10% of the ICU patient can have either influenza associated or COVID associated pulmonary aspergillosis. You heard last 2 years there was an outbreak happened of COVID associated mucormycosis. Now in this mucormycosis we have all diagnosed mainly the cases which have been in the nasal sinuses and going into the orbit. But what about lung? So we did a discussion. We planned with the pulmonologist that please let's see how we can diagnose. Yes, the picture was similar in that when it is having severe COVID, but certain things which can be main thing suspecting mucormycosis like thick wall cavity, reverse halo sign, mycotic aneurysm, bird nest sign. So these are the things the way we try to do. Now let's come to the diagnosis. Conventional diagnosis is important, but we say it's less sensitive and it is time consuming. But friends, I would say still conventional diagnosis is more important because you know this is the, if you can do a microscopy well, you can immediately diagnose it. But second thing is that it's a proof for fungal infection. Any fungus can be detected. And there are certain improvements which had come up. Especially I would say the pulmonologist, if we have got a pulmonologist in the hospital, they can diagnose this much better. Especially when we started doing the EVAS in PGI, so many cases. We never knew that there are cases of mediastinal fungal infection. There are now cases which we are diagnosing because of the EVAS. And also we can do, there is CT or ultrasound guided aspiration. One of the clinicians of Italy was discussing about it. I said, how can you do it? This is a patient who is thrombocytopenic. How will you put the needle there? He said, what is your problem? Give 2 infusion of the plasma with platelet and try to do it. And when we try to do in case of PGI, our diagnostic importance, our diagnostic sensitivity has improved by that same procedure. So till now, our conventional techniques are helping when there is symptoms. But that might be late. So we need to know when fungus is entering, that is biological infection. And that way, certainly the biomarkers are helpful. What are the biomarkers available? It is the galactomannan and beta-glucan, and of course PCR is coming up. But these are only helping ruling out instead of diagnosing it. So it is also important that where the high risk group, there it is being detected. But we are now trying to have, this is point of care test, that is lateral flow assay, which is helping in case of diagnosis, initial in case of crypto, now also in case of aspergillus and in case of histoplasmosis. There are certain improvement in case of molecular technique had come, but I would say that the future is cell-free DNA detection. I'm telling you, in case of immunosuppressed host, this particular study had shown very clearly which can first pick up. It had shown again the biomarker. That is the galactomannan, if it is being detected early, that would help in case of picking up. Now, galactomannan earlier, which is being tried with the ELISA technique, now we have also lateral flow assay, where even manoprotein can be detected, but you should be very careful about the false positivity of this biomarker test. Even if your patient has taken yogurt, lateral flow assay can, or this galactomannan assay can false positive. We have a very interesting case, a patient who was shown to be positive, but again, patient has no symptoms, there is nothing in the lung which could be, but galactomannan was high. When it had been analyzed, it was found that the patient had taken ice pop. Because of taking ice pop, galactomannan had given false positive result. So these are the two lateral flow assays which have been there. You can try either of them, and it had shown that it is compared to the galactomannan, this lateral flow assay is very good result. But of course, in case of neutropenic host, when it had been looked into, it is the galactomannan lateral flow assay is much better than the other procedure of manoprotein detection. So friends, if you see, these are the different sensitivity and specificity of all this procedure has been mentioned. Instead of going into this, I would say, yes, biomarker test is important. But when I ask, like suppose in Calcutta, in one of the institute, they said, we have started galactomannan. As you have said, I said, very good. You have started galactomannan. How many days you are doing? Once in a week. I said, once in a week, suppose if you are doing on Tuesday, and if the patient comes on Wednesday, he has to wait for 1 week for having the test. So what is your turnaround time? That would not be giving in your result in this sense. So what we tried to do, this is one of the algorithm which just recently published in expert review anti-infective therapy, where in your city, Dr. Todi is also with us in this particular paper. What we tried to say is the serum lateral flow assay might help in case of picking up. And of course, you can try if there is peripheral lesion, there is CT guided or ultrasound guided FNAC can help. This is one interesting paper. I'm not sure how much it is possible in all these centers who are handling in case of the hematologic malignancy. They try to see how early they can detect. So they have done a baseline CT, and baseline CT could pick up 5% of the cases. So this is one study which attracted me. I'm looking into if it is being tried in case of India. Now, as the diagnosis was difficult, you know that there is, in case of neutropenic host, there is a URTC MSD classification which have been there. And these have been upgraded now. And this has said that in case of proven group, this particular classification makes fungal infection proven, probable, and possible. And this is on the basis of the host, clinical factor, and mycological factor. And here what it had been found that even if you don't have the direct microscopy positive, but if you can extract the DNA and do the PCR, that can also help in diagnosis. Certain host factor had been added because T cell immunosuppressant, B cell immunosuppressant, these are becoming important. Even in case of the clinical feature, radiology, wedge-shaped, segmental or lobar constellation had been added, and aspergillus PCR is now included. And in case of the non-neutropenic host, in case of ICU, main thing is that if first you have to have aspergillus in the respiratory tract culture, then same signs and symptoms, host factor and imaging, which helps in case of diagnosis. In case of influenza-associated pulmonary aspergillosis, one important thing is that tracheobronchitis is more common. So if you can do a bronchoscopy, that would help you in case of picking up. Otherwise, galactomannan would help. When we were discussing about COVID-associated pulmonary aspergillosis, there was a big challenge because people were not collecting respiratory sample. They were all afraid that there would be a chance of getting COVID. Even in case of the pulmonary group internationally, they were not encouraging bronchoscopy that time. So, international society, we together started telling that can we do something non-bronchoscopic lavage sample by doing this? So this was the protocol which we developed. But later, when we met together as experts, we recommended that now enough is learned about COVID. We can take a protection. Only if you do bronchoscopy, you can possibly correctly diagnose these cases. So BL galactomannan has become important. So what is the practical approach in this scenario? First, if you have a positive galactomannan, then start antifungal, but repeat the galactomannan. You know, biomarker one test would not help you or would not confidently give you the diagnosis, or you do the bronchoscopy. If it is positive in case of non-bronchoscopic sample, it is better to try bronchoscopy to confirm it. And in case of the PCR or galactomannan, both are positive, then start the therapy. Other than aspergillus, there is also problem, as I have mentioned, that mucor, scerosporium, lematospora, all these things are coming up where we need a multidisciplinary approach for diagnosis. Now I am giving few examples. You know, need to aggressive diagnosis. This is one patient, a 55-year-old man, who was in our hospital in August 2016. Patient was having myelodysplastic syndrome and required frequent blood transfusion since February 2015. He had disseminated tuberculosis, and when he came to us, patient was already receiving isoniazid, rifampicin and ethambutol. CT thorax was being done. You see there is some shadow is there, and serum galactomannan came 3.48. So we are very confident this is a case of invasive aspergillosis, so voriconazole started. But there was no improvement till 10 days. Fever persisted. So question to us was, is it a resistant aspergillus infection, or is it a management difficulty, or some other fungal infection or bacterial infection? You know, as I mentioned, single biomarker test giving result, it's very difficult to say the diagnosis. You know, antifungal is expensive, toxic, problem in case of giving it. So it is at least in high risk group, 2 samples should be positive. So the question to us was, when the patient is not responding, have we diagnosed it properly? Is it a case of mucormycosis or aspergillosis? Yes, positive galactomannan is there. Sputum is showing aspergillus fumigatus, but again, is it a colonizing aspergillus fumigatus? At the same time, patient is diabetic, multiple transfusion had been done, and moreover, patient received already voriconazole 1 week. And voriconazole really helps in picking up mucormycosis cases. So for clinician diagnosis, ultimately we did the transbronchial biopsy and also CT guided biopsy, and that ultimately helped us in picking up mucormycosis. So voriconazole was replaced with liposomal amphotericin B, and DNA was extracted. It could confirm the Rhizopus aereus. We are very happy, but patient went downhill and patient ultimately died. An autopsy performed You see both Aspergillus and mucormycosis there. We really missed it. And we started liposomal amphotericin B, but it was quite late in that scenario. So we need aggressive to go for this aspect. So when you suspect in this type of patient a new cough, chest pain or hemoptysis, unresolved pneumonia or certain situation where antibiotic is not responding, if you have got a new positive culture of Aspergillus from the respiratory tract, think about this, which is being useful. Next important, another point is the proper interpretation of the laboratory report. I am giving another example. This is a 67-year-old man, respiratory decomposition of known severe COPD which is there. Patient is having history of uncontrolled diabetes, bronchopneumonia and frequent bronchitis. Patient was on long-term prednisolone therapy, but chest X-ray when came, it shows that something at the right apex, thought to be of tuberculosis, which is already patient is having earlier anti-tubercular therapy. But here sputum examination could not get anything. Even gene expert was negative. So patient was giving amoxicillin, clovulanic acid and prednisolone had still been continued. On day 4 he went into respiratory failure, so he had to be shifted in ICU. Question is now if we can change the antibiotic or add antifungal or investigate the patient. At least investigate the patient. Tracheal aspirate culture was done and serum beta-D-glucan was sent. Whoever can see this picture will excited and say, this is pneumocystis cerevisiae. So you should start treating pneumocystis cerevisiae. And when beta-glucan also came 357, it is also helping the same diagnosis. So trimethoprim sulfamethoxazole started. Patient PF ratio improved and the patient was negative for pneumocystis cerevisiae, but the patient had low-grade fever and BG beta-D-glucan is still high. Serum galactomannan was negative. So we started thinking, is the beta-D-glucan was false positive or we are missing aspergillosis and galactomannan is false negative. So whatever it is, because beta-D-glucan was positive, which is commonly seen in case of candida and in case of the pneumocystis, so clinicians started fluconazole, but there is no improvement. Then BL sample was collected and it came out that there is presence of Aspergillus fumigatus. So voriconazole started. Now it's a non-neutropenic patient. Generally from this sputum or BL sample, even if you find Aspergillus, that does not always correlate with the invasive disease like in case of neutropenic host. On day 22, galactomannan serum was 0.7, which is not very clear, positive or negative, but BL came 3.4. So it was said that yes, now it is invasive aspergillosis and serum beta-D was quite high. So the question is, when you have started the voriconazole, they are not responding. That means is it azole-resistant Aspergillus fumigatus? So we thought of going for liposomal amphotericin B, but family refused, and he was extubated per family's wish, and he died later that day. Autopsy performed shows teeming with invasive aspergillosis. So again I am saying you that earlier we should have thought about when the patient, yes, pneumocystis cerevisiae has been responded, but patient is having fever and patient beta-D-glucan was high. So we should have started thinking sometimes serum galactomannan may not give the result. So the lesson learned is that think of aspergillosis in non-neutropenic host, possibility of aspergillosis in those on systemic steroid, serum galactomannan may not be useful and patient may acquire aspergillosis in the hospital. New issues are coming up in your pulmonary field. This is one patient of 34 years, low-grade fever, productive cough, hemoptysis for 1 month. He has a history of tuberculosis. 1.5 years back, patient was treated well. And this time, patient's vitals were normal, no abnormalities in systemic examination except few crackles in right lung. Chest radiograph shows again something is there in the right upper lobe. And sputum AB was negative. Gene expert was also negative. HRCT shows soft tissue mass on the right upper lobe with a cavity. Thought of there is possibly drug-resistant TB. So, though bronchoscopy, nothing could be detected, no AFB was there, but the patient was discharged on the second-line anti-tubercular therapy. 2 weeks later, patient returns with persistent hemoptysis. This time, bronchial artery embolization had to be done. And HRCT now shows there is clear-cut cavity with the right upper lobe, and there is presence of something inside, which ultimately, when it had been lobectomy had been done, biopsy shows presence of chronic pulmonary aspergillosis. So, friends, post TB, don't jump that this is a drug-resistant TB. 20% of these cases we found is a chronic pulmonary aspergillosis and simple test of antibody which can help. So this is, we have developed for low middle income country how we can define or we can diagnose chronic pulmonary aspergillosis. Symptoms more than 3 months. If you cannot do CT, even plain X-ray can help you. Microbiological evidence of aspergillus, and you have to exclude at least mycobacteria. So this is the algorithm which we have proposed. Cough, radiograph, then cavitation if it is present. Exclude at least TB by doing the gene expert and do the serum antibody test for helping diagnosis. So friends, at the end of this my presentation, these are my 6 essential elements which I think for better diagnosis. One is be aware of the risk of fungal infection. Be alert when the risk occurs. Be able to access the test needed. Sample adequate for test. That is also very important. Results available in timely manner and be affordable for repeated diagnostics. And I invite you, we from our fungal infection study forum develop a fungal registry now. If you have got any case, in case of the mold infection or rare fungal infection, please submit it. We are reimbursing you with 2000 rupees for each case. Thank you for your kind attention.
Thank you, sir. Now, at the end, I will like to invite Dr. Parthasarathi Bhattacharya, sir, to please say the vote of thanks.
Thank you, Abhishek. I am sure that everybody is spellbound by the discourse from Dr. Arunalok Chakraborty at the fag end of this inaugural session and oration program. I thank all my dignitaries, all the guests who have taken pain to come from distant places. I thank Dr. Arunalok Chakraborty profusely, Dr. Samiran Panda, Dr. Deepak Talwar sir, and Dr. Emil Gupta. Dhimanda also, he has been a constant encouragement to us. And I thank you all. With this, thanks, I close the inaugural session. Now we are right on dot. The lunch is ready. I request you to have your lunch and come back and join here. The session to start at sharp at 2 p.m.
One more announcement I need to make is the poster session will be held in the upstairs and it will be post lunch from 2 to 3 p.m. So those who have posters with them, please contact the authority and they will be demonstrated upwards beside the lunch room.
Good afternoon. Post lunch, we are going to start our next session, which is a case-based learning session, basically on chronic indolent lung infection. To chair the session, we have two dignitaries, Dr. Unalo Chakraborty, whom we have already listened to, and Professor M.L. Gupta. Sir, Dr. Gupta and Dr. Chakraborty, please be on the. And kindly introduce the presenters, Dr. Deepak Talwara and Dr. Kanish Kumar.
Okay, both of you already introduced Dr. Deepak Talwar and now also Dr. Kanish Kumar.
Thank you, sir.
I don't think we need to introduce again Dr. Deepak Talwar. You have heard him earlier. And Dr. Kanish Kumar, anybody can put the slide of Dr. Kanish Kumar. Dr. Kanish Kumar is at present, he is the consultant in interventional pulmonology at Metro Center for Respiratory Disease, Noida. Both of them are same center. So you are the junior to Dr. Deepak Talwar. Okay, start with the test.
Okay, so I think the flow of this case would be that after it's a little longer story, and I was supposed to discuss about a case which is having a chronic lung infection. So there will be multiple times it will be stopping at asking you the question as to what would you do. So obviously case will be running through by the entirely by Kanishk, and in between wherever there are questions, I'll be coming for some interaction so that we don't delay the entire process. We have 30 minutes given for this, and we'll try to complete it in 30 minutes.
Good afternoon, everyone. Thank you, Pulmocon, for this opportunity. Without wasting any time, let's proceed and see the case. So this is a 77-year-old male, former smoker, a doctor, pediatrician by occupation. The patient is a known case of hypertension, type 2 diabetes mellitus since 18 years as in on medication. Patient is a case of pemphigus foliaceus diagnosed in 2020, treated with injection rituximab, has taken 3 doses. Thereafter, the patient is on MMF since March 2022 to December 2022. There is a history of COVID-19 in April 2021, treated at home with no hypoxia. Now presented in December 2022 with the chief complaints of fever, which was high grade, and dry cough since last 20 days. There is no history of hemoptysis, no autoimmune symptoms. No exposure history, but there is a history of travel to Singapore 1 month ago. Patient took antibiotics with no pain, no relief in the symptoms. On examination, the patient was febrile. Saturation was 91% on room air, and on auscultation there was bilateral crackles which could be heard on the chest. This is a CT scan. Routine CBC, LFT, KFT and fever profile was also negative. 2D echo was done, ejection fraction was 60%. So you can see the CT scan now with the HR cuts.
Do we have any radiologist? Any radiologist? No. Yeah, so any pulmonologist, anybody who wants to say what is there? Milan, you want to say anything what is there on the CT scan? So are there postgraduates here? And then it is slowly coming up. I think sound is not coming. Can you increase the sound if it is on?
Yeah, what I can see is
Yeah,
huge
yeah.
ground glass opacities. They are more in the bases. There are some nodular opacities as well, but I could not see the mediastinal cuts as well if there were any lymph nodes.
I'll play it again.
Okay. So
Hardly any. Yeah. So
with fever above 3 weeks and in a patient who's been immunocompromised primarily because of the immunosuppressants being given, with the fever for which almost antibiotics and everything is taken. And I think after listening to Dr. Chakravarti, everybody will jump to some other conclusions at this point, but we'll move on to the next slide. Yeah. So this is what we were coming to, that what is the pattern. So anybody wants to comment on what is this kind of pattern what we are seeing on a CT scan? Because many a times as a pulmonologist we try to take clues from the radiology that what is likely the etiology, that's what we want. And I think most of the times etiology cannot be one single unless and until so dramatically it is telling us what it is, which is like PJP, but then also that is missed so frequently. So I think the basic thing when we start with the fever and the CT scan, this is the pictures which are showing. So is this pattern suggestive of anything? I think Dr. Emil Gupta already made a point that it's not just ground glass opacities, there are a lot of interstitial shadows which are there. And of course there is bilateral pleural effusion in this patient. No significant mediastinal lymphadenopathy. So I think the next question is that this kind of pattern is seen in which conditions? So
I think Bhatta Acharya wants to add something.
Yeah, yes, there is particularly at the bases we are seeing, and I think the very prominent thing is the apices are almost clear actually. There is nothing in the apices. It's a predominantly a disease which is in the middle and the lower part of the lungs. It is diffuse, and of course it has got a component of ground glass opacities, some consolidations, as well as a lot of interstitial shadows and a bilateral pleural effusion. So, of course, this kind of organization and other things can be seen in many conditions. There's a long list given, but most of the times when we see in clinical situations, we need to distinguish between is it a infection, maybe unusual infection, or is it an autoimmune process, or it is a malignancy. All those things which are normally seen can be seen. So what happened next?
So what are the differential diagnosis comes to our mind when we see the CT scan with the organizing pattern? Can be infections, bacterial, mycobacterial, viral, parasitic, fungal, or is this an autoimmune disease, or eosinophilic syndromes, chronic heart failure, or is it a malignancy? These are the
Any
questions.
other thing anybody wants to add to this list of differentials on the basis of what we have told you about the case? Drug-induced is also a possibility. Yeah. So rituximab is the only one which they have used. So rituximab induced would be two things: either eosinophilic lung disease, basically the eosinophils, or secondly infections related to rituximab use. So both of them are the possibility, correct? So I think this question is very relevant to pulmonologists, that what will you do? You are seeing this kind of a CT scan, you can do a bronchoscopy, you can do a bronchoscopy with biopsy of the lung, TPLB, you can do a pleural tap, anything is possible. There were small lymph nodes, I do not know how significant they were for the EBUS, but I think that is always there. So you can pick and choose. So any comment on this?
I think before going for invasive procedure, a collision workup may be required.
Okay. Correct. So before jumping on to this, because if it's a systemic cause, then you may get nothing actually on a biopsy even if you do that. And at least autoimmune in these kind of scenarios, particularly fever not responding, One cause is, of course, the infections which Dr. Chakravarti told us, the fungal infections. Second is an autoimmune disease. And in normal routine autoimmune diseases, like if you do only ANA, ENA, you might miss it because myositis is a very important component of it. And you need to really look into PL5, PL7 as well as PL12. So they have done the autoimmune profile. It was all negative. And
serum galactomannan was 0.5. Then we did the bronchoscopy with BAL, and then we went for TBLB. The PCR weak positive for the mucor, and BAL galactomannan was 1.2. Gene export was negative. Pleural tap was done, as said by sir. The fluid was exudative, low ADA, LDH was 171, and the gram stain was negative. Autoimmune profile, as we discussed, was negative too.
So we have just learned that, getting galactomannan is like a Waterloo. You must interpret it with your clinical background, and then of course you have now differential between serum and a BAL galactomannan also. So I don't know how to interpret, so I'll ask Dr. Chakravarti sir how to interpret this galactomannan, which is the most clear
thing is that, as I have discussed, that at least you need, when you don't have the direct microscopy or histopathology or anything, just on the basis of galactomannan, at least you need two. Second important thing is that serum galactomannan 0.5 is almost just a cut-off value. It is not being positive. And BL galactomannan 1.2 is also near close to it. So in this scenario, we will not go jump on diagnosing invasive fungal disease on the basis of these two galactomannan report. Rather, we like to repeat it again, if possible, in this patient.
Right, sir. So what about the sir PCR being weakly positive to mucor?
Well, what type of PCR you have done, I don't know, because you know that mucor, we don't have any commercial standardized protocol available. There is one test which has been developed by French people, but again I would say that it's not yet standardized for diagnosis in case of mucor by PCR.
So this was the time, like when I think 22 beginning, at the time when this PCRs have come up long for mucor, primarily because of COVID getting it from some laboratories, God knows which methodology they use. But I think the biggest challenge for us was, how true is this mucor PCR? The culture came out to be negative later on, but of course the question is, at this point we treat the patient how? So the only thing, the TB test being all negative and a biopsy showing that there is a lot of alveolar exudation, and you can see that on the corner, that there is a process of so much of fibrocollagenous tissue that it is almost becoming like a meson bodies. These are not meson bodies, but this is going on becoming more and more organized into that. So on the basis of it, obviously the pathologist said that it is an organizing pneumonia. Now, as we see that now this is organizing pneumonia, the causes again is such a big list which we have discussed before. And here we have narrowed down to perhaps fungus related, because we didn't get anything else. So at this point of time, shows the next slide. Okay. Obviously, we had all these questions in mind. Go ahead. What happened? Yeah.
So the patient was started with steroids 40 milligram and was discharged on tapering dose on January 2023 with antifungal therapy, isavuconazole 200 milligrams OD for initial 8 weeks. Steroids stopped, and within 3 weeks started having fever, which was moderate to high, and the patient also complains of chills along with that.
Do you think that this antifungal should have been given to this patient?
And especially when we are saying that steroids stopped and the fever appeared, because initially when this patient was seen with steroids, I was wondering why steroids and antifungal both together, because you do not know what you are treating actually. So as sir said very rightly, I think the doctor was advised to undergo a repeat BAL actually for a PCR for mucor again, and he went through that, and this time it was negative. So he was happy that my posaconazole is going to go away. It is going to be much. He is obviously, it was pinching his pocket also at that point of time. And the moment, but the steroids were stopped, he started running fever again. And this time they were with
Doctor was advised to undergo a repeat
So,
valve.
okay, show us what happened.
Patient continues to be febrile. What do you do? Would you recommend now as
Should we just now think that it is a cryptogenic organizing pneumonia and treat him with steroids? Or we should do more evaluations for these patients? Or maybe because we gave only steroids, did not give clarithromycin,
But the steroids were stopped,
might
he
have
started
given
running fever
clarithromycin
again.
to him.
And this time they were with
profile
was advised
of
to
the
undergo a
patient. So
repeat
what's your
valve.
opinion? Anybody
So
knows what happened?
patient continues to be febrile. What do you do? Would you recommend now as
Should we just now think that it is a cryptogenic organizing pneumonia and treat him with steroids? Or we should do more evaluations for these patients? Or maybe because we gave only steroids, did not give
But the steroids were
we
stopped,
think
he
that I'm
started
going to
running
use it
fever
for
again.
18 months.
And
I
this
do
time
give
they
them
were with was
profiles
advised
of
to undergo a
drugs. So
repeat
what's your opinion?
valve.
Anybody
So
knows?
patient continues to be febrile.
Recommendation
What do you
is
do?
20
Would you
milligram
recommend
and
now
above
as
doses for
just
more than
now
4
think
weeks. Is
that
that
it is a
right?
cryptogenic
40 milligram for 4 weeks.
organizing
Is that right?
pneumonia.
Okay,
gave
so that
only
is
steroids,
but
did not
generally
give
if I
but the
if a long
steroids were
3
stopped,
months
he
even
started
at
running
20
fever
we start
again.
giving them
And this
because
time
now
they
it's
were was advised to
we
undergo a
know that
repeat
like
valve.
with ILD we are going to continue for a long time. So
Recommendation is 20
Would you recommend
this
now
patient was
as
actually brought
just
from
now
40
think
to
that
30 and 30 to
40
20
milligram for
and
4
then the
weeks.
moment after
Okay,
20
so
goes
that
off,
is
it switched off and the
generally
patient
but the
started running.
steroids were stopped, he started running fever.
CT was done. The picture has changed. Anybody wants, Milan, you want to make a comment on this now? What's happened? Ground glass has gone and it is getting loculated even. And there are more dense shadows now. And perhaps now, what would be the suspicion? Dr. Gupta, what would be the suspicion now?
We have treated adequately the primary disease, but probably we have invited another infection. And with steroid in India, probably we should tuberculosis first.
Very right. So we also thought so. Next slide, we didn't decide to add steroids and we didn't thought of doing a repeat FOB. Or there was a question that we can do a CT guided or a thoracoscopy. Actually, the patient at this time was advised thoracoscopy somewhere, but we told him we'll just tap your fluid at this time and see because this was not there previously. And the other side fluid has
So repeat pleural tapping was done on March 2023, which showed exudative, lymphocytic, and pleural fluid ADA was 39.3. The gene expert came out to be positive, which showed MTB detected. Bal pen fungal PCR was negative. Started on ATT from 4th March 2023. Pleural fluid AFB culture was negative. 2 months and the patient continues to be febrile.
So all the initial enthusiasm by the patient that without thoracoscopy I have got the diagnosis, I am very happy, gradually went away because the fever didn't go away. So obviously everybody thought that, let's give him more time, he's immunosuppressed, he will take more time, continue with the 4 drugs, wait for it. And there was another group which was saying add steroids now so that his fever goes away. Next.
So we did a PET scan.
MTB sensitive and what
It was sensitive. It was MTB sensitive, but culture never grew anything. Culture didn't grow anything. Yeah.
So on 13th May 2023, we did a PET scan.
Anybody wants to make a comment? Is a malignancy a suspect here? Because now at this point of time, obviously you can understand the PET scan. No, sir. So EBUS was tried on the day 1 itself, sir. At that time, after that, we didn't repeat. But now we are, yes, seeing a lymph node which is actually very, very avid at this point of time, as well as there is a lot of uptake in the pleura. and particularly the parietal pleura is shown localized uptake at multiple places. Any comments from the house? Anybody? That's the most common thing everybody thought about, that give steroids, immune reconstitution is one of the things. And but we were not happy with labeling that diagnosis. So we thought at least one more biopsy must be done to confirm what is going on before writing it immune constitution. And there was also a thought process that it is a drug resistant TB, change it into a MDR, saying that it is a clinical failure. Clinical failure. So actually, she did go to a specialist for this, and at Delhi, you know this. We have this Meroli.
Once. Yeah.
Second time is now, sir. We haven't done anything right now.
We are evaluating
In fact, it is third time actually.
Third
First
time,
time pleural tap, second time pleural tap. Third time we haven't decided what to do. And they were very reluctant to undergo any procedure at this point of time. And they consulted and somebody said it is MDR-TB on the clinical failure grounds. And she was started on, or he was started on all this new regimen which has come in with Delaminid and others. It was basically started on that. But then somebody raised the suspicion of malignancy and they got a PET scan, and with the PET scan they came back to us that what to do with this. So can it be MDR, or is it a malignancy, or it's something else?
But before we know what has been done, but to me the chances of malignancy are less, because patient fever is not a feature of a malignancy.
True.
And second thing, malignant diffusions are usually massive, moderate to massive. It doesn't give picture like that of a loculation unless it is mesothelioma.
Right.
So to me,
It should have been
malignancy is less
picked
likely.
up in the previous one, but we didn't do a PET scan in the previous one actually. So that was the little catch in it, because people thought that it's a slowly growing malignancy with AFB positive, gene expert positive. Two diseases together was the one theory which was going on. And obviously when you get into all this, you have all these choices. Like there was even a choice surgeon advised for decortication because fever is persisting, tubercular pleural effusion, and this is insisted. So why not to just take it out everything along with the pleural membrane and everything. Steroids, as you said correctly, that steroids was also one of the option on the cards. CT guided pleural biopsy versus thoracoscopy. So anybody wants to, yeah.
Thoracoscopy would definitely have been a good option, but if she's not willing for any procedure, then probably CT-guided pleural biopsy
Right.
would be the best way forward.
Very correct. Very correct. So, any other reason you will think not to do a thoracoscopy here? Can you show the picture again? The PET scan? No, that's not the thing. Look at the pleura. How thick is the pleura? You do a thoracoscopy, you put in an ICD, it will be very difficult to get the ICD out in this patient. Lung is not going to expand. Because it's been 2 months now, the pleura has become very thick peel now. It's very unlikely. So we decided, okay, we don't want to he didn't want to go for decortication and things like that. So we decided, as you said, that CT guided biopsy was done. Sure.
So we went for the CT guided biopsy.
The idea of getting good, PET scan helped us in picking up the avid area only to get into the biopsy, and which was actually in the upper part, not the lower part. The radiologist would have been very happy to do it from anywhere, but once the PET was done, he knew where to take the biopsy from.
So I paused that slide in the PET 2, and you can see the pleural.
Yeah, the needle is there.
Needle is there, and the biopsy was taken from that area.
Go ahead.
So this is a CT guided biopsy was done after diagnosing twice. Again, the complaint of fever was there. So after the pleural biopsy, expert plus MTB detected trace. Rifampicin resistance was indeterminate. AFB stain was negative. Gram stain was negative. Fungal smear was negative, and pyogenic cultures showed no growth.
So what now? Yeah.
This is the histopathology slide.
Histopathology we are showing. You see this and tell us. That's what we are supposed to. We are pulmonologists. If we can't interpret our own pathologies, who is going to help us? Tell us what we are seeing here. cardiac parameters. In fact, we thought that it was a normal ejection fraction heart failure at that point of time, which caused this this thing, bilateral effusion. But it was exudative at that point, and since it disappeared the other time, we thought, okay, steroid responsive. Pericardial thickening was already there. You are right. You have picked up that there was a pericardial thickening also. So anybody wants to see this pathology? Anybody wants to jump in? There's no pathologist in the hall, and I can understand that.
Say only granulomatous pathology is being there, but truly speaking, cell looking into the nucleus hypoplasmic ratio is not very well determined. We need a higher power of
Right, sir. So see, he's a microbiologist, na? Mycologist. He's able to read that. Go back to the slide. There is an extensive necrosis with a granulomatous reaction, which is very nicely being shown in the lower part of the slide. You can see so much of necrosis. And when you see so much of necrosis, the next thing somebody will jump into is, where is the fungus? They will look for fungus. They know that TB is already there. They know it, TB is there. But then they are seeing now, with so much of necrosis, something else could be there. We'll show you the high power. Anybody wants to make any comment on this? Now, don't tell me that we do not know how to see the high power films also. Is it malignancy or not? Is it tuberculosis or not? No. No comments. Okay. Are you seeing any microorganism or any fungi here? Don't know. Okay. We'll show you the next slide. No diagnosis. What is this? What are you seeing? Which is this stain? And what this stain is used for? Come on, at least say it is a GMS stain. And GMS is done for what? So what do you see here? Clumps of clumps and clumps and clumps. And some of them are single ones also being shown here. What is it? Anybody wants to put a bet on it? What it is? Very good. Who picked up histoplasmosis? Very good. I think that guy definitely deserves a prize. This is a GMS stain. The only thing you can confuse it with the dust particles actually. They just look like the same.
You can confuse with emergomycosis, which is now coming up.
So MTB also. Right, sir. So anyways, obviously when you give such kind of an exotic diagnosis, you are actually for the second opinion. So second opinion AIMS and second opinion PGI and second opinion even to the US, the slides. And finally the answer did come that this is histoplasmosis. But now I will come to this question to sir, that how else we could have done it, because the culture was not positive and serology was, yeah. Yes, yes, it was. We had suspected fungus. It was taken for fungal culture. It was taken for everything. But fungal culture came out to be negative. And this was actually already a tuberculosis patient. You know that. And then we were, the debate is, as sir said, that is it tuberculosis or it is tuberculosis plus histoplasmosis, both. So in such situations, sir, how do we approach this? Sir, you.
I would say that besides this smear, examination would be very important, because some of the cases which thought to be histoplasma came out to be emergomycosis, because they exactly look like histopathology picture same. Only culture could differentiate, or doing that you extract the DNA, do the sequencing can help you in diagnosing it. But this particular case, another thing can also indirectly, you can go for histoplasma antigen detection. Histoplasma antigen detection in urine is a very good sensitive procedure, except in case of chronic variety. There is a, sometimes it can come negative. Otherwise, acute disseminated group, there is usually it's a very good sensitive test in case of diagnosis. But Mucor, I would not agree for the diagnosis on the basis of PCR. So I would consider the TB plus histo, that would be reasonable bet.
True, yeah. So, sir, any comment on this indeterminate resistance now to rifampicin on pleura?
whenever there is a less amount of the
So it
material is
becomes
there,
indeterminate.
it will come.
So this is what I think excellently Dr. ML Gupta has put in. There is always a confusion that they get MDR on the basis of this, which is correct, not correct because the sample is got very little material, so it is coming out to be indeterminate. So I think we were not able to get a urine antigen done, but we did get serology test done, and unfortunately IgM was negative actually. Yeah.
If you go for
Antigen test. We couldn't get it.
antibody detection in this scenario may not be so good. You
Right.
can go for antigen detection.
Because it's a chronic disease, the
Not
antigen
only
would
that, usually antibody detection, it persists for a very
for
long
life,
time.
for life almost. Correct, sir. So, sir, only other question is like this patient is on TB treatment and still not responding, and we have got this thing like histoplasma. So, will that be clinically good enough to at least cover the histoplasma in this situation?
At present, if you have really, I'm not very convinced from this photograph. I would love to see on microscope because I could not see the yeast cell, his budding pattern, all those things, which is very important. But if it is histoplasma, we will start the therapy with amphotericin B for at least 2 weeks and then go for itraconazole therapy.
So,
which is making him prone to any granulomatous like
Yeah, patient, what is the initial patient rituximab therapy which have been there? So basically it's a immunology where there is being altered. So you can, earlier we used to say immune depression means when there is a something completely profound neutropenia. But now immune deficiency has different stages, defined pattern. Even there is a signal transduction pathway deficiency. Like in case of your CARD9 deficiency, STAT1 deficiency, which make them susceptible for infectious aspergillosis. So I'm saying immunity pattern has completely, is not the profound neutropenia, which is seen in hematology malignancy, but suppose diabetes. Diabetes also has an immune suppression. Mainly the macrophage activity or fungicidal activity is coming down. That's why we see in case of mucor which have been there.
So we continued the same ATT, all 4 drugs, and 2 weeks later, still when he was running fever and all the confusion about histoplasmosis was discussed. And then finally he was given amphotericin for 2 weeks and put on itraconazole and sent back home. He's now 6 months down the line. The things have all improved, fever has gone, everything is gone, but there is a residual amount of fibrosis which is left behind in the lung. So I think that's exactly what tuberculosis and histoplasmosis look like, that they just are identical images, very difficult to distinguish. And of course, our diagnostics are not so accurate and so widely available that we have an access where we can actually pick up this diagnosis. So I think when we talk about an immunosuppressed individual, multiple infections is the most important thing to keep in mind.
So how long you will continue the itraconazole? And with rifampicin, did you go for the blood levels or you just increase the dose of that? No? Yes.
I would say that if you are giving itraconazole, you must do the therapeutic drug monitoring. That's a bit important. And generally what we have found that in case of histo, at least 1 year therapy with itra, that would be required. That is very important.
And many a times, sir, they are given a chronic prophylaxis therapy, like 1 tablet continuously going on because.
We prefer to not go like that. That would be low dose. Usually the recommendation is very clear that 2 weeks amphotericin B therapy and then itraconazole, it is at least 200 milligram itraconazole for 1 year therapy. That is the
Possible, particularly that there is some overlap between the genomic sequence of histoplasma and mycobacterium tuberculosis, so that was a false positive CV0. Is it possible?
Second time or the first time?
genomic similarity. No, that is prokaryote and this is eukaryote. So prokaryote in case of bacteria has a completely different morphological structure from the fungus which is eukaryote.
So I think at the end of the day, if the patient becomes all right, everything is fine. So that's exactly what happened. Thank you very much for this wonderful case discussion. Thank you, everyone.
Thank you, sir, for a wonderful discussion. It was a great learning for me to learn a few more points. So this is all about the discussion. Every time we discuss, we think that we have more to learn. Thank you so much, everyone. Thank you, Pulmocon. Thank you.
So now we are moving to the next session. This is a symposium of interstitial lung disease. And to coordinate the session, may I request Dr. Shivarashmi Unnithan. Ma'am, please. Dr. Unnithan is already introduced in the morning. She is an acting consultant in the Fortis Hospital, Kolkata.
A very good afternoon. So we are now into a very, it's going to be a powerhouse discussion. There will be some deliberations followed by hopefully absorbing kind of ILD panel discussion. We start off with Dr. Milind Baldi. He's our speaker from Indore. He's done his DM from PGMER and MD from SAID GSMC. Dr. Milind.
All right. Thank you. Good afternoon, everyone. Thank you, the organizers, for having me and giving me this opportunity to be here. All right. The last session, the last talk ended on the fact that the more we learn, the more we get to know that how much more we need to learn. So, taking the lead from there, what have we learned in the last 2 decades in interstitial lung diseases? That's me in 2003, and right now in front of you in 2023. A lot of things have changed since then. That's when I started learning about interstitial ILDs first in my second MBBS. The world has changed significantly since then, but some things have been static. It's the same case with interstitial lung diseases as well. So a lot of things have changed, a lot of things have been same. Just a search on PubMed about what's happening with ILD. 50,000, more than 50,000 publications the last 20 years. And most important thing is it's an exponential growth all throughout. So plenty of learning going on there. The highlights in the last 20 years, I'll be talking about them. First, in 2000 came the ATS statement of IPF, a consensus statement. And then in 2002, they told us how to classify idiopathic interstitial diseases as well IIPs into different categories as well. Then came AE-IPF in 2007, which was again a consensus diagnosis kind of statement, and another in 2013, where they have said that any patient with IPF, typically lasting for worsening in the last 1 month, and no extra parenchymal cause identified with new GGOs, which is not cardiac failure or fluid overload, is most likely AE-IPF, whether triggered or not triggered. There have been a series of papers from joint ATS, ERS, and the other authorities about IPF, 2011, 2015, 2018, and lastly in 2022, where definitely these papers have taught us a lot, and this is like a consensus statements. What has changed? What has changed is basically how we are classifying the disease now. Previously, we were giving them names according to clinical, radiological, and pathological diagnosis. Now we have started grouping them, and as per their behavior. So, disease behavior, what all different types of behavior we are seeing. So, reversible and self-limited. For example, RB-ILD, it is reversible if you remove any possible cause. Reversible, but with a chance of progression. Example, cellular NSIP, the kinds where you will want to intervene because there's a chance if left untreated, they will progress. Stable, but with residual diseases. For example, some cases of fibrotic NSIP, and progressive, irreversible, with a potential for stabilization, again where you would want to intervene. However, there were few prototype being IPF where irrespective of whatever you do, they will progress. So behavior-based classification is one change which is happening. And other thing what we have realized in the last 20 years is individual features are rarely pathognomic. It will not happen that the moment you see honeycombing, it is UIP and nothing else. So it's not. So you need to take input from multiple domains, and there is a significant inter-observer variability in interpretation of whatever facts you are getting from the results. And there is a potential harm of doing any invasive procedure, particularly in patients who are hypoxic or sick. So what we came out was with a MDD approach, wherein inputs from different domains, clinical, radiological, pathological, rheumatological domains are taken, and a prognosis based classification and an optimized approach for the treatment is given to the patient. So MDD is one thing which we have learned. The other thing which we have been doing a lot these days is either splitting or lumping, whether you call it smart splitting or smart lumping. Splitting is basically classifying it further, which is the key for precision medicine. Each individual patient is different, so you would want some precision medicine there. And lumping is for non-specific treatment. You would want to group particular patients in particular group of patients. For example, treatments like pulmonary rehabilitation or LTOT. You would want to group them together. So that's an important. Both these approaches are comprehensive. We were talking about splitting. More than 200 ILDs we have kind of discovered in the last 200 years, and it is obvious. I mean 20 years, and it's obviously important because there's a difference in prognosis, and there's a difference in the way we would manage them as well. So splitting is much more important. However, we have been lumping them as well. For example, IPAF 2015 paper, you would see some features of CTD, you would call it ILDs with autoimmune flavor or something like that, and you would want to put them together in a basket. You are not able to give a diagnosis to them, but you would want to put them together. Different criteria were given for them as well. Coming to IPF, this figure which I mean, a landmark figure, we know different patients will behave differently, and there can be sudden bolts from somewhere where acute exacerbations can happen and patient can suddenly go down. However, different trajectories will be there. But what we have also learned is intervening in time can significantly increase the decline of the lung progression of the disease will be slower with early treatment. However, even with a delayed treatment, there will be a slower decline with late treatment. So that is something which we have gained. Other thing which is like happening in the recent paper significantly is between UIP and probable UIP pattern, specifically on the radiology. The major difference is about honeycombing. UIP has honeycombing, however, probable UIP doesn't have any honeycombing. Other features are almost the same. So the 2018 paper, what it said was in a patient with probable UIP, the guideline suggested that we would suggest a surgical lung biopsy. However, a very low quality of evidence was available, but they would suggest surgical lung biopsy even in probable UIP. However, if it was UIP, they would say we do not recommend biopsy in any form. So is honeycombing that different? Is honeycombing and traction bronchiectasis or traction bronchiectasis that different? Is there a conceptual separation between the two? The new things which are coming up, they are saying that there is a pathologic L and CT correlation demonstrated between these two things. As in, if you're finding traction bronchiectasis or bronchiectasis in isolation, that can be maybe with time it will develop into honeycombing. So it's not that big a difference. It was also observed that probable UIPs and UIPs would go on to have a similar disease course, and even in patients where histopathology was achieved for probable UIP, around 80 to 85% were UIPs. So there's a trend towards merger of probable UIP and UIP on CT as well. At least in the 2022 guidelines that they have said, in appropriate settings, for example, a male who's a smoker, a 60-year-old male, even patient with a radiological pattern of probable UIP can receive a diagnosis of IPF after MDT without confirming it on a lung biopsy. BAL may be indicated depending on a case-to-case basis. So probable UIP can directly go after MDT without the need of biopsy into IPF. About diagnostic advances, we have evolved from surgical lung biopsies to transbronchial lung biopsies and cryobiopsies. Lot of papers have come in the recent last 3 or 4 years. Chest guidelines said that cryobiopsies can be used as an alternative. However, very low quality of evidence. ERS paper, excuse me. ERS paper again said the same thing. The yield is lower, however, at a reduced risk and serious adverse events, but again very low. The 22 paper again said that it is an acceptable alternative to surgical lung biopsies in ILDs of undetermined type, however, very low quality of evidence. But so, in a nutshell, low quality of evidence, but TBLC can replace surgical lung biopsies significantly. One more thing, because of this TBLC coming into picture, we are not going into the periphery of the lung. How we are doing it on surgical biopsy, we are taking the periphery of the lung. Now we are not taking the periphery of lung. In a patient with HRCT pattern, the only difference between these two tables in 18 and 22 is if there was an alternative diagnosis suggested on HRCT, the histopathology is showing probable UIP, you would call it non-IPF. You would be disregarding the probable UIP on histopathology and you would be calling, no, this is not IPF. However, now in 2022, if there is probable UIP on histopath, even in a HRCT pattern of alternative diagnosis, you would want to call it indeterminate. At least you are not calling it non-IPF. So that is the only difference which has come up in these two tables. Most of it is similar. Next thing. The next big thing which is happening is we are realizing and understanding that fibrosis causes fibrosis. Fibrosis begets fibrosis. This is a self-fulfilling prophecy of fibrosis, that irrespective of the inciting agent, be it aging or be it environmental stimulation or autoimmunity, once there is a chronic inflammation has set in, there is a cycle of self-perpetuating fibrosis. So fibrosis will lead to fibrosis, and that's how a group of fibrosing lung diseases are grouped together, which may progress to become PF-ILD or progressive fibrosing ILDs. Again, we are putting things into basket. And earlier this year, we had this expert ERS statement, a lot of familiar faces there as well. So PPF, what's happening is, how do we define PPF? If in a patient with interstitial lung disease, there is evidence of progression of fibrosis over time, progression in terms of symptoms or lung functions, and progression of fibrosis pathology, we would not be repeating it, but at least radiologically, if we are doing that, we are seeing that tracheal bronchiectasis or bronchiolitis has increased over time, or honeycombing is increasing over time, you would call it PF-ILD, or better term is PPF. The ERS statement particularly said that you would want to call it PPF only despite optimum management of the basic disease. That's really important. You would not want to start antifibrotics straight away if the primary disease was not treated appropriately. So again, the same thing. Other than IPF, known or unknown etiology, pulmonary fibrosis progression in the last 1 year with no alternate explanation, you would call it PPF. However, PPF is not a diagnosis in itself. It goes in conjunction with the basic disease, because most of the interstitial lung disease where there is a fibrotic component may go on to develop PPF. For example, as shown in this slide, about one fifth of patients with CTD ILDs, in spite of optimum treatment, will go on to develop or progress the fibrosis. Can we identify them? Can we pick up them early? Yes. There are risk factors. For example, basically risk factors of advanced disease, UIP pattern or extent of fibrosis if it is high, or low baseline FVC. In RA, if there's a high level of anti-CCP, if you are not able to identify the antigen in fibrotic HP, then the chances are a lot that this person will develop progression of fibrosis. Talking about the medications, we all know. I'll just raise a few important points to highlight. Nintedanib, usually given in 150 milligrams twice a day. However, something which may miss at times, allergy to soy or peanut is a strict contraindication, and so is severe pulmonary hypertension, which most of our patients may be having. So there's a contraindication there, frequently missed, but QT prolongation, it increases your risk of bleeding significantly, and so is the risk of embolisms and cardiovascular diseases as well. We need to monitor liver functions as well when we are putting them on. And 62%, that is almost 2 in 3 patients who you are putting on nintedanib may develop diarrhea. There's an increased risk of myocardial events as well. All right, coming to the next one, pirfenidone. I'm not going into the details of it as well. However, we need to remember the dose escalation weekly, and a reminder for using a SPA for your patients, and the usual side effects. Head to head, neither drug is more efficacious than the other, and all we know is that they will reduce the rate of decline by about 50% for your patients. depending on the setting which you are using. Someone prefers outdoor setting, I would prefer nintedanib. Someone is already on articulation or coronary artery disease or has a planned surgery, I would prefer pirfenidone. Cost wise, more or less similar. Pill burden may be different at times. Next in therapeutics is oxygen therapy. Again, no lot of evidence there, but data is extrapolated from COPD studies, almost similar criterias. Transplant coming up big way. However, we need to realize that there's a transplant window when we would want to start convincing our patients early rather than when they are here malnourished or patient is already too much into advanced disease and pulmonary hypertension significantly has developed. So we need to start convincing our patients somewhere here. That's what we have learned. And most important thing I think is we need to have more patient-centered outcomes rather than just talking about FVC or DLCO. What we also need is health-related quality of life status, the oxygen needs, the symptoms of the patient, the survival. Are we having meaningful patient-related outcomes? That is something else. And precision-based medicine depending on the factors which we just spoke about. So what I've realized, I've worked in UK in interstitial lung disease. What I've realized is they have a different setup, they have a different guidelines, they have a different patient population. We can't extrapolate and imbibe what all they are saying and put them verbatim on our system. We have our own set of problems and we need to have our own set of solutions for this. We need to have local research and local data. For example, I'm really happy that we have this Indian registry and a single center study coming the last few years. At least we discrepant results agreed, sarcoid versus HP, but at least we know that IPF is not the most common thing which we see in our centers. CTD ILD is almost as equal and HP or sarcoid may be increasing maybe a lot. So we need to have more data. I should congratulate the authors sitting right here. Local innovation. We definitely don't need a 100 feet corridor for performing a 6-minute walk test. Just a 6 feet distance is good enough for performing a 2-chair test. So we need some more local innovations and local setups like this to have our own problems. Palliation is something which we need to work upon and learn more and more. And it is not only treatment when it's coming to ILD. It's a holistic approach where we have to see so many things. Just to recapitulate, incorporation of MDDs, smart splitting and smart lumping, role of cryobiopsies, how we define fibrosis, begets fibrosis, the newer advances in therapeutics, and the need for patient-centered outcomes. Thank you.
Thank you, Dr. Milind. We'll deal with the question answer part after everybody in this session speaks. Dr. Partho, you are going to announce something or shall I?
Still a small announcement.
Yes.
Yes, there is a poster session upstairs. The four judges for the posters are Dr. Rupak Ghosh, Dr. Somnath Mitro, Dr. Raghav Rao. I have already informed Dr. Raghav Rao on the other hall. He will be moving, and Dr. Monotosh Khara. Those who have posters, they kindly move to upstairs poster area. It will start at 3 p.m. And on the other hall at 3 p.m. there will be a case presentation where Dr. Unalok Chakraborty and Dr. M.L. Gupta are supposed to move. So with that, I will come.
You don't want to introduce?
Yes. So, okay. So I'm taking advantage of being already introduced. So focus my, yeah. So I'm going to talk on algorithmic approach of interpreting HRCT for interstitial lung disease. Okay, thank you very much. Thank you, Chairman, ma'am. So in my next 15 minutes, I will touch upon the fundamentals and I'll go for the proper algorithm. In the fundamentals, these are the issues. And what is a HRCT chest to start with? It's basically thin collimation sharp algorithm. You can see this potato is sliced into multiple thickness columns. These are thin collimations. And HRCT in DPLD or ILD is always a high density issue. We look at the lung window where we can see the lungs. And this is a sharp contrast in contrast to the normal CT HRCT shows. There are 2 or 3 more important factors, supine versus prone film. In supine film, there is a problem, but in prone it has disappeared. This is called gravity dependent effect. And this is expiratory film which shows air trapping very clearly, making it mosaic appearance, which is absent in inspiratory film. So all these issues are important before you consider HRCT interpretation of DPLD. The basic lung skeleton is also important to understand. This distal hexagonal or pentagonal structures are called secondary lung lobules. And you can see one pulmonary artery which is blue because it carries deoxygenated blood, and a bronchus is traversing to the center of it. So the center is centrilobular, and you can see there are centrilobular pathologies. Actually, interstitial lung disease starts at the alveolo-capillary membrane, which is very remote, and the alveolo-capillary membrane becomes thick. That is basic interstitium. If you trace that interstitium proximally, it goes on to the bronchiolar wall, then to the bronchi. So a peripheral interstitium can go ultimately to the axial interstitium, or vice versa. The interstitial problem can occur in the lobule itself or intralobular, where you can see a mesh in the lobule, or it can be in the wall called interlobular. We discuss interlobular septal thickening, but we hardly say intralobular interstitium is affected because that's difficult, and mostly it is ground glass opacity. Well, this is an algorithmic approach for DPLD altogether. This is what I came out 1915-16, but it had to take 2 or 3 years to publish in Lung India in 2018. So basically, this is a historical chest X-ray followed by CT, serological, bronchoscopy, FOB, etc., etc. But I will focus on the HRCT part, which helps in confirmation, which helps in giving identification clues for etiology and also for determination of the progressive pulmonary fibrosis. And here is the algorithm that I have published. This algorithm starts with understanding of UIP. You know what is UIP. UIP is one of the basic interstitial patterns been seen in DPLD. Let's come to the algorithm. The first thing is the detection of the morphological abnormalities. I'll quickly scroll on. I'll just show you examples. This is called ground glassing. You can see the structures through a haze. So these are ground glasses. On the right hand side, it is organization. These are ground glass. This is crazy paving. This is honeycombing. You can see honeycomb, multiple layers of small cystic structures from the periphery into the lung. They are in a palisading fashion. This is mosaic appearance. This is pure reticulation. This is a mixed pattern where ground glassing and organizations are mixed together. These are nodules. Multiple nodules are there. If you see on the right side, there are a lot of it is sitting on the fissure, and you can see in the right lower zone the right lower part, a lot of nodules on the bronchovascular tree. On the left side, there is a mass-like structure, which is nothing but a big conglomeration of huge number of nodules. Basically, it's a case of sarcoidosis. Well, let me come to the detection pattern in DPLD. There are multiple patterns, and people who deal with the radiology of DPLD and physicians too, we discuss this pattern: UIP pattern, NSIP pattern, LIP pattern, organizing pneumonia pattern, and other features. I will show the basic 4 patterns. You can say this is a classical honeycombing or UIP pattern with traction bronchiectasis. This is classical NSIP pattern. Here you can see the subpleural peripheral part is spared. There's a lot of reticulations and some bit of organizations. Here you can see in both sides there is ground glassing, especially on the left side, and within the ground glass there are small thin walled cystic areas. This is classical of LIP pattern or lymphocytic interstitial pneumonia pattern. If you see these patterns, you can easily pick up this is an LIP, and your differential diagnosis immediately comes down, narrows down to a small number of conditions. So this is very important to understand UIP, NSIP, LIP. This is organizing pneumonia. You can see this is bronchovascular distribution, lot of opacities which are absolutely opaque, unlike the ground glasses. Dr. Rupak Ghosh is also requested to go to the poster zone, and I'll request my people to see whether there is any issue there. This is also a case of organizing pneumonia. There are other features in DPLD which are important, because if you find hilar bilateral hilar adenopathy or the classical 1, 2, 3 sign, you can think of sarcoidosis. Pulmonary hypertension, although is not specific of any etiology, but an important comorbidity that one should look for, pleural effusion if present or pericardial effusion, that can suggest DPLD arising out of sarcoidosis. Sarcoidosis rarely, maybe from the CTD-ILD, and esophageal dilatation immediately gives a clue for systemic sclerosis induced interstitial lung disease. Well, next algorithm is identification of the etiology or specific characteristics. Let me come back to my algorithm again. First is UIP, diagnosis of UIP. I'm sure meanwhile you have understood what is UIP. You can see the honeycomb and easily diagnose UIP. And if there is UIP, a small list of diagnosis or possibilities are there. For diagnosis of UIP, already Milind has projected. This has been presented way back in 2011. There are features for UIP pattern, possible UIP pattern, and inconsistent with UIP pattern. Always I take from the last. Look for the inconsistent with UIP pattern. I'll give you some examples. This is normal. And on the left hand side, you can find UIP, multiple small honeycomb-like cyst. And on the right hand side is upper zone involvement. So upper and middle lung predominance is not going with UIP pattern. Here you can find lot of ground glassing, which is not UIP. Here there are multiple micronodularity, huge number of nodules. This is not UIP. Here you can see a lot of organizations, not UIP. Here also you can see a lot of cysts, which are not UIP. And here and here. So you have seen so many conditions which are not UIP, which can be easily picked up from the HRCT picture. Well, let me go for the decision algorithm now for etiological diagnosis. First, you have diagnosed UIP, and by now you know if not UIP, it is all non-UIP. So if you go to interpret HRCT or ILD, you just say whether it is UIP or not. If it is non-UIP, the algorithm starts with, is it sarcoidosis or not? Let's see what are the features of sarcoidosis. This algorithm has come up to my mind right from our ILD India registry. We are tuned to think of ILD in terms of predominance in frequency of idiopathic pulmonary fibrosis. But once the ILD India registry was published, it showed 47 to 48% of the patients were non-UIP HPS, basically hypersensitivity pneumonitis, and only 10% or so is idiopathic pulmonary fibrosis in India. So we thought that we should not think in the fashion the Westerners think, we should think in our own fashion. That's how we made this algorithm. So let's see what are the features of sarcoidosis. I've shown that CT cut with the multiple nodules. So these nodules are sitting on fissures. They are on the pleural surface. They are called perilymphatic nodules. They're very small differential diagnosis for perilymphatic nodules. And if you find this picture, think of sarcoidosis. On the left hand side corner, you can see apical shadow with lot of the pleura is peripheral, is subpleural area is spared. It's like a flower, it's a hole-like thing, as if it is growing with the bronchivascular ramifications. So this kind of fibrosis is suggestive of sarcoidosis. Down below there is reticulations and band-like structures passing from mediastinum to the periphery. That too is common in sarcoidosis. And on the left hand side you can find random nodularity with some nodules sitting on the fissure. This is very, very important sign for sarcoidosis. On the left hand side you can see there's some sort of little bit of collapse consolidation with hilar adenopathy. In the center, pleural thickening, a little bit of effusion, and on the right hand side, random nodularity. This is called Milky Way sign, been seen in sarcoidosis. Well, if it is not sarcoidosis, then what it is? Is it HP? The next step is HP. HP is hypersensitivity pneumonitis. Is it chronic HP? Let me show you the classical signs of HP. The classical HRCT appearance of HP features upper lung predominance, but it can involve the lower lung also. And the pulmonary changes include ground glass opacities, poorly defined centrilobular nodules, lobular areas of decreased attenuation representing air trapping. What happens? The HP starts bronchocentric. It's a peribronchial pathology, granulomatous pathology to start with. So there is high risk of bronchial obstructions, and it leads to air trapping, and that air trapping is usually lobular air trapping. So let's see. This is a classical HP where you can find a lot of it is admixed. There are fibrosis of different kind, but in many areas you find the lobules being dilated and they are hyper. They are showing they are hypotense nodules. They are nodular areas. This mosaic kind of appearance, the lobular hypotensity, is classical of small area involvement as it is seen in HP. This is typical HP pattern. The diffuse interstitial fibrosis actually and relatively spared lower lung zones. This is also important. If you find this juxtadiaphragmatic area is spared, it is very suggestive of HP, as well as marked mosaic attenuation in a predominantly caudal distribution. This is probably UIP. Here you can find a lot of honeycombing, but those features of small area obstruction and lobular, air trapping are there. So this is also HP, a little progressed disease. We can call it progressive pulmonary fibrosis from HP. And this is unlikely HP. You find a lot of findings, but hardly any air trapping in lobular distribution. So if you find lobular distribution and air trapping, even in advanced fibrosis, you can think of HP. This is one patient of HP. I will show you chronologically. This is the next after 6 months, and this patient came back to me after 3 years. How it has been changed from basically some interlobular septal thickening, some small areas of organizing density. It has been a lot more areas showing little bit of air trapping and some places forming cysts, and here a lot of cysts, lot of fibrosis, but no honeycombing and pleural base thickenings. Well, if it is HP, fine. First we have seen UIP, non-UIP. If non-UIP, sarcoid, non-sarcoid. If non-sarcoid, is it HP? No, it's not HP. So what it is? It may be CTD-ILD or collagen vascular disease related ILD. I told you that pleural pericardial reaction, rheumatoid nodules and other changes can be very pathognomonic at times. Well, I'll show you some of the signs, but the central shadow shows a big dilated esophagus, which gives clue to a systemic sclerosis. And in the central shadow, you can see picture like honeycombing. It is actually exuberant bronchiolectasis or bronchiectasis, exuberant bronchiectasis. This is called four corner sign, anterior upper lobe signs on the left hand side, and on the right side you find the shadows are there, the abnormalities there on the four corners. This is called four corner signs. These are classical of CTD-ILD. You can see the involvement which is predominantly in the lower zone, and as if there is a sharp line which demarcates the normal lung or the rest of the lung with this involved lung. This is called sharp edge sign, which is also very pathognomonic of collagen vascular disease related ILD. Well, I have shown you some signs. I have not shown you any pericardial or pleural effusion. You have to look for it. If they are there, think of collagen vascular disease and investigate the patient in that line. If you don't find that, then what could be possibilities? Then you look for certain specific signs. These specific signs may be a crazy paving for pulmonary alveolar proteinosis, maybe PMF changes seen in colorectal pneumoconiosis, or maybe eggshell calcification like in silicosis, or certain specific signs for asbestosis. They are all in the list of ILD, although they are seen much less in frequency. On the right upper corner, you can see a lung and a mediastinal window. See, there are big mass-like structures. When you cannot, find this explanation of such mass-like structures and calcification, please keep in mind this could be colorectal pneumoconiosis, progressive massive fibrosis. I was wondering once with a patient, and later it came to my mind. It happened to be a case of progressive massive fibrosis. And in the bottom you can see the crazy paving, which is classical of pulmonary alveolar proteinosis. Here you can see the PAS staining, which is quite evident. Well, the left hand side is pleuroparenchymal fibroelastosis. There's a cap-like structure on the tip, on the top of the lungs. These caps can extend to a good length into the middle zone and even maybe somewhere in the lower zones. And on the right side, you can see subpleural asbestosis subpleural thickening with calcification, classical of asbestosis. And there are sometimes a subpleural thin line running along the pleura, and such lines, if present without any reason, is a very, very pathognomonic of asbestosis. These are silicosis and progressive massive fibrosis. So I have shown you how you can approach an HRCT to understand the etiology of a particular ILD. After that, the rest is, once you are lost, you cannot do anything. Now you have to depend on multidisciplinary discussion. That will guide you what to do, whether you give a diagnostic stamp on it or go for a further invasive investigations. So this is the scheme altogether. I will end with a little bit of advancement information. These two things are coming in the way of understanding DPLD. One is optical coherence tomography, and the other is confocal laser endomicroscopy in pulmonary diseases. Many of you may not have heard about it. This is optical coherence tomography. Here you can see OCT is used in ophthalmology very frequently, but it can be used through bronchoscope, and we can actually we can see layer by layer the changes around the bronchus, and it matches with the histology quite well. Although you cannot make histological picture. In between there was a term called micro CT. Micro CT was done in resected section of the lung, but somehow it has not been popular so far. It gives a very good idea and clear-cut image of the alveoli and other structures, but it is possible only on sections of the lung. But the other one, the confocal laser endomicroscopy, has got tremendous prospect. Here you can see from left to right. When you see in CT is 0.5 millimeter diameter. Smaller than that we cannot see in our eyes. But if you go for this laser endomicroscopy, you can see plus minus structures with plus minus 100 micron diameter. And this is what it looks like in a patient of DPLD. You can see the alveolar membranes and some cells within these alveolar spaces. So this is what about my approach. This is my favorite slide because image is something which is sometimes more beautiful, more fascinating than actual image. So thank you very much.
So two very enthralling presentations by Dr. Milind and Dr. Parthasarathi Bhattacharya, giving us a vivid idea about how to deal and how to approach our interstitial lung diseases. Our next speaker is Dr. Shona Ghosh. Hi. So he will be talking about CTD-ILD evaluation, the science and the art. He's presently working in CMRI hospital.
That's right. Thank you, dear Chairperson, and thank you, Dr. Bhattacharya, for giving me this opportunity. When he called me up with the topic of this talk, he told me that I have to make it interesting. This is a grateful moment for me that I can present this to a forum of pulmonologists, because we always want MDD, which has been talked about through the morning, multidisciplinary discussion. The first thing that came to my mind when I thought of science and art together were artists, scientists like Leonardo da Vinci and Michelangelo. So you have on screen famous painting on the ceiling of the Sistine Chapel, The Creation of Adam. And for most of you who know about this painting, you will notice that the painting of God on the right hand side touching Adam, that has the accurate anatomical details of a human brain. So with this, I went one step ahead and thought of how do I divide my talk into the following headings. Science, which has to do with what I think, evidence-based facts, and the art, going by feel. And my talk comes at a very opportune moment where Dr. Bhattacharya has already made things easy by describing the CT findings. I won't be spending time on that. And Dr. Talwar and Dr. Kumar discussed a case which was very confusing, whether it was CTD, whether it was tuberculosis, finally histoplasmosis. So science asks these questions. What is the burden of CTD-ILD among the ILD population? How do they present? What are the risk factors for progression of lung disease in connective tissue disorders? How do you diagnose them? How do you monitor them on follow-up? And the last part, beyond the scope of my talk, as the next speaker will speak about the treatment. And the art, more confusing. Is CTD really the cause of ILD even in a known case of CTD? Is dyspnea only due to ILD or some other causes? What is the concept of IPAF has been touched about a little bit. The timing of evaluation and follow-up, and very interesting, interpreting radiology. First part, burden of CTD-ILD. You must have been seeing this chart over and over again, not going into the details except 2 points. This is after the 2013 update where they have described in detail how to classify or diagnose hypersensitive pneumonitis and the subtypes of IIP. So the subgroups keep increasing, but I am interested in the top left-hand corner, connective tissue diseases. Yeah. This paper also, it's an honor to share the forum with some of the authors of this paper, where in India, locally relevant population, it was tried to find out across 27 centers in 19 cities, over 1,000 patients, what are the causes of ILD. So among all the ILD patients, just focusing on data relevant to my talk, CTD-ILD comes second highest, about 14%. And interestingly, HP comes to the highest prevalence proportionally, 47%, but this has been described in the paper. This comes after how to define HP. So older papers may have slightly different prevalence values, but still between 7 to 35% of ILD is due to CTD-ILD in most studies. And salient points of this study show that the proportion of CTD-ILD, usually female predominant, there might be a mean diagnostic delay of 5 years. These patients usually have a lower prior history of TB. Commonest CTD happens to be rheumatoid arthritis, closely followed by systemic sclerosis in this population. And on HRCT, as Dr. Bhattacharya showed us, NSIP happens to be the commonest radiographic presentation, followed by the UIP pattern. Now, a little more details. This is about pulmonologists diagnosing ILD, what proportion I might be called in for, how many of them have connective tissue disorder, what about my end from the rheumatologist perspective. So among our autoimmune diseases, very obvious winners, scleroderma, systemic sclerosis, and something called antisynthetase syndrome, a myositis subtype of presentation. I'll show that in detail as well. These two have relatively highest proportions of patients developing interstitial lung disease. RA on the spectrum, relatively lower. However, in most studies of ILD, it turns out that rheumatoid arthritis associated ILD is the commonest proportion. Why? Because as it is quite obvious, prevalence wise, RA is far more common than any of these other rarer entities, and that's why taking the denominator as 5 times, 6 times, 60 times more common, even 10% of RA is higher in number than, let's say, 70% of systemic sclerosis patients. Once you know the burden of disease in population, so about 1/5, 20% of ILD may be due to autoimmune diseases. How do they present? The various obvious modes of presentation and why they are important I'll explain in the new slide. So ILD developing first, nothing else has appeared yet. Rare but may happen. So rapidly progressive ILD, antisynthetase syndrome. ILD comes up, clinical features, radiologic features, at the same time other autoimmune features are developing. Like in lupus, myositis, everything happens together. And finally, easiest, pre-existing chronic rheumatic disease like rheumatoid arthritis, now developing features of ILD. And why it's important to distinguish this is, pre-existing CTD, relatively easy to establish the diagnosis. Seropositive disease, long-standing deformities, now having progressively worsening, shortness of breath, cough. Maybe it is due to the underlying disease itself. But when the two things appear together, some autoimmune features ILD, what do? Testing, diagnostic evaluation. I will explain that in details. The worst part is if ILD comes up first, you think this is idiopathic IP, interstitial pneumonia, without CTD features, and then you have to keep following them up, evaluate, follow up, to see if other autoimmune disease features develop or not. So these two you need evaluation for, but for the first one, it's relatively easier. How to diagnose CTD-ILD? Most things have been covered. We have talked about the usual suspects. So I will discuss more about the clinical features and serologic testing. Very confusing, so many autoantibodies, while HRCT findings, pulmonary function tests, lung biopsy are things which all of you know much more than I can ever describe in detail. So looking at the clinical features, I always try to follow the dictum, look beyond the lungs to find out what is going wrong with the lungs. And examples of that, so if you have a patient with symmetric polyarthritis, joint pain, swelling for several years, slowly developing shortness of breath, cough, okay, you might think first differential diagnosis might be rheumatoid arthritis associated ILD. On the other hand, skin manifestations, skin tightening, thickening, Raynaud's, skin ulcer, esophageal reflux, server showing us features of dilated esophagus, also having shortness of breath, cough, maybe scleroderma, systemic sclerosis, or mixed connective tissue disorder like presentations, and sometimes like a bomb blast, everything is happening together. Sudden onset, muscle weakness, rash, fever, joint pain, pleural effusion, might be something like myositis or lupus-like diseases. These are just some photos for pure interest. So rashes, malar rashes, not just lupus, may also happen in dermatomyositis or the antisynthetase syndromes. Mechanics hands, I'll show you in the subsequent slides. Some Gottron's papules for myositis, sclerodactyly or digital ulcers, arthritis, oral ulcers, muscle weakness. Any organ can be involved. And Dr. Talwar said it very well. It's difficult sometimes just to say A plus B plus C is an accurate depiction of D. So what is this antisynthetase syndrome? As most of you know, so mechanics hands is nothing but the presentation of fissuring of the fingertips or the lateral aspect of the hands in patients who may have rapidly progressive ILD with or without muscle weakness, sometimes with arthritis, and usually you need serologic evidence. What is that serologic evidence? I'll come to in the subsequent slides. It's important because these diseases progress rapidly unless you treat them early. Serology tests. Dr. Milind was already showing us the IPAF, so many serologic tests. Before looking at the chart of tests, I want to say that it's so difficult to interpret serology properly. So I will order everything under the sun. ANA, rheumatoid factor, anti-CCP, ANCA profile, myositis profile, this profile, that profile. And now the report comes after 3 days, PMSCL positive. What do? I don't know. There is no answer for just autoantibody positivity. And if you look at studies, even in idiopathic pulmonary fibrosis, studies show that 30 to 40% patients may be ANA positive, although they have IPF, no CTD features. So interpreting this is a tale of caution. There are two questions that arise from this. Number one, so does serology, autoantibodies, these things that we rheumatologists love to confuse people with, is it at all important to predict ILD as a risk factor for development of ILD? And does it help in diagnosis of ILD? So let's look at each of them step by step. What are the risk factors? There was a wonderful ERS paper this year. It was a systematic review and meta-analysis by Dr. Joy and colleagues about the prevalence and risk factors. Who will develop ILD among all these connective tissue disorders? And how will they progress? So if you look at the clinical, demographic and serologic features, in RA, for example, seropositive disease, high titer seropositivity seems to be a risk factor for development of interstitial lung disease and progression. Similarly, older age, longer disease duration for RA. These do happen to be prognostically important for future development of lung disease. In scleroderma, on the other hand, you have anti-SCL70 positivity or anti-topoisomerase 1 as it's reported in some labs, with anticentromere absence. So anticentromere negative but SCL positive disease, African population, but look at this, very interesting, opposite from RA, earlier duration, so shorter duration of systemic sclerosis. These patients are at higher risk. So yes, serology is important if you take the background of clinical and demographic details also. So for inflammatory myositis, these are the antisynthetase antibodies I was referring to, Jo1, PL7, PL12, MDF5. They may have rapid progression of lung disease, while some others, like look at anti-MI2, may not have this sort of an aggressive ILD. Just a chart to highlight why serology might be important for prognosis. Very important slide I always talk about. ANA need not be positive even if certain ANA profile antibodies come out positive. The reason being certain antigens, which are the targets, like all the antisynthetase antibodies have synthetases as the target, and Rho52, these are located in the cytoplasm. So unless the lab technician who reports this knows that nucleus going dull, but cytoplasm taking up the fluorescence on immunofluorescence microscopy is actually positive cytoplasmic antibody, this will be reported as ANA negative, although patient may have ANA profile, myositis profile, these profiles as positive. So this is important from an ILD point of view. What if it does not fit a CTD? So you have all these serological features. What do you do with them? And based on this, there was the controversial definition, 2015, ERS ATS, IPAF, interstitial pneumonia with autoimmune features. So if you take lung disease on a spectrum, idiopathic IPs on one end, idiopathic truly, absolute defined CTDs on the other end, you have a gray area in between. Certain autoimmune features, certain antibodies are positive, but the question is, why is it difficult? How do you treat them? And there has been no consensus statement for the treatment of IPAF. Certain features, ANA is positive, SCL70 positive, but no skin thickening, nothing. Some features of ILD, what do you do? So that is where the art of medicine and multidisciplinary discussion comes in. I will not be the right person to answer single-handedly. I will discuss with the radiologists, pathologists, pulmonologists before saying what is best for the patient. And Dr. Milind has shown us this already, not going into the details. You have some clinical features, so many serologic tests, or some morphological features, whether on histopathology or CT, to say that this is IPAF, and then follow up the patient to see, because more than half of these cases over a 10-year follow-up do develop some of the connective tissue disorder features. Imaging, my work is easy here, don't have to go in detail. So RA, ILD usually has a UIP pattern, usually, not always, while you might have systemic sclerosis disease presenting usually as the NSIP or even the fibrotic type of NSIP pattern. The extent of CT involvement at baseline, and mind you, all this data is taken mainly from the scleroderma studies. So most of the treatment modalities of CTD ILDs come from the scleroderma lung studies, scleroderma studies, etc. Very rarely studies have been done in lupus pneumonitis, myositis, except the antisynthetase syndrome. So this was a very nice paper, relatively older, by Dr. Go and colleagues, where the initial extent of CT involvement was divided into extensive and limited based on whether it was more than 20% or less than 20% of the lung field involved. If it was extensive disease, these are the patients who initially, if untreated, had the chance of worsening pulmonary fibrosis, drops in FVC as well, while limited disease may not progress. But like I said, in systemic sclerosis, the initial years are most important, so follow-up becomes very important. Secondly, and this was a very interesting paper, I had the good opportunity to sit in on Dr. Stephen Nathan's talk, who is the first author of this paper, about the problem with radiologic reporting. So this was a study where they took 50 patients and their CT scans, 5 expert independent blinded readers, divided the scans, diagnosed them on the basis of this, as on the 2018 paper that Dr. Milind was talking about, as UIP, probable UIP, indeterminate UIP, and alternative diagnosis. And look at this very funny heat map. So many differences. So it's difficult just based on one CT pattern to say that, oh, stamp, this is UIP pattern, this is NSIP, fibrotic. It is more difficult based on that stamp to say, oh, if it is UIP, if it looks like a duck, quacks like a duck, it must be due to a duck or RA. So multidisciplinary discussion is important. Secondly, there are so many papers, controversial data on whether ground glass opacity is always equal to active inflammation. It has not always been shown that ground glassing is there, treat with immunosuppressants, and then ground glassing goes away. Part of that may be inflammation, partly fibrosis, difficult to judge on one sitting. Follow up with PFT, look for other features beyond the lungs. That is what's important. I'm not going to describe the PFT in detail, but remember, not just FVC, always look for DLCO, because as sir pointed out, pulmonary hypertension may also be there in patients who have connective tissue disorder associated ILD. And for progressive disease, usually a fall of more than equal to 10% on a 6 to 12 month interval is taken as progressive disease. This is a very simple algorithm. It's not that simple always in reality about how to do PFTs and HRCT at baseline and follow up. If they are normal, you can have a yearly checkup. If they are abnormal, then like Dr. Go has said, extensive or limited disease, and that should judge whether you treat them immediately, whether you can wait for treatment, what about immunomodulators, etc. Just a highlight that dyspnea, even in a diagnosed case of CTD ILD, is not always due to ILD activity. So myositis patients, maybe there is respiratory muscle weakness, diaphragmatic palsy, in which case PFTs will show increased residual volume. It may not be due to an ILD activity. So you have to judge what to treat. Similarly, look for pH. FVC DLCO ratio of more than 1.6 is often used as a cutoff to differentiate pH or ILD causing dyspnea. There might be background COPD or asthma having an exacerbation. Might happen in any patient. Elderly patient with RA might happen. Pneumonia, always important to look for infection. No one has the guts to say that, okay, this is not due to infection and I will not give antibiotics, only give steroids. Most of us use a combination for this reason. And the acute interstitial pneumonias due to drugs, atypical infections, AIP picture, maybe steroids, oxygenation, ARDS picture goes away. All of them might not be a CTD ILD. Slight important points to just discuss. Coming to bowel and lung biopsy, nothing much else to say from my part except you don't need this to diagnose CTD ILD, but certain atypical features, high-grade fever, hemoptysis, weight loss, when you're looking for infections or malignancies, these become very, very important. Biopsies as well as a bronchoalveolar lavage. Finally, before I wrap up, I just want to share some of the experience we learned from experience. So when we looked at our data from my residency days at Medanta, these were some of the papers we published on our CTD ILDs. So coming to rheumatoid arthritis, we had about 130 patients. Very interesting, you look at this, of all the 23 patients with ILD, 100% were seropositive, which I was just discussing a few slides earlier. Seropositive long-standing disease, higher chance of ILD, and mean disease duration was also more. And this was only from a denominator of RA patients who had symptom duration more than 10 years. So with disease duration going up, higher chances of ILD developing, especially untreated seropositive disease with higher disease burden. Similarly, another study published this year in the Indian Journal of Dermatology from systemic sclerosis point of view, 106 patients, about half each, ILD without ILD. Look at some of the differences. Diffuse cutaneous scleroderma, significantly higher risk of having ILD. SCL70 positive, much more chance risk, but centromere antibody positive, higher chance of having no ILD. Small but important points of how to look at CTDs from all these perspectives. And finally, the paper published this year in Oxford Rheumatology, 139 patients of inflammatory myositis. We ran some of the antibodies and found out that yes, JO1 and RO52, significant association with developing ILD, but MDA5 PL7, high association of ILD, but so few in number in general that no statistical analysis was possible. So before I wrap up, these are my take-home points with an interesting and funny cartoon. CTD ILD may be the underlying cause of ILD in about 15 to 25% cases, as the studies have shown us. A proper clinical history examination of all systems is essential before understanding the relevance of serologic testing. Otherwise, just like this cartoon, we'll keep saying that there is an obvious knife injury on the back, and after exhaustive testing, I have narrowed down your cause to a knife injury on the back. The natural history of connective tissue disorders, very important in determining the natural progression of ILD in those connective tissue disorders. And early diagnosis is the key to management. Thank you.
A small announcement, a very interesting case presentation session is going on in Hall B. It will be followed by another very interesting session on mucus management, etc. So I'll request those who are interested can move to Hall B.
Thank you, Shunok, for a very different take on this CTD ILD. And thank you for bringing up this concept of multidisciplinary discussion. Yes, this is an extremely important part of ILD management. Speaking of management, we are now into the treatment part. We have Dr. Shaurin Bhuiya. He's from Bhubaneswar, AIMS Bhubaneswar. Welcome, sir. So he will be speaking on antifibrotics versus immunosuppressants. Can I have the presentation view? Well, thank you very much. A very good evening to all of you. At the outset, I would like to express my sincere thanks to Parthoda and the entire team of Pulmocon for inviting me to this. It is always a pleasure to be back at Pulmocon. And after these three fascinating talks, I have this daunting task of completing the management part in just 15 minutes. So already there is a lot of confusion, as my previous speakers have already expressed their in their session, in their talks, that there is a confusion, there is a wide heterogeneity of interstitial lung disease we are dealing with. There's a lot of confusion with diagnosis. Parthoda showed a very classical examples of the CT scans, but practically when it comes to our day-to-day management, there is always a confusion. There is always overlap of features, so there is always a confusion. And a lot of serological tests are there, which one to advise, which is not, how to interpret it. And finally, coming to the management part, when to give, how long to give the immunosuppressants, when to start the antifibrotics. So a lot of confusion is there. So I will just try to keep it very simple and short, because we all are treating ILD day in and day out. So I think from the management point of view, it is very important that we classify, we try to remember that what is the cause, and depending upon the cause, we can think about the treatment, whether it is idiopathic, then or whether it is autoimmune, or there is or it is related to some kind of exposures which can be removed, so that that is the first and foremost important point, where they are related to the exposures. So this is a very simplified form where we should keep in mind, before going for the treatment part. Then before going to the treatment, I think it's really important to understand the pathogenesis, what is going inside. So just a minute. So as you can see, so there is a repeated injury. The environmental antigens, repeated injury by the environmental antigens. Then there is a genetic susceptibility. Then also we have the activated immune system. So based upon this, then there is the inflammation going on. Then that will lead to the endothelial activation, and then this injury and the repair process goes on and on. Then if there is a defect in the repair process, the aberrant repair process, that leads to the progression of the fibrosis, and this is how a typical ILD case progresses. Now this is again a very simplified slide, which I like very much, because we have got this two spectrum of interstitial lung disease here. On one hand, we have got this predominantly inflammatory diseases. On the other hand, we have the idiopathic mode, the fibrotic diseases. So here the antifibrotics will be more effective, whereas here the immunosuppressants may be more effective. So coming to the immunosuppressants in interstitial lung disease. So let us first look at the best published evidences on immunosuppressants, which give us, based upon which we form our treatment policies. So this was a review published in 2022, where the efficacy of different immunosuppressants have been summarized very nicely. In prednisolone, I think there is improvement in FVC, in eosinophilic pneumonia, sarcoidosis, and hypersensitive pneumonitis, the non-fibrotic part. But it has been found to be detrimental decline in FVC in case of systemic sclerosis related ILD. And also we know that it can induce the renal crisis. So we have to be very careful. Whenever a diagnosis of systemic sclerosis is made, then steroid is really contraindicated. Coming to mycophenolate mofetil, again there is improvement in FVC and improvement in DLCO in systemic sclerosis, hypersensitive pneumonitis, CTD, ILD. But sarcoidosis, it has not been shown to, there has not been any improvement in the decline in the FVC and DLCO. Coming to azathioprine, again, in case of HP, there is a decline in FVC, but an improvement in DLCO, but sarcoidosis, CTD, ILD, and systemic sclerosis, there has been improvement in the lung functions. Methotrexate also, there is an improvement in sarcoidosis and RA-ILD. Cyclophosphamide, systemic sclerosis, NSIP, there has been improvement and stabilization of the lung function. And coming to rituximab, the monoclonal antibody, the systemic sclerosis, sarcoidosis, CTD-ILD, RA-ILD, everywhere there has been improvement. So if we look at the level of evidence, so as my previous speaker told, there has been always, the most of the studies were in the systemic sclerosis, so all well-designed studies, so it is always a grade 1 evidence in case of systemic sclerosis. Now, coming to the treatment, so far as the type of ILD is concerned, if you look at the CTD-ILD or the IPAF, so prednisolone is always started as the first line. Then we have got MMF, azathioprine, and rituximab. In case of systemic sclerosis ILD, again MMF as the first line. Then we have the cyclophosphamide, rituximab, and tocilizumab also is indicated as third line. Vascular dermatomyositis, hypoxemic respiratory failure, again there is a role of pulse methylprednisolone as the first line. Then we have cyclophosphamide, rituximab, and azathioprine. When it comes to NSIP, again prednisolone as the first line, MMF, azathioprine, and cyclophosphamide. HP, again in the non-fibrotic part, the prednisolone is a very good, and as the first line we use chronic HP, MMF. Sarcoidosis, again prednisolone and methotrexate are the most widely used immunosuppressants. Fibrosing organizing pneumonia, again prednisolone, MMF, and cyclophosphamide. Eosinophilic pneumonia, we know it's always steroid. Now, which are the conditions? Increased likelihood of benefit after prolonged therapy with immunosuppressants. So these are the conditions organizing, whenever there is any organizing pneumonia pattern or the NSIP patterns, myositis ILD, younger age, where there is predominant inflammation, though they are more likely to respond to immunosuppressants. Where there are non-pulmonary symptoms that flare up on stoppage of previous objective response to corticosteroids and or immunosuppressive therapy in the disease course, then also they respond more to immunosuppressive. Whereas if we find any UIP pattern, older age, where there are evidence of recurrent infections, absence of clinical physiological improvement with increased risk of side effects, we should be very cautious with the immunosuppressants. Now, recently the American College of Rheumatology, they have come up with this, the guideline summary regarding the treatment of ILD in people with systemic autoimmune rheumatic disease. So as per their recommendation is, whenever we come across any SARD ILD, the first line of therapy, it is always mycophenolate across the CTDs, the systemic sclerosis, myositis, mixed connective tissue disorders, rheumatoid arthritis, Sjogren, it is always mycophenolate is the first line therapy. Then mycophenolate, azathioprine, and rituximab. These are the three immunosuppressants which are usually recommended in that chronological order. That is the hierarchy, 1, 2, and 3. And also the additional agents, there can be cyclophosphamide. In systemic sclerosis, as I have already told, there is a strong recommendation against glucocorticoids. But in the other CTD ILDs, there can be short-term glucocorticoids can be prescribed initially, after which we usually taper off, substituting with the steroid-sparing agents. Then the recommendation, whenever there is progression despite the first-line treatment, then again the mycophenolate, rituximab, nintedanib has been adopted here, and cyclophosphamide. These are the order in which it is recommended. And again, there is a strong contraindication for glucocorticoids. In all these conditions, the long-term glucocorticoids is not recommended. Always we start with a short course of glucocorticoids, then we try to taper off, substituting with the steroid-sparing agents. And then, of course, if we see that patients are not improving, we have to line list the patients for lung transplant. Now, coming to the antifibrotics, so we all know the role is very much well established in case of idiopathic pulmonary fibrosis. We have been using for years now. based upon the capacity and the ASCENT trials in case of pirfenidone and the tomorrow impulses 1 and impulses 2 trials in case of nintedanib, there has been a significant reduction in the deterioration of the lung function. And also there has been a trial, the InJourney trial. It was a very short trial where both the drugs were tried, and it was shown that when both the drugs were used together, there was a significant more decrease in the decline of the lung function. I know this slide was shown by Dr. Milind also. So this concept of this progressive pulmonary fibrosis has not now come up. So as per the ATS definition, 2 or more of the 3 criteria has to be present for progressive pulmonary fibrosis: worsening of the respiratory symptoms, the radiologic progression of the fibrosis, and absolute fall in 5% of the FVC and 10% of or more of DLCO. So these are the group of interstitial lung disease where you can see the proportion of the disease which falls in this circle. The more there is a significant proportion of CTD ILD. Then we have got the unclassified interstitial lung disease. Then we have a small part of drug-induced lung disease, and also the chronic HP takes a bigger chunk, and we have got idiopathic NSIP. So these diseases they have been found to progress and behave in a common single the modality of fibrosis, so that they can be treated as a single entity called the progressive pulmonary fibrosis. Now, coming to the drugs, how the drugs act in case of progressive pulmonary fibrosis, as I had told, there are the repeated alveolar and epithelial injury is there. Then the fibroblasts, they are recruited. Fibroblasts, they get converted to myofibroblast, and ultimately there are the extracellular matrix. The collagen deposition is there. So the mediators which facilitate this pathogenesis, all the growth factors, the patellar growth factors, the vascular endothelial growth factors, and the fibroblast growth factors. So the nintedanib acts in these growth factors, and the TNF alpha and TGF alpha, the pirfenidone is the drug which is acting here. Now, what is the rationale of antifibrotics in this progressive fibrosing interstitial lung disease? So the pro-fibrotic mediators are elevated in both IPF as well as the progressively fibrosing ILD. So the mediators are the same, and also it has been seen that the genetic variants are also similar, like the MUC5B gene, the TOLIP polymorphism, and the mutations in the telomerase complex genes. So this concept of treating the progressive fibrosing ILD with the antifibrotics also has come up. Now, coming to the some of the trials based upon which the recommendation of nintedanib and pirfenidone is there. We know there is the tomorrow trial, the impulses trial. They have been on the patients of IPF. So all of them have found that there is a decline in the there is a improvement in the rate of decline of FVC. Coming to the studies on nintedanib, there is the SENSIS trial and the INBUILD trial. The SENSIS trial was on patients of systemic sclerosis ILD who are currently taking mycophenolate. So they have also found the annual rate of decline in FVC was 52 ml, whereas in case of nintedanib, whereas in placebo it was 93.3 ml. This was the primary outcome. And in the INBUILD trial, based upon which the PPF treatment has been devised, the nintedanib, again 150 milligram twice a day versus placebo. Then 663 patients with fibrosing lung disease on HRCT. The decline in FVC was 80.8 ml per year with nintedanib, whereas it was 187.8 ml per year in case of placebo. Now, in case of pirfenidone, we know the capacity trial for in case of IPF, again there was a significant improvement in the decline of FVC. Also, there was the ASCENT trial with pirfenidone, where in case of IPF, which showed the similar results. Then there was the RELIEF trial with pirfenidone, where patients of progressive fibrosing ILD, based upon which again recommended pirfenidone was approved by FDA for PPF. Then we have got this in-journey trial about which I have told previously. So based upon all these landmark trials, the recommendation of pirfenidone and nintedanib have been there for progressive pulmonary fibrosis. I think this slide was shown by Dr. Milind also. So there is no head-to-head trial between pirfenidone and nintedanib regarding which is more efficacious. I think both are equally efficacious. We have, but there have been some drawbacks based upon other factors, like the pill burden is more in case of pirfenidone, and in case of when it comes to the adverse effects, nausea, weight loss, and photosensitivity is more in case of pirfenidone. And nintedanib is the more likely to cause diarrhea and weight loss and elevated liver enzymes. So suppose the patient has got outdoor job, then we can choose to give nintedanib, because pirfenidone may cause more photosensitivity in such patients. If patient is on anticoagulation therapy, we can choose to give pirfenidone. Ischemic heart disease, again pirfenidone. Then but the quality of impact on the quality of life and the prevention of acute exacerbation or respiratory related hospitalization have been similar in case of both nintedanib and pirfenidone. So to summarize, so it is very important that we correctly identify the type of ILD at the first diagnosis, because that is going to direct our management part, how to approach the diagnosis and how to treat the patient. Then long-term corticosteroids is more harmful than beneficial, as all the studies have shown. It's always we start with steroids and we gradually taper off with the steroid sparing agents, and then there has been no standardized treatment regimen for any ILD. It is always case to case and disease by disease approach. You have to there is no one size fits all strategy for treatment of any case of ILD. And last but not the least, multidisciplinary discussion is very much essential before initiating any treatment. Thank you very much. Thank you, Dr. Bhuiya, about for giving us this very clear-cut, what do you say, approach to the treatment of ILD. I'll just spend 10 minutes, just 10 minutes over the question answer session. Somehow I am left with only two panelists for answering the questions.
I also am a diabetologist. So what I want to tell you is that I found that since he has found a relation with rheumatoid arthritis factor, I have found that RA is more common in patients who are CCP positive. Is there any study with CCP? I just want to know.
Yeah,
Is
so
there any?
I'm sure Dr. Shonak, he's pretty enthusiastic about the question.
There are studies of both RF rheumatoid factor. There is no thing called an RF factor. I always try to bring this up. Nothing called an RF factor. Rheumatoid factor, it may be present in so many conditions, not just RF. And anti-CCP positivity is associated with ILD. The problem with CCP is smoking is a very, very badly confounding factor for the development of citrullinated proteins. So there are so many patients who have lung changes, who have rheumatoid arthritis, are CCP positive. It becomes difficult to say whether this is ILD due to rheumatoid arthritis activity, whether they are smoking related changes, where CCP will be positive in both. So much so that patient with joint pains but not real arthritis, CCP positive, we poke the patient and ask, smoker, are you a smoker? That might explain CCP. So there are studies, but it's not as easily put out there as rheumatoid factor positive versus negative studies are there. Yes, CCP is. That's why the studies, it's difficult to put them out. So many of them have smoking as a confounding factor.
What I found is that most of the drugs which sir mentioned, most of the drugs are those drugs which we always use in rheumatoid arthritis, which is
Drugs causing what? ILD.
No. He mentioned those drugs as treatment for ILD.
Yes.
But most of the drugs are also the same drugs. Most of them, almost all of them, are the same drugs which are used for rheumatoid arthritis in complicated cases or not, who are not responding to the normal drugs. That is why I wanted to tell this.
Yes, so those are the patients, if they are properly treated with medications for rheumatoid, there is a less chance of them developing ILD also. That has been proven. There is a much less chance of that.
Thank you.
I see Dr. Milind coming back. So there's one question I would direct to you. Which of your ILD patients will you confidently refer for lung transplantation and why?
All right. So the first thing I would consider is resources for the patient. Not only the initial cost, but whether they will be able to sustain the, if at all, any post-operative complications, infections, and the drugs required, they should be able to sustain that as well. That was, I mean, real practical thing. But obviously, younger patients, rapidly progressive diseases, preserved, as in not developed significant severe pulmonary hypertension, yeah, pretty much these patients I would refer.
And I'm sure we would refer all our progressive fibrosing, the fibrosing subtypes of the ILDs for.
Yes, who are on, despite optimum treatment, who are worsening, developing severe severe impairment in lung functions. Yes.
Is there any particular subset of ILD patients you wouldn't want lung transplant at all? You have diagnosed that patient with a particular diagnosis and you think that you're never going to ever think of lung transplant in those kinds of patients. Any kind of subset?
Age would be a significant factor there. Beyond 65, 70, I would let the patient be aware of the options. It's a number actually, but the physiological age of the patient would be an important factor there. Apart from that, if the patient is worsening, I don't see any particular reason why patient should not be referred.
Okay. So, Parthoda just asked me to find out if all the speakers for the next session are here. So it's sort of a presence. Yeah. So Dr. Shudeep Ghosh, he's there, and Dr. Shumit Sarma, I see he's there. Dr. Shoibal Moitra is also there. Dev Konna De, she's here, and Dr. Shumit Sengupta, I saw him just. Oh, there. Yes. Shayanti Kormakar. She'll come. And Dr. Arindam Mukherjee. He's here. Okay. So one quick question to Parthoda. How sensitive would one be about the diagnosis of ILA?
Oh, one should be very sensitive. Basically, peripheral ILS, fibrotic type of ILS, one should be really sensitive because these patients are going to be a problem in future. So IL is a new term where it's now sort of pre-ILD situation. You find different kinds of shadows in HRCT chest, which are going to be either turning to florid ILD or they can regress. Peripheral fibrotic ILS are bad ILS. They should be picked up early and should be given treatment. According to my opinion, given treatment, not just observation. But so we start with the next session. May I request Dr. Shoibal Moitra to coordinate the session on small error disease. I'll request Dr. Moitra to stick to time so that we can find time for 2 lectures after that, which I have shifted from hall 2 to this hall because hall 2 has got a very sparse presence of delegates. And I will request all the speakers to stick to time and finish it in time. Okay.
Thank you, Parthoda. I would like to thank the organizing committee and IPCR Pulmocon to invite me to this is really well known and acclaimed conference from this part of the country. Now it's a national event. Okay. So this workshop on the small airway disease is gaining more significance day by day. See, after you all know, after this bold study came, so then there was a huge noise all over the world, okay, about this silent zone of the lungs. That is silent zone of the lung now creating a huge noise. Okay. Why it is so? Because just now you have heard about the ILAs. So taking an analogy from that, the ILAs going into an ILD. So similarly, a small airway disease going into a florid, an obstructive airway or restrictive airway diseases, or maybe it's a different phenotype. So we would be discussing all these aspects today in this very important, exciting workshop. So for that, I would like to, there are a series of lectures and we'll have a group discussion. I will take the questions and from all of you. So let's start with the first talk, which will be given, which is on small airways, structure and functional importance, and also detection measurement of the small airway dysfunction by Dr. Sudeep Ghosh. Yes.
Good afternoon, everybody. So thank you to the organizing committee for inviting me to this conference. So my topic is small airways, structure and functional importance, and the second part is how to detect small airway abnormality. So I would like to cover under the following headings. First, little bit about anatomy, then functional importance, and then clinical importance. So as you all know, what is small airways? Small airways are airways which are defined as a less than 2 millimeter diameter. And if we look at the airway generations from 1 to 23, small airways are airways beyond 8 generations, and it includes both conducting and respiratory zones. These small airways constitute most of the lung volume, nearly about 98%. If we look at the small airways anatomy, it is little bit different from the large airways because it's lack cartilage and submucosal gland, and goblet cells are very rare in small airways, but the secretory cells of the small airways are club cells, and airway smooth muscles are not present everywhere in the small airways, but it's present up to the terminal airways, terminal bronchioles. And there is a change in respiratory epithelium within the small airways. Up to the terminal bronchioles, it's cuboidal epithelium cells, but from the respiratory bronchioles to the distal part, it's a squamous epithelium. Now, if we look at the functional part of the small airways, as Sir already told, is a silent zone which is causing more noise. Why it is silent? Because here airflow is laminar flow. And why so? Because the diameter is the individual diameter of an individual airway is very small, but they act as a unit. So the total functional cross-sectional diameter is huge compared to large airways, and the transition point is 6 to 8 generation. If you look at the graph, that as the cross-sectional areas are increasing beyond the 6th or 8th generation of bronchioles, the resistance is gradually falling beyond 6 to 8 generations and nearly negligible at the level of 20 to 23rd generations of airways. So why small airways is important? Why we are looking at the small airways? Because many diseases can involve small airways. The most important is asthma. Our classical teaching is asthma. COPD is morely as a small airway disease. Asthma is a large airway disease predominantly. But the recent studies and the Atlantis studies showed that the 50 to 60% of the asthma cases can involve small airways, and it is associated with poor function, severity, and exacerbation risk. Similarly, many ILDs, the commonly hypersensitive pneumonitis, sarcoidosis, and the rheumatoid arthritis can involve the bronchioles or bronchiolitis. So ILDs may also involve these small airways. And these small airway diseases can progress silently because the normal spirometry, what we do to diagnose a airway disease or a restrictive lung disease, may be normal in the initial phase of small airway diseases, because we need to have 75% loss of small airways to detect abnormality in a normal spirometry. So there are many tests which can be used for detection of small airways, like our normal regular spirometry, body box, nitrogen washout testing, IOS or FOT, and CT scan. But we have to also remember that the prevalence or the detection changes with the method used for detection of small airways. So the different spirometric data are evaluated for detection of small airways, like FEV1, which is not a very good parameter for small airway detection because it largely depends on larger airway obstruction. Other is the FEF 2575, which is a expiratory flow in the 25 to 70% of 75% of the vital capacity, which is a very effortless zone of your expiratory flow. But again, this FEF 2075, if it is less than 60 to 65%, then it is considered as abnormal. And if there is a 25% reversibility, then it is considered as a significant reversibility in FEF 25-70%. Similarly, FEV3 by FVC and 1 minus FEV3 FVC is also used as a marker for this detection of small airway disease from a normal spirometry. But these spirometric parameters are having lots of disadvantages, like it's effort dependent, it's not physiological. So it depends on FVC. If FVC is low, automatically your values of FEV1 and FEV 20-75% is going to be low. It's a poor reproducibility. It changes from patient to patient. And the FEF 25-75% value is not very much significant of small airway disease if your FEV1 by FVC ratio is more than 75%. The another thing which term the PRISM in spirometry, that is a preserve ratio impaired spirometry, where your FEF 25-75 and the other test may help in diagnosis or detection of small airway early. The next important tool for assessing our small airways are body box, where we can detect your lung volumes like residual volume and total lung capacity. Also can detect our resistance of the airways. But as the small airways are involved, there is a risk of air trapping, so that will increase your residual volume and also total lung capacity. So the RV-TLC ratio is usually increased in airway obstruction disease. Similarly, the resistance is going to be increased in airway obstruction, but again, it's effort dependent and not specific to small airways. Another important test for diagnosing is a nitrogen washout test, where if you look at the curve, it is after inhaling 100% oxygen, when patients exhaled nitrogen, nitrogen was analyzed, and this curve can be obtained, the phase 1, phase 2, phase 3, and phase 4. The important parameters which can be seen from this curve are the percentage of nitrogen between 750 to 1250 ml of vital capacity. The normal value is less than 1%, 1.5%, but it usually increases in small airway diseases. Similarly, slope of phase 3 also it's going to be increased in small airway disease. If there is your small airways are obstructed, there is a chance there will be increase in closing volume and closing capacity. So increased closing volume and closing capacity is again a feature of obstructive airway diseases. But this is this test is not available in everywhere. It's basically a research center based test. Now another most important, which we are going to use more and more in diagnosis of small airway disease, is of IOS or FOT, where we give multiple or different low and high frequency sound waves and we measure the impedance. And this impedance then calculated in two parts. One is resistance, one is reactance. And if we look at this picture, the resistance in a healthy individual is frequency independent. But on the other hand, reactance is a frequency dependent. The negative part of the reactance curve is came from your capacitance, and the part of the positive part is come from the inertance of the lung parenchyma lung. So we can look at resistance at different, we can look at the resistance in different frequencies like high frequency and low frequency, the 5 Hz and 20 Hz, and again we can calculate the area of reactance and X5. So what will be the change in airway diseases? So if we look at the higher frequencies traverse less and the smaller frequencies traverse more. So the higher frequencies are only look at the larger airways, and the smaller frequencies looks at both the larger and small airways. The difference between the R5 and R20 specifically looks at small airways. Now this is a graphical representation of what should be your curves looks like in different conditions like small airways abnormalities, isolated small airway, combined small and large airways, and the large airways. So in isolated small airways, your R5 will be high, but your R20 will be normal. So the curve will be like this. In isolated large airways, both R5 and R20 will be high. This is a normal blue line. R5 and R20 is high, but the difference between R5 and R20 is normal. Similarly, in airway diseases, your X5, that's a reactance at 5 Hz, will be more negative, and the frequency resonance point will be shifted to the right. The frequency resonance point will be shifted to the right, so the area of reactance will be more in small airway abnormality. So by this we can detect the airways abnormality, and by this test we can also detect the bronchodilator response. There is a recommended threshold for positive bronchodilator response in FOT. You should have 40% decrease in R5, that is resistance and 5 Hz, with a 50% improvement in XRS, that is your X5, that will be more positive or less negative, and the 80% decrease in your area of reactance. But again, this test is a newly upcoming test. It's effort independent. It can be easily done in children also, but the issue is predictive value. There are few studies, and normal values are method dependent, because if you use the FOT, if you use iOS, the normal value may change, and there is a lack of standardization in FOT and iOS testing. So after if you able to detect the small airway disease, the next important is how to treat. Before treating, we should know the receptor distribution, because we are going to treat with inhalers of beta agonist, steroid, and muscarinic antagonist. So if we look at the receptor distribution in the peripheral or smaller airways, beta adrenergic receptors are present everywhere from the large and small airways, but the cholinergic receptors are most abundant in larger airways, but very few in small airways. But there is some cholinergic receptors which are not supplied by the cholinergic nerves on epithelial cells of the epithelium of the distal airways also, which that acetate is secreted from epithelial cells and can act on smooth muscles of small airways. Glucocorticoid receptors are present on many cells, including epithelium, inflammatory markers everywhere from the large and small airways. The another important issue in managing the small airway diseases is drug depositions, because we know if we want to give inhalation medicines through by any route of inhalation medicines, the most important thing about inhalation medicine, drug deposition in our desired area. This is a well-known thing, that's if your mass median diameter is more than 10 micrometer, those are filtered in nose and upper oral cavity, throat. The mass median diameter of your inhaled particles should be between less than 5 millimeter to 0.5 millimeter to be deposited in airways. But if we look at the this study or graph, it shows that if your particle size decreases, there is increased chance of deposition in smaller areas. And as your particle size increases beyond 2 to 3 micrometer, there is an increased chance in deposition in upper airways. So they are defined as extra fine particles which are less than 2 micrometers. And if we look at the mass median aeromic diameter of commonly available inhaler medicines, there are many inhaler medicines which have a mass median diameter of more than 2 to 3 micrometers, but there are few also which are less than 2 micrometer. Those are probably will act better in a small airways. These are like biclomethasone dipropionate HFA solution, cyclazonide, all this. If we look at your llama or tiotropium and glycopyrronium, both are having a mass median diameter of more than 2 or near more than equals to 3. So in summary, so small airways are less than 2 micrometer in diameter and includes both conducting and respiratory zone. Although diameter is small airways is responsible for only less than 20% of the total airway resistance. Many diseases can involve small airways like obstructive airway disease and interstitial lung diseases. There is a risk of delaying diagnosis because spirometry cannot detect small airways in early stage. At this condition, we have other tests like FOT. There is a risk of low drug deposition with commonly available drugs. We should choose drugs intelligently. The drugs which are having less than 2 micrometer particle diameter and having a more chance of deposited in smaller airways. That's why the ultrafine particles may be the better option in small airway diseases. Thank you.
Yeah, thank you, Dr. Ghosh, for setting the stage in. I think we should have some questions in this topic. We'll take an end. Next is the radiological detection of small airway disease by Dr. Sumit Sharma. I'll request Dr. Sharma to please come on stage and present his deliberation.
Warm good evening, everyone. I'm here today to present to you about the radiological findings in case of small airway disease. So we are in the workshop zone now. This is small me. Okay, so the contents are as forth. Introduction, anatomy of the airway. The small airways will have the direct and indirect radiological signs, the common airway pathologies in small airway disease, and the conclusion. So we can move forth with this because the past so many slides have been about it. Anatomy has been covered. In this, I would like to really focus on one thing, that is prelobular branching, which according to us radiologically is known as centimeter pattern, and an intralobular pattern, which is millimeter pattern. So that millimeter pattern is what is the area supplied by each terminal bronchiole, and that area is called the acinus. So Miller defined the secondary lobule as an area surrounded by the interlobular septum. So in this photomicrograph, you can see this region over here, which we call as the secondary pulmonary lobule. And by Reed's definition, we know that this is the branching terminal bronchioles that you can see. And the issue over here is that on CT, this is not visible. What we do is by looking at it as in the vascularity, we can guess that this is where the pathology is taking place. Moving forward a bit, yeah. So this is another secondary pulmonary lobule where Miller's definition, we can see this over here is the secondary pulmonary lobule, and there's over here the alveoli. Now, what is the scope of HRCT? Now, HRCT can be used to visualize an airway anything greater than 2 mm. So that is subsegmental bronchi. Now it is located in the inner 2/3 of the lung field. So our job as radiologists is to make sure that the difference between the pleura and the finest of the airway is least. So as we are going on with a thinner collimation, say 0.5 to 1 mm, because of the powerful resolution, so peripheral lung structures actually are visible as close to the pleura as much as 1 to 1.5 mm, and that is between the most distal visible airway and the pleura. So another image where we can see that we are trying to, with our technology, trying to reduce the gap between this distal bronchioles and the pleura. As far as possible, if we are able to see it, we'll be able to pick up interstitial lung disease as well as small airway diseases better. So here is an HRCT of the normal lung. You can see that the centimeter and the mm level peribronchial regions are seen. So what are the radiological signs that we can pick up? So there are direct signs as well as indirect signs. As far as direct signs are concerned, there are thickened peripheral airways, maybe only seen in the proximal portion, which we are not able to pick up on the common HRCTs that we do at 0.25 onwards. And indirect signs are very non-specific individually. So it is still important for us to pick up air trapping on inspiratory or expiratory field, and subsegmental atelectasis, mosaic attenuation, and central lobular nodules. Some of the times when we see them in a branching pattern, we call it tree in bud changes. So in the direct signs, we have thickened peripheral airways, which can only be seen in case of chronic bronchitis and asthma. Asthma, as we know, that HRCT features are very non-specific. There could be bronchial wall thickening, expiratory air trapping, inspiratory decreased lung attenuation, small centrilobular opacities, bronchial luminal narrowing, or subsegmental atelectasis. So sometimes in case of asthma, all we will pick up is these mucoid impactions and bronchoceal formation that you can see over here in the lung. So this is in a Y and V kind of shaped mucoid impaction where we only see, apart from that, we also see clinically elevated IgE levels and a mildly raised eosinophil count. So what we need to do is check for the sputum to find fungal hyphae on microscopy. Now coming to indirect signs, we have air trapping, subsegmental atelectasis, mosaic lung attenuation, and centrilobular nodules. We should all be able to pick up these findings. Let's have a look at first of the findings. What is the air trapping? You can see this is a case of a bronchiolitis obliterans, and you can see patches of air trapping. Why do we say what is air trapping is, when on expiratory field, you are able to see all these patches which are of differential lung attenuation. So you can see these are appearing a bit on the brighter side and these ones on the darker side. So which do you think is the normal ones? So these ones happen to be normal lung attenuation. Okay, these are the lungs which are showing air trappings. Subsegmental atelectasis. So are we able to pick up subsegmental atelectasis over here? So this linear structure that you see, this is a subsegmental collapse. And apart from that, anywhere else that you are able to pick, there are few over here as well. So those are a bit more on the finer side and you will confuse them with fibrosis. What is mosaic lung attenuation again? So mosaic lung attenuation is places where you see these differential lung attenuations without seeing the background septas. So you'll not be able to pick up and what you see over here are differential areas all throughout, and this is in the case of bronchiolitis obliterans. Again, coming to a case where we see some centrilobular nodules and what you see with a branching pattern. So this branching pattern will guide you towards the diagnosis of TB or acute lung infective pathology. The common airway pathologies in SAD, we are all aware: asthma, COPD, hypersensitive pneumonitis, that's a wide range of pathology that we see. Sarcoidosis, again a very long list what we go through. Respiratory bronchiolitis, induced interstitial lung disease, which is seen mostly in smokers. Microcarcinoid tumorlets, any kind of diffuse idiopathic pulmonary neuroendocrine hyperplasia, follicular bronchiolitis, and drug-induced, which he was just talking about, COVID-19 infection, which also has now shown us with a lot of delayed and late sequelae, which show kind of peribronchial nodules. Also, connective tissue diseases, rheumatoid arthritis, Soren's, and pulmonary manifestations of IBD. Histopathologically, we have a long list over here, and which we are all aware of. So COPD, the major CT phenotype that we come across is it's a spectrum of three components which may exist coexist in an individual. So either it will present like emphysema or a bronchitis or a bronchiolitis, of which the most difficult is air trapping seen in case of bronchiolitis. Emphysema has qualitative and quantitative assessment according to us. So what we do in qualitative assessment is gauge the severity, the type of emphysema, and the distribution that it shows. What are the types? We know of centriacinar, panacinar, and paraseptal. Apart from that, parasecretional also adds up to it. In a centriacinar emphysematous change, we will mostly see in case of smokers, we see destruction of parenchyma around the terminal bronchiole. So this is more marked in the upper lobes, and you can see over here the CT findings. So a lot of centriacinar, and it is involving the entire lobule over here. The central dot sign is also seen in few of them here. Case of panacinar emphysema, which is seen in most case of alpha-1 antitrypsin deficiency. It is most of the times mixed with centriacinar emphysematous changes, affects all the lungs. Areas of the lungs, and you can see over here this in the subpleural zone is a panacinar emphysematous. Paraseptal emphysematous changes which are adjacent to the pleural surface, and it's also causing pneumothorax or lung collapse very frequently. Parasecretional is something that we usually are not able to differentiate from honeycombing, and difficult to differentiate also from pulmonary fibrosis. So these are the patches of fibrosis that you see, and right adjacent to it you would see sometimes parasecretional emphysema, which might be confused with a paraseptal or sometimes centriacinar emphysematous changes as well. Apart from that, when you see these kind of fibrotic changes, you also see traction bronchiectasis and bronchiolectasis. So what do we do for quantitative assessment? We have CT density mask in FURS systems. And apart from that, we also have parametric response mapping. What happens in case of CT density mask? So the software what we have shows us, if you just see it with a naked eye as we do, we can see some centriacinar emphysematous changes in the lungs. So are we able to match it on the density mask? I think what we do is we are able to pick up even better than the naked eye. So you can see few areas that you are not able to see on naked eye, you are able to pick it up on the CT density mask. Another system that we have in place is a parametric response mapping. So in parametric response mapping, we are able to pick up the difference between small airway disease as well as ILD. So if you see this green, the first one is a normal lung. So in this, there was no signs of COPD, and we could find that the entire lung turns out to be green on parametric response map. Over here, you can see few areas which are turning yellow. So yellow represents the interstitial lung disease pattern, and the red represents the emphysematous lung field. So in this patient with the gold stage 4, you are able to see a few areas which are showing both. But in the last image, you can see more of, in the third image that you are able to see more of emphysematous changes. But in the final image, you can see it's also like a conglomeration of both the findings of SAD as well as interstitial lung disease. This is a new technique which has developed over time, and we now using it multiple places, although I don't have any experience with it. So this gives you a combined assessment of both qualitative and quantitative. We use the dark field chest radiograph. So what we do is the normal findings are below the 950 HU that we place are labeled as emphysematous lung field. On 3D emphysematous map, which is projected on the CT, we see that there is both emphysematous as well as interstitial lung pattern. Many other pathologies that we come across, however, it is tough to differentiate unless we put together our heads and make it into MDT. We are not able to pick up specifically hypersensitive pneumonitis just based on the lung pattern. So we require multidisciplinary meets to discuss and make sure that the diagnosis is achieved at this level. Small airway affections which have a non-airway diseases are as forth. So many of these are actually non-airway diseases and yet present as small airway diseases. So in conclusion, all I would like to say is since small airways are located at a transitional zone between larger airways and lung interstitium, so the pathophysiological conditions can also make sure that we see a lot of ILDs along with SAD. So before we actually had a differentiation between SAD and ILD, both were clubbed together and presented as a similar kind of a pathology. Now, non-invasive methods for diagnosis have been greatly improved by progress in HRCT, and novel image analysis softwares are even putting forth our diagnosis in a better way. We are also able to monitor a lot of airways diseases without actually going ahead with the requirement of a biopsy. Environmental and drug exposures are changing rapidly, which we are all aware with the current scenario in Sikkim that we are all already aware of. So many kinds of environmental exposures to diseases are happening. Apart from that, what we know is treatment of small airways disease is not well established even now. Although I would like to learn a bit more about it in today's program. Better and earlier identification of small airway diseases now should improve the treatment interventions. And as I've already told you, collaborative research will make sure that we improve our knowledge on SAD. Thank you. I acknowledge the role of Dr. Parthasarathi for inviting me over here. Thank you.
Yeah, thank you, Dr. Sumit. So now I think I have a small talk. Okay. Okay. So before I start, let me just put one point in front of you. You know why we are so much worried about this small airway? If you see that in our body, the part of our body which is in close conjunction with the environment, okay, the environment dictates how that part or the organ system should function, and it is also the responsibility of that organ system to act as a good innate immune defense system. Okay, so what we have for that? We have number one, the skin, which is also a quasi-immune structure. We have a GI tract, and we have these airways. In the airways, if you look, the upper airways, the epithelium and mucosa and submucosa is very well defined. Okay, it's quite robust. If you go into the alveoli, alveoli is mostly it functions as a diffusing organs. But if you look into the airway, that's the terminal bronchioles, the respiratory bronchioles, this is the part, though it comes in contact with the environment, and so all the vagaries of the environmental insults it has to face, but more so, its defense mechanism are not as robust as that of the upper airways. As robust means, I mean to say that the physical defense mechanism, that is the epithelium, the subepithelial structures, the mucosa and the submucosa. So what happens is that whenever there is this insult over there, the system has to react. So anyway, the innate immune system will then pull in its mechanisms. Mainly, it's either an antiviral state by releasing of the type 1 interferons, or it will be the most common thing that happens is the inflammation. And this inflammation in the smaller airways, it does not have an effect not only on the local structure, but also in the far outreach structures as well. So that is the part which is actually driving the entire thing, which is causing the fire to go on to burn. And that actually manifests later on with all the systems and all the manifestations that we have for any of the diseases. My talk is basically would be on the obstructive airway diseases, because this is the part where we have the maximum evidences about the small airway dysfunction, right? Okay. So anyway, so nothing to disclose. Outline, well, I'm not going to go into details because it is a continuum of the lectures. So what is small airway? We all know by this time. So we'll talk about the small airway dysfunction, COPD, because that is the main important airway disease in which we have very large number of evidences. Then came the SAD in asthma, because we all knew that asthma is a disease of the medium and the large airways. COPD is a disease of the small airways. But now the entire notion is changing. We know now that in asthma, as Dr. Sharma was saying, Dr. Ghosh was saying, that from the Atlantis trial, he says that like it is almost around 70 to 80%. And then in one cohort, it was 90%, which was in a subgroup of the Atlantis, that there is a small airway dysfunction. So that means this disease in asthma also, there is a significant involvement of the smaller airways. How to measure small airways dysfunction? We have just heard about it. I'll just reiterate a few of the points, and then I'll put forth an open questions, because what are the future directions and where to go from there. This is small airways. You all know, less than 2 millimeters in the diameter. And this is the study, the BOLD study, which came in the Lancet Global Health in January, and showed that significant number of patients shows the small airway dysfunction. Now, what is interesting in this study? See, this study was not done on anyone who has a disease. This was a community-based study. India was one of the participating centers. And in India, Mysore was one of the centers where the study was done. Now, what the patient they took, no, I won't say patients, what the participants they took, they were individuals 40 years and older who were either smokers, and they stratified it depending upon the burden of the smoking, and they were non-smokers who had a family history of the COPD, because this notion was taken from the COPD gene study, and there was a subgroup who had a past history of the tuberculosis. So these were the participants in this study. And they were using two metrics to study this small airway dysfunction. One of them was FEF 25 to 75, and another one is the FEV3 by FVC. Dr. Ghosh has just given a brief outline of the two metrics. Well, when they took the FEF 25 to 75, they found that the highest number of the small airway dysfunction came from the Mysore group. That is, it was 34%. But when they took that in the FEV3 by FBC, it was the highest came from one of the Australian centers. So the main thing is that to understand, though these subjects did not had any manifestation of any of the airway diseases, but they were showing significant small airway dysfunction. Now the big question is, now what does this implies? Where will they go? Means, is it going to be something static, or is it going to be progressive, or maybe in few years they are going to land into a full-blown obstructive airway disease? So that was the catch of this thing. Anyway, so as I was talking about, so this is the main inflammatory process in the small airways, which actually drives the entire thing. This inflammatory process comes from the injury. This injury could be because of the cigarette smoking, or it could be a biomass fuel exposure. It could be an infection, which could be a viral, bacterial. It could be anything. It could be a pollutants. It could be trap. It could be diesel exhaust particles. It could be whatever you think about. Because now we know that we individuals, we human being, along with our microbiota and along with our environment, we are holobiont. Okay, so we call this concept of holobiont, which has come. So anything which is coming, we are actually responding to it. Now, and this response is either in the way of airway remodeling, because I was talking to you that they do not have that robust defense mechanism in the form of the structural defense mechanisms or the physical defense mechanisms. So they usually responded, the smaller airways, actually by causing inflammations, and this inflammation led on to increase in the extracellular matrix depositions, the increase in the neutrophilic infiltrations, because the neutrophils, as you know, they are the main cells which come into an area of the infiltration the first cells. They are actually the foot soldiers of the innate immune inflammation mechanisms. And when neutrophils came, they released the neutrophil proteases. So there was this protease, antiprotease, increase of proteases, this increased activity of the matrix metalloproteinases. All these things actually lead on to this airway remodeling, the mucus plugging, and obviously the immune cell infiltration. This neutrophils followed by the macrophages, then followed by the T lymphocytes, mainly Th1 or Th17 as we know nowadays. So what this causes? This causes the onset of the small airway disease, and very important, its progression to involve the other part of the respiratory system as well. And on the top of that is the bacterial colonization, which also further increases this inflammation, and also these exacerbations because of the bacterial colonizations, because of further insults by the environmental injuries. This also increased the inflammatory load in the airways, and further it increased the entire spectrum of the chemokines, cytokines, and the interleukins, which actually drive the disease. So this is a vicious cycle, and it goes on and on and on until and unless we do something to halt it and prevent its progression. So what is the impact? Like if you see that this was first, I will talk about the COPD, because the COPD, we had talked about it, we know it very well. So usually this small airway obstruction, it leads on to the dynamic hyperinflation. That is, as we are able to take in air, but when we're exhaling, all the air doesn't go out, and there's air trapping, which can be detected by many radiological means, and it leads on to the activity limitation. And now we know there's the dynamic hyperinflation and the activity limitation. These two are the major determinants and independent determinants of mortality in the COPD. So we can see that this all arises because of the small airway dysfunction leading to the small airway obstruction. So again, the same model holds as a COPD, as I just talked about, the injury model leading on to the inflammation in the small airways, and which actually drives the entire thing. So that means the story starts much before the patient lands up into a clinic, or maybe the patient lands up having some symptoms. So it is much beforehand. So the point is how early we catch them and we prevent this progression. Now let's briefly discuss about the SAD in asthma. We know that small airway dysfunction in asthma, now it is typified as the SAD asthma. We say it's a SAD asthma. But in the Atlantis study, as I was just mentioning, it has shown that 90% of the asthma in that group had a small airway dysfunction. So this is really an important concept to reckon with, okay, because we were not treating that part. Okay, whatever we are treating, those drugs and those modalities does not reach that part of the airways where there is a inflammation and the dysfunction. As you can see that this over here on the A, it's a normal airway. On the B, see the airway that is the small airway has become so thick, there is so inflammatory infiltrate, the lumen has also got narrowed, and this is progressing, and this goes on, and it causes the typical signs and symptoms that we see. So if it was seen that the small airway dysfunction, it is present in all the severities, genia severity of the asthma, and as the genia severity progresses, the small airway dysfunction also goes on increasing. So be it say in genia 4 and 5, the relevant small airway impairment is significant. If you see the duration of the disease, the more longer the disease, the more small airway dysfunction it is. So maybe like typically if someone has a T2 asthma, childhood onset, frequent exacerbations, and comes to you say in the middle age, That means a long duration of disease. These are the patients with asthma who will definitely had a significant small airway dysfunction. Even the exacerbators phenotype, they have the mode of the small airway dysfunction. And now we know that the small airway dysfunction, it is an important correlate of not only the loss of control of the asthma, be it a mild asthma, or it is also an important contributor to the increased exacerbation of the asthma. So that is what we know that from the recent trials and studies that we have come about. And obviously severe exacerbation, that is more frequent involvement of the small airways. If the asthma control makes it worse, and the quality of life is also poorer, as you can see the various correlates by using either various quality of life questionnaires like SGRQs or so. So then the thing comes that if it is so common, then how can we measure? Because we need to catch it early, So we had a talk, we actually discussed, I'll just reiterate it. Spirometry is not a good test to detect the small airway, but this is the most common pulmonary function test available, most inexpensive. So can't there be any metric which can be used? As in the BOLD study, they use the FEF 25 to 75 and they use the NANES as equation for that, or FEV3 by FVC. Now it is coming that we can use FEV3 by FEV6 is another metric. And recently there's one study which is going to come up from the southern India, where they have used in the numerator FEV3 minus FEV1 and the denominator is the FVC. So this is the way in which they're trying to have some kind of picking up of the what is thing which is happening during the mid part of the flow of the airways, where it is mainly coming out, the volumes of air is mainly coming from the smaller airways. Well, the whole body plethysmography, that's both the RV and TLC, it increases, and increase in the RV is by RV TLC ratio is an indicator of the small airway dysfunction. This is the most important test that we talk about, and I think that more and more we use it, we'll be able to pick up the small airway dysfunction. So this is, we are using the lung oscillometry. In this, we're using the actually basically either the air sound waves or the sound waves, and which is throwing inside the lungs. It comes back and we measure two important parameters, the resistance and the reactance. And by throwing it at the lower, smaller frequencies, we try to get the information from the small airways. And that is, this is one of the most sensitive tests that we can have. And though it was given very long back by Du Bois, so who also gave the invented whole body plethysmograph. But this is really one of the tests in the hands of the clinicians in clinical practice, which can pick up small airway disease early. Inert gas washout, so I won't talk much about it. Multiple nitrogen breath test, a washout test, or the single nitrogen breath washout test. This actually is still, it is not available in majority of the centers. And well, if it is an increase, that is showed that it is definitely the one of the indicators of the small airway dysfunction. But the advent of this oscillometry, it has superseded all these measures. Radiology remains one of the mainstay in diagnosing the small airway, as you just heard the talk about by Dr. Sharma. Difference between the inspiratory and expiratory phlegms, wherein with expiration there is the air trapping areas, or there can be use of the hyperpolarized helium MRI techniques, or maybe the single photon emission computer tomography. These are all the nuclear imaging techniques which helps to pick up basically the small airway dysfunction. So with all said, now what remains? Number one, suspecting it. Very, very important. We have to suspect it, then only we can pick it up. So suspecting, then using the appropriate test in properly selected patients for early detection. Next comes is the targeted therapies. So what after detection, then what? Okay, we'll have a small group discussion on that. And then we have to think about how we can address the protease anti-protease imbalances in treating the small airway dysfunction in the COPD, which is the new thing to come up. So with this is the next talk in this series is basically also related to the small airway dysfunction in obstructive airway diseases, and that we presented with, and some case will be presented from and these are cases from this Institute of Pulmocare and Research. Okay, so I would just then request Miss Devkunna De to come on stage and present few of the real cases of the small airway dysfunction in the obstructive airway disease.
Good afternoon, everyone. So I am basically a research scholar. I'm doing my PhD in the field of COPD. So I will not be going to present cases, but analysis related to the cases. So my topic today is small airway involvement in obstructive lung disease, and I'm going to present the IPCR perspective, our own experience on this particular topic, what kind of analysis that we are doing, and the interesting results that we are getting. Now, I will be talking about small airway dysfunction in asthma and COPD, and I'll also mention asthma-COPD overlap, or the term ACO. Now, the term ACO has become an enigma for the pulmonologist because the definitions keep changing, as we heard this morning. And right now in 2023, Gina and Gold, they have given up this term. They want us to call it asthma plus COPD, a patient having characteristics of both asthma and COPD. And these are the excerpts from Gina and Gold. So you see that there are more questions that are rising. Are we finally accepting the British hypothesis? We are accepting that asthma and COPD are completely different entities. We are giving up the Dutch hypothesis. We don't know. There are a lot of questions, there are confusions. But one thing that is true, that small airway involvement is present in all kind of obstructive lung diseases. So my previous speakers have talked about the diagnosis of small airway diseases. I will be focusing on the conventional spirometry and the more advanced technique known as the oscillometry. Now, this study started in 2019 when we had access to spirometry in our clinic and we were not so familiar with oscillometry. So from the outpatient department, we had recruited 647 COPD patients, 550 ACO patients, and 403 asthma patients. Our COPD patients had FEV1 by FVC ratio less than 0.7 and no FEV1 reversibility. Our ACO patients had FEV1 by FVC ratio less than 0.7 along with FEV1 reversibility more than 200 ml and 12%. Our asthma patient had FEV1 by FVC ratio more than 0.7 with FEV1 reversibility. We included their clinical data as well as their spirometric data and proceeded to analysis. So this was a demographic of our patients, and you can see that our asthma patients were the youngest, followed by the ACO patients and then the COPD. The male-female ratio, we know that COPD is still a male predominant disease in this country. So in case of COPD, there was a male predominance. And smoker to non-smoker ratio was also as we expected. Now, when a patient comes to a clinician first, they present with symptoms. So the first thing we looked into are the symptoms. And here you can see that in case of cough, expectoration and exacerbation frequencies, there was a gradual increase from asthma to ACO to COPD. But wheeze was higher in case of ACO patients as compared to the other two. When we look into the symptom severity, we had measured it in terms of a Likert scale, and here we found that sometimes ACO was matching with asthma, sometimes ACO was matching with COPD. We were not very clear. So next what we did, we analyzed their spirometry data, and these are the results where you can see that ACO was falling just in the middle of asthma and COPD in terms of majority of the spirometry parameters. In terms of FEV1 by FVC, it was right in the middle. In terms of FEV1 post percentage predicted, it was right in the middle. And same is true for FEF 2575, which is the marker of small airways. ACO was falling just in the middle. And from the FEF 2575 data, we can understand that asthma patients perhaps had a better FEF 2575, followed by ACO and then COPD. So using all the data we had, their spirometry data and their clinical data, we did a multivariate analysis to understand where this ACO group actually falls. And here also we found that in our multivariate analysis, OPLS-DA, the ACO group was falling just in the middle of asthma and COPD. When we looked into what are the parameters which were actually creating these clusters, although there is an overlap, we can still see the pink circle here. So what were the main variances, the main parameters which are causing this difference? So apart from the already known and expected parameters like reversibility, age, and FEV1, we found that FEF2575 was also a remarkable marker which was differentiating these groups. So this actually prompted us to do an ROC analysis of FEF2575 parameter between ACO and asthma and ACO and COPD group. What we found that this FEF2575 parameter could actually distinguish between ACO and asthma with a cutoff of 35.5 with a very high sensitivity and specificity. But when we are trying to differentiate ACO and COPD, we had a cutoff of 12.5 but a low sensitivity. Now coming to 2023. Now our institute we have access to oscillometry. We are doing it regularly in our patients. We are learning every day. And in this case also, we want to see what is happening in case of ACO patients. But right now, first we wanted to focus on COPD and asthma so that we learn from these two and then we will study this overlap or unclassified patients. So again from our OPD, we collected COPD patients about 50, asthma patients about 22 and analyzed their oscillometry data. So this is the asthma data, pre and pro bronchodilator. And I'll not go into the details of each of the term that has been explained by my previous speakers. So we see that the R5 and R20, there is a distinct and significant drop post bronchodilator. And that is also true for X20, which is the reactance value. So this is what we expect. Post bronchodilator, the resistance R5, R20 are going down. And also the X20 value is also going down. Coming to the COPD data, post bronchodilator, we see similar results that significantly there's a drop in R5 values, R20 values, and X20 value. Now we go on to compare the asthma versus COPD data. And here we see that post bronchodilator, the drop is much more profound in case of asthma patients with respect to the COPD patients. And this is exactly what we expect. We expect the bronchodilators that we are using, salbutamol, to work more for the asthma patients. This is exactly what we thought we will be getting. And this was our result statistically. So what does this mean? This means that our spirometry data was resonating the oscillometry findings. Although we did not find any significant difference between the R5 and 20 and X5 data, but my patient population was also very low. Again, in case of X20 value, we see a much more drop in case of asthma patients as compared to the COPD patients, as I have explained before. So does that mean that we can draw a correlation between the oscillometry parameters and the spirometry parameter? We did a correlation study in case of asthma and COPD patients. We used the R5 data and tried to correlate it with FEF2575 and FEV1 post percentage predicted in case of both asthma and COPD patients. And here we saw that we found a moderate correlation with significant p-values among all these parameters, like R5 was correlating with FEF2575 as well as FEV1 post percentage predicted. So now this is the study we have done till now. There are many other parameters in FOT that we need to analyze. But what do we understand from the study till now? We do understand that yes, in small airway, there is the COPD and asthma both have involvement of small airways. Perhaps involvement is more in case of COPD. And in absence of oscillometry, oscillometry test is not available everywhere, whereas spirometry is. So in cases where there are no oscillometry available, we can still look into the FEF2575 values to understand if there is a small airway involvement. So FEF2575 is a neglected parameter which many physicians do not see. We request, please look into this. Why? Apart from our studies, there are many other published studies. One very interesting study which have shown that a person can have normal lung function but a deteriorating FEF 2575 value, which is an indication of early COPD. And I think the future ahead is to use the artificial intelligence and the predictive power of the artificial intelligence and include all the data from spirometry, oscillometry, and imaging to have an algorithm which will be able to predict small airway disease right at its initiation. It will be of benefit for both the patient and the clinicians. And there are many other things to do, both qualitative and quantitative, and we look forward to more research in this field ahead. With this, I want to end my presentation. Thank you, Dr. Parthasarathi Bhattacharya, for giving me this platform.
Yeah, thank you, Devkonna, and I really thank Parthoda for generating such data from our country. And maybe when we increase the sample pool, I think it's going to be really be a important and study which is going to help all of us all over the country. Okay, so next we move on to the restrictive lung disease. So, and we'll see what is the small airway dysfunction in the restrictive lung disease. And for this, I will request Dr. Sumit Sengupta to speak on this. Thank you.
Good afternoon. I think you'll all welcome a break from obstructive airway disease and fix on something which is my topic today, small airways dysfunction in restrictive lung disease. Now, to start off with, what is restrictive lung disease? This is a 2020 PFT interpretation criteria from the ERJ ATS. You can only diagnose restriction with a lung volume measurement. Spirometry cannot diagnose restrictive lung disease. So the commonly used term I don't know how many of you, I have not done a TLC since I've come back to India for 30 years now. So casually calling a disease restrictive lung disease is bad medicine. You need to get your terminology correct. Most of the cases of the so-called restrictive pattern, which is now recognized in the ATS-ARS guidelines, are obstructive or poor effort. It's called variably non-specific pattern or preserved ratio impaired spirometry. In fact, it is not recommended at a spirometry report mention the word restriction unless you have clinical or radiological data incorporated into that. So restrictive lung disease, to be used casually, you have to have a TLC. This is 2022 and this has been around from 2005. This is the last version of it. If you see, I put it in inverted commas, total lung capacity is necessary to confirm or exclude the presence of restrictive when VC is below lower limit of normal. So casually saying the patient has a restrictive defect is absolutely not science. Okay, most of the patients you see on spirometry who have restrictive defect, so-called restrictive defect, don't have it. So that's the first thing to say. So how do we proceed from here? So you exclude asthma and COPD and look at the rest of the so-called restrictive lung diseases, and there's a huge list of it. It starts from, I mean, for example, you have a patient with TB and they have train bud all over the lung. Do you do PFTs? You don't, but if you do, you would mostly get restrictive in the acute phase, and later on when bronchiectasis develops, you would get obstructive. So the context of what we are talking about here is a chronic or subacute disease. So not the acute diseases where bronchiolitis is the commonest disease known to mankind, viral bronchiolitis. 4 times a year, everybody in this room is going to get it. So we're not looking into that. That's small airway disease. That's why you cough. That's why you get all these things. If you do a CT, you will find it out quite soon, but you shouldn't do it. What we are looking at is slightly different. I'll talk you through this. You all know this. So obliterative bronchiolitis, this is the first on the list. I don't know why. This is not my list. This is from the ERJ. The commonest obliterative bronchiolitis in the world today is post-transplant OB, and that is thought to be a chronic rejection marker. So that by definition is obstructive, and then you actually have obstructive patterns on spirometry in more than 50% of patients, but not in everybody.
Acute bronchiolitis we'll leave alone. Diffuse panbronchiolitis is a very geographically limited thing, so we will not talk about that. Respiratory bronchiolitis, smokers' bronchiolitis, extremely important because not because it happens, and of course you can get RBILD, you can get respiratory bronchitis, interstitial lung disease. It can, a current smoker can confuse you on CT scan and what actually is the pathology. And secondly, also, it will confuse any smoker with any other disease. The involvement of the small airways, is it due to smoking or is it due to the actual disease? So it's confusing, but you need to know that respiratory bronchioles are involved almost inevitably if you smoke. It's of course dose dependent and genetically determined, but you need to be aware that a smoker can have small airway disease quite frequent proportion of the time. Follicular bronchiolitis, I'll mention in a different context. Diffuse aspiration bronchiolitis, all these sort of things. These are rarer diseases we'll talk about a little bit. We'll talk about interstitial lung disease with prominent bronchiolar involvement. We all know about hypersensitive pneumonitis, and I'll show you a CT later on. And that is a classical disease where bronchioles are involved, but it's not the only disease. RBILD is a smoker's disease where not just the bronchiolitis, there are fibrotic areas and ground glass appearance, and can confuse people in what is happening. Cryptogenic organizing pneumonia is a small airway disease, not in entirety, but a strong part of it. If you remember its old version, the name was bronchiolitis obliterans, and that's where the pathology was. So that's also small airway disease, and it's not that uncommon, and often we end up giving steroids to people with a persistent shadow after pneumonia. That is actually organizing pneumonia. There are lots of other things. Sarcoid, occasionally you get things, and we will not discuss it. I'll go to another thing, which is now this is a patient of mine. As you can see, there is mosaic. This is an expiratory scan. There's air trapping, classical HP, and so small airway disease is very easily obvious in this restrictive lung disease. These people often, I'm sort of being very, very old-fashioned here and saying, if you put a stetho on these patients, you will often find a crackly wheeze. And in the context of an ILD, if you get a crackly wheeze, unless there's a COPD and asthma, you should think of HP. And it's very old-fashioned, but you still can use the stetho once in a while. This is a patient is currently under my treatment, a young lady of 34. She has, well, let's say secondary Sjogren, SSILD with Sjogren, with prominent Sjogren's syndrome. And she has, if you look at it once, you would think it's honeycombing. Then you look at it again and you'll see it's not honeycombing perhaps. There's a variability in the size of the cysts. And cystic disease in Sjogren's is a small airway disease. It's not a parenchymal disease. Now, which of these is cystic and which is honeycombing? We were obviously without a lung biopsy we cannot, but I will be discussing at length at idiopathic pulmonary fibrosis. So this is one patient. This is a patient of mine from about 7 years ago. As you can guess, he has passed away. This is IPF, UIP pattern, classical honeycombing, palisaded cysts at the periphery of the lung, subpleural. And now, why am I bringing this up in a small airway disease seminar? Well, that's going to be the main impact of my talk. In 1977, a long time ago, in idiopathic pulmonary fibrosis lung biopsies, 94% of the patients had peribronchiolar fibrosis or inflammation. At that time, this gentleman, who was not at all famous for his work, said that it is a disease of the small airway as well as alveoli. 94%. So it's not an all-out thing. You next go to people. I have already my speakers before me have mentioned the lungs quiet zone. This is the original article from NEJM in 1970. And as people have said, small airways contribute so little to total airway resistance. You cannot measure it in our standard tests, and therefore it's the quiet zone. So that is the reason perhaps it has not been picked up in classical ILDs like idiopathic pulmonary fibrosis. The concepts are changing. Honeycomb cysts, this is explant lung. So that's the best way of looking at idiopathic pulmonary fibrosis. You've transplanted a lung into this gentleman with IPF. You take out the whole lung, which is diseased, and you look at it under the microscope. And they found that the honeycomb cyst, the one which you look at and say, oh, this is IPF, that has MUC5B predominantly. It doesn't occur in alveoli. And there are epithelial and mucous cells, pseudostratified mucociliary epithelium. If you the previous speakers all spoke about where that ends. This is airways. This is 2013. This is a oft-quoted study. This is the thing which probably started off looking into it. Now, this is a look at the HRCT honeycombing. Now, I'm sure you're aware the HRCT honeycombing and the histopathological honeycombing are different things. They're not the same. So what you see in HRCT as honeycombing is this, bronchiolectasis, not fibrotic lung alveoli. So things came to a head in 2016 to 18, and basically I will not bore you with the details. The concept which was promoted was that IPF is a genetic disease, the MUC5B being one of the genes, and which is the promoter gene for mucin in the airways. And that involves mucociliary dysfunction of the peripheral airways. That's the physiological review. And then in the annals of ATS, idiopathic is a genetic disease involving mucus and peripheral airways. No alveoli written there. Turns all that we know on its head, doesn't it? So this started off people looking at this, and as I said, the explant pathology is where it works. This is Lancet Respiratory Medicine in 2020. Small airways disease is a feature of IPF with significant loss of terminal bronchioles. Almost 60% of terminal bronchioles are lost, with regions of minimal fibrosis in places you remember in IPF you have normal looking lung. In those bits of normal looking lung also terminal bronchioles are already gone. 60% loss. And again in the AJR-CCM, the Blue Journal in 2020, it was a follow-on from another group. It occurs early in the disease process. And they reiterated that the terminal bronchioles with fibrosis and peribronchial fibrosis, they undergo traction bronchiolectasis, resulting in formation of honeycomb cysts. Honeycomb cysts are airways. They are not alveoli. They're not lung parenchyma as such. So the very, very obvious honeycombing I showed you on the CT was airways. And that's so obvious, and it's only lately that we've discovered that all of that is small airways. Now, this is, as you can make out, it's very early, and people are looking into how this can be, in the normal looking lungs where you have small airway disease in an IPF patient, how that can be translated into action, into preventing that bit of lung going into honeycombing. So I'll leave you with that thought. Thank you very much.
Thank you, Dr. Sengupta. I think we all are waking up to understand that how important small airways are. Okay, so we move on to Ms. Shanti Karmakar, who would be talking about the airway involvement in the ILD. She is also from the Institute of Pulmocare and Research.
Thank you, sir, for the introduction. So my previous speakers have already narrated a lot on airway involvement, and thanks to my previous speaker who has narrated on interstitial lung diseases. So why not have it together? So today I'll be sharing our experience in airway involvement in interstitial lung diseases. So as we all know that ILD is a parenchymal lung disease which primarily does not exclude concomitant airway problem. We have some of the DPLDs who present as bronchiolocentric in nature to start with. So ILD starts from periphery and does include smaller airways eventually, as in hypersensitivity pneumonitis. I would not reiterate more into this because a lot of talk has been on this since afternoon. So let us come to the modes of assessment of airway involvement, which is evolving nowadays. So we have considered the gold standard criteria, that is FEV1 ratio less than 0.7, as a sign of airflow limitation, which is although mostly designating intermediate and larger airways. We do not have conventional criteria to assess smaller airways, and primarily we have considered this as a sign of airflow limitation. So here is a CT image of a DPLD patient where we are only bothered about restriction. So is there any airway involvement? To answer this, we have taken clinico-radiologically suspected DPLD patient population, and based on the GOLD criteria, we have classified them into two groups. And the two groups are labeled as ILD-OAD overlap group, who has a FEV1 ratio less than 0.7, and the other group is labeled as an unmixed ILD group, having the ratio greater than 0.7. And the demographic and the spirometry comparison was done between the two groups, where we see that the two groups are having demographic and spirometric variables almost similar. I'll come to the second half, where the parameters marked in red, that is FEF 2575 percentage predicted values, and another spirometric derived variable FEV1 to FEF 2575 distance, have proven to be the most significant parameter standing out between the two groups. So with this, we have performed ROC curve with the most two promising candidates, and we have found that FEF 2575 has ranked highest with a sensitivity as high as 84.62% and a specificity as high as 81.15%. This was followed by the spirometric derived variable, as I just mentioned before, FEV1 to FEF 2575 distance. We have performed this to check the efficiency of these two parameters to serve as a surrogate of our GOLD criteria. And now we have applied this FEF 2575 and the other spirometric derived variable on our so-called unmixed ILD group. And we tried to see how many patients could be independently diagnosed by these two variables. And to our surprise, we have found that 29 plus 29, that is 58 patients out of 175 ones, were recognized by our additional OAD criteria, which we have labeled them as in red color. And we have also compared the fibrotic score and the non-fibrotic score between the two groups, where we have considered the score based on a linear Likert scale done on a visual impression. It was a manual scoring done by my guide, Dr. Bhattacharya, on a Likert scale based on the HRCT characteristic signs. And we have also found that the fibrotic score has proven to be significantly higher in the unmixed ILD group, whereas the non-fibrotic score is significantly higher in the OAD overlap group. And this is quite expected. So, using the conventional criteria, we find that 12.93% of DPLD patients are having an concomitant airway obstruction. And if we add our proposed OAD criteria, what is the scenario? And we find that this 12.93% goes up as high as 41.79%. And this 28.86% is the extra or the additional percent which gets added on to the number. So, after considering the conventional criteria as well as our proposed criteria, we are having now 84 patients who are having a concomitant airway obstruction apart from their restrictive impairment. So, had we been only considered the gold suggested guideline, we would have missed this 28.86% patients who are also having an airflow limitation apart from their restrictive disease. So to sum it up, I would say that airway disease in ILDs is underestimated, as it was already mentioned by Dr. Ghosh in the first talk of the session. And both the large airways and the small airways should be considered for inclusion in the treatment regimen of interstitial lung disease. But of course, we would say that more research is of course needed to establish this. So thank you. With this, I would thank my guide and mentor, Dr. Bhattacharya, for offering this platform to present my research work. And I'm happy to share that a part of this research work was accepted as a poster presentation in this year's ERS Congress. Thank you so much for your patience here.
Thank you, Shanti. It's really commendable work that Institute is doing. So now we move on to the last talk, and this is the most important topic in today's workshop, that where we culminate. We culminate in what is the impact of the small airway disease and what is the treatment. And for this, I would request Dr. Arindam Mukherjee to please.
Group meeting.
Or
discussion.
Or maybe, yeah.
Brief group discussion in which he will join.
Okay, I think
in next 4-5 minutes we can have a group discussion with all the speakers together, including Dr. Arindam. Huh? You have any projections or anything? No, you can please take a chair. Dr. Ghosh, please.
Okay.
You be seated there and conduct from the chair. You can conduct from the chair.
Come. Okay, so I would request Dr. Sudeep Ghosh, Dr. Sumit Sharma, and Dr. Arindam Mukherjee to please come on stage. 5 minutes, yeah. Okay. So first of all, I would begin with if there is any questions from the audience and on the small airway disease workshop. So we'll take that first. Okay, then let me start. So first, I will definitely ask Dr. Arindam Mukherjee. Dr. Mukherjee, yeah, that is what was your topic. So first, let's see that what is the impact of the small airway disease, say according to you, on the obstructive airway disease and also on the restrictive lung disease.
Sir, what I understood or what I have felt, sir, this small airway disease is something which is less talked about and less understood and less tried to be treatment has been applied for it. But small airway disease is possibly the beginning of the other diseases. It starts from there and then it involves the larger airways, all the parenchymas, and ultimately they happens in the clinical manifestation which we can see. So if we can identify diseases as the small airway disease when it is limited to the small airway, then we can possibly offer them better treatment. So that is the main importance of understanding small airways. But to my understanding, small airway has not come to a clinical relevance till now. It is more and more of a research activities where we can understand the background small airways of this known obstructive or restrictive airway diseases. And there should be a continuous influx from the bench to bedside so that this research information, this new understanding of small airways or the treatment options can be applied to the restrictive and obstructive diseases at large.
Yeah, thank you very much. So what we understand is that, see, we are in a flux, okay, in this time. So, and we know that the chronic respiratory diseases, it's a major illness all over the world in our country, and we also have a national program for that. So maybe we're trying to move ahead the tide rather than following the tide of the rise. So in this, we are trying to figure out that to understand the small airway disease, to detect the small airway disease, what impact it can have on the patient treatment and the outcome. So that is what is still in the process of the development, and maybe we are in a time where we should be able to understand what is the impact of it, so that we can think of treating these patients who come to us with some subtle signs of maybe related to his or her illness. Okay, thank you. So I would ask Dr. Ghosh. Dr. Ghosh, do you think that lung oscillometry is a substitute for the spirometry? I am asking in the context of the adult population.
The spirometry and lung oscillometry, the physics is different, and I think spirometry oscillometry is a better sensitive marker than spirometry. So if we suspect the clinic patients, when I should use spirometry, oscillometry, is that when patient came with a complaint of breathlessness and some respiratory problem, and the spirometry is near normal or borderline, then I think oscillometry should be done to prove or disprove his diagnosis of obstructive airway disease.
Okay, so that means what you are trying to say that
See,
yes, yes, yes.
I'm doing both oscillometry and spirometry, but I feel that they are supplementary. You should do both together. We are learning, you are in the phase of learning. We see that sometimes we find oscillometry grossly normal, spirometry is okay. But sometimes both are abnormal. Sometimes spirometry is abnormal, oscillometry is looking okay. So it's a different issue ballgame altogether, and we are yet to know in which case what to be the best.
Yes, I think that is the consensus which holds today. For the adult patients, oscillometry is not a substitute for the spirometry. Rather, it complements the spirometry. But scenario is a bit different for the children who cannot perform spirometry. For them, the oscillometry is the only test that can be done to see the airway physiology. Okay, so I would like to ask Dr. Sharma. Dr. Sharma, what do you think that when we should actually refer a patient and whom is suspecting as having a small airway dysfunction to undergo the radiological evaluation? So, and what extra information the radiology can give us despite the patient is having some subtle signs and symptoms, and also the patient is having some very subtle spirometric changes?
So as far as radiology is concerned, it's quite sensitive in picking up even the subtler findings. So supposing there is a patient with deranged kind of spirometry, we are known to find a lot of features which actually correlate with your spirometry findings as well. So since you follow GOLD for COPD, so in that we have seen in the stage 2, 3 and 4, we are able to pick up a lot of findings as far as we are concerned, indirect and direct signs, as I had already explained. So we actually pick up emphysematous changes quite early these days with our collimation, which is quite thin as of now. So I think patients should be sent across for radiological examination as much as possible. In my last talk in Nabin crosstalk, we had a discussion where many of the clinicians raised a doubt about the amount of radiation that a patient has to undergo. But if you kind of compare the risk versus benefit analysis, I would still tell you that there is no data as such which says that radiation from a CT scan is causing tumor. If somebody can actually come across something, they can forward it across to me. So what I mean to say through my talk is the patient should undergo follow-up imaging after spirometry, also should undergo the first baseline imaging, so that we actually know the entire the temporal transition that a patient undergoes with the pathology.
Okay, thank you. So Dr. Mukherjee, I would like to ask that please let us discuss then what are the treatment options we have for a small airway disease?
Sir, at present we don't have much treatment options. There are small molecules which can be delivered in the distal airways that had been advocated for using in small airway diseases like beclomethasone, ultrafine particles. And so what I have understood about small airway diseases, treatment for small airway diseases, the recognition is important. Sometimes the systemic therapy may improve the impact of the small airway diseases, and these ultrafine particles are also being identified. What I think is more important is to identify the underlying small airway disease behind these clinically manifested disease so that we can pick them up early. If we can pick them up early, then we can think of treatments which are yet to come. But at present, the options of treatments are very limited for small airway disease. And that is why the investigations or clinical importance of small airway disease has also not picked up as it should.
Yeah, it is very right that what we have in our hand, okay, means one thing is the prevention. That is very, very important. That is the reduction in the exposure to, say, the biomass fuel and always the smoking. So, but apart from that, for the treatment, if we pick up a small airway dysfunction, then what we have, as you have just heard the talk and what Dr. Mukherjee has said, that the ultrafine particles only can reach the smaller airways. Fine particles, ultrafine means which are less than 2.1 microns in the diameter. And for that, the ultrafine particles we have in our hand the beclomethasone. And now also we have beclomethasone with the formoterol combination. So using this and also the specific type of the inhaler device, not only the particle size, but also the specific inhaler device which can generate this size of the particles, and then what these particles when they're going and they're impinging on the smaller airways and they're bringing about the result. But this brings us to a very, very important, pertinent, practical question. Okay, so which I would like to ask Dr. Mukherjee and Dr. Unnithan also, Dr. Ghosh also, and Dr. Bhattacharya also, or whosoever can participate. Say patient has come to you with a very subtle sign. Say subtle sign maybe some mild cough or having repeated cough and cold. You do a spirometry and find the spirometry to be normal, but you suspect that this patient can be, since you hear so much about the small airway dysfunction and this exposure, the patient living in a city where there's too much of pollution and things like that, and you suspect a small airway dysfunction and you do a lung oscillometry, you find that the small airway parameters, that is R5, R5 minus 20, AX, F-res, they're significantly raised. So then what you do? You have this is ultrafine particle beclomethasone. So do you start treating that patient with this, or do you wait and see see whether how the disease evolves? Dr. Mukherjee first.
Sir, I would definitely not start the treatment for this patient until unless patient is very symptomatic. And as per the description, patient doesn't seem to be very symptomatic because otherwise his spirometry is also okay. I will try to follow him up. I will try to give him good advices like cough hygiene, like not smoking, avoiding as much pollution as possible, and will really hope that patient will follow up with me and I know how the disease evolve. And I hope, as everybody has seen in the history of science, the new things are going to come. So if we can follow him up, we will definitely have options in the future. But at present, based on iOS abnormalities, putting him in a long-term beclomethasone inhalation, whether it is actually going to help him, I don't know. So I will not put him on the therapy.
Dr. Ghosh?
But in these cases where the symptoms are not much, what I do in my practice, I want to give some objective scoring to know details about the symptom sequence and all. Because when patient tells us symptoms and their severity, sometimes the severity of symptom is subjective. But if we give them a scoring sheet to score the CAT score on all the scores available, I sometimes found that their symptom score is much higher than what we can get from their only hearing. So symptom score is one thing. Another thing is if patient is asymptomatic, I will repeat the test in 3 to 6 months, and if it's still worsening, then I will start treatment.
Yeah, Dr. Nathan.
So, the kind of patient that you were talking about, most of them come to us like this with chronic cough, not very bad. They do sleep well, but they do have this chronic cough. So, for me, if I see a patient who has this kind of good variability in the reversibility in my impulse oscillometry, I would definitely treat the patient. And also, I have not used beclomethasone that much. These people respond very well to budesonide. So for me, my obvious choice would be budesonide inhalers. Maybe we might. There is this Nivioli. I think there was one inhaler which had a ultrafine. This one we had used some patients with beclomethasone, but I didn't see much difference between budesonide and beclomethasone, frankly.
Okay, so means one thing is clear that if this patient doesn't have a much high symptom load, we do not start the patient on a corticosteroid in any form, whether it's inhaled. If this patient symptom score increases, then we start the patients on treatment. Then comes the question, what treatment? Whether it's a conventional ICS or it's an ultrafine particle ICS. So there we do not have the answer yet. But I would just like to end the thing with one very interesting observation, which was done quite long back. It was in say in early 20th century. There was a very famous scientist, brave scientist, I would say, from Canada. His name is Dr. Hargreave. Okay. So from Dr. Hargreave's lab, Dr. Hargreave and Dolovich, what they found, they found a very interesting observation. They saw the patients coming to them having cough. Okay, frequently coming to having frequent cough, but they say that it is not an asthma because at that time they only used to say asthma when the patient had an airway hyperresponsiveness. So these patients did not had airway hyperresponsiveness, but so they did not have an asthma, but they had cough. And these patients, they did an sputum analysis also, and they found these patients to be having increased eosinophils. And eosinophil having increased eosinophilic inflammation was pathognomic of asthma of that time. So they said that these patients have an cough, but no asthma, but asthmatic inflammation. And what they did to this patient is that they treated those patients with a corticosteroid. And they got the good response from that. Well, by that observation, they broke the nexus between the eosinophilic inflammation and the airway hyperresponsiveness in the asthma. That's a different story. But in today's time, also we have to use our prudence and our knowledge and also for each patient individualized to say that whether this patient has to be treated, and if treated, does they need the ultrafine particle beclomethasone, or will the normal usually the anal corticosteroid is going to work good in this patient. So that is still an open question. I think more and more with the time comes we'll have the answer for it. Okay, if anything else you want to add at the end?
I want to, in this patient, I would like to do a CT scan, sir.
Yeah.
Because that can give some
Yes,
insights.
yes. So there I was thinking that in these patients, the radiology comes in hand, where we can see that where there is significant of air trapping or something like that. Maybe we would like to start these patients on an ultrafine particle doses. Thank you.
Okay, so now we move on to the next session. Actually, this is the session that was scheduled to be done in Hall B, but now we are doing it in Hall A. So that this session is the mucus management in airway diseases. And for this talk, I would like to invite our coordinator for the talk, Dr. Milind Baldi, sir, and our expert panelist, Dr. Shrudeep Ghosh. Would you please take the chair for panelist? And I would hand over the proceedings to Dr. Baldi, sir.
Yeah, all right. So lot of small airways we have discussed. Let's see something which we deal with in practice every day. So the part of country where I come from, cough is basically sputum. So patient typically comes to you and says, cough aata hai. And you're like, okay, it's dry or wet. They say, cough is sputum. So the confusion goes on. Basically, what I want to say is this is a very, very common scenario which we see in practice is how to manage mucus. There's no khasi, but there's cough, and so on and so forth. Similarly, again, if you can really make a difference in patient's life and make the relatives appreciated as well, be it any chronic respiratory disease, pulmonary rehab has a very, very big role. So I think this is a very interesting session. I agree, it's the end of the day. There are snacks being served as well, so please help yourselves. But yeah, so I'll like to invite Dr. Avya Bansal for the talk on mucus management and airway diseases. Can I have the introduction slide, please? All right, so Dr. Bansal is a pulmonologist and sleep medicine, and all right, he is coming to share his experience right from Mumbai with us. All right, over to you.
Good evening. At the onset, I'd like to thank Parthasarathi sir for giving me this opportunity to come to this wonderful city once again and share my experience in mucus management in airway diseases. Now, we all see our airway disease patients, namely asthmatic COPDs, your bronchiectasis patients, and they often have a very high tolerance level to cough and not cough like we often associate. Even in Bombay, Indore belt is similar, so they often say that. So the tolerance level and the threshold for coughing is pretty high. But when we start talking about phlegm production, that's something which really bothers them and irks them, and they really can't deal with this phlegm production. So we often treat them, we address the coughing issues, but the phlegm production and the phlegm management sometimes goes unnoticed, and we tend to tell them that yes, as and when the disease gets controlled, as and when the disease becomes better, the phlegm production will automatically come down, the inflammation in the airways will reduce, the multiplication of the cells will reduce, and you will get symptomatically better. I've noticed very often that if we give some stress in mucus management and airway clearance in all our airway disease patients, the symptom control is far better, and we achieve a relatively less decline in lung function over a period of time. So this is going to be the essence of my talk today. Now, just to share a fair bit of highlight on what is mucus, it's basically an extracellular gel mixed with water and glycoproteins. It's commonly observed in hypersecretion in all our airway disorders, asthma, COPD, bronchiectasis. We don't see that much of cystic fibrosis because of underreporting and less diagnosis. Effective mucus clearance is an important defense mechanism against harmful environmental exposures, your noxious chemicals, tobacco, smoking, infections, and an excessive mucus production or an impaired mucociliary clearance. Now, this is something which reminds me of my postgrad days where we had this term as Cole's vicious cycle of an excessive mucus production, an impaired mucociliary clearance, which results in eventually stasis of a lot of secretions, and eventually there's pooling and harboring of bacteria, which further causes excessive mucus production. So that vicious cycle keeps going on, and you really can't seem to find a break in that cycle. And that cycle over a period of time will cause some trauma and damage to your airways and result in a decline in lung function in your asthmatics and COPD patients. In your bronchiectasis, it will cause further rapid decline by destroying the already destroyed airways. In the beginning of the talk in the morning, we had fibrosis begets fibrosis. I would like to use the similar analogy that mucus begets mucus and destruction begets destruction in the pathophysiology of mucus management. Again, the structure of mucus is what we've already seen in the previous slide. I've told you, you've got a mucus layer, which is a periciliary layer. You've got the pericylia, which is pushing the mucus forward, and eventually it's all getting either absorbed or swallowed. You've got your ciliated and your secretory cells, which are present all along your airways, which result in production of the mucus. A normal mucociliary clearance is essentially important in our pathway. We produce a lot of phlegm. Some of us are habitually high producers of phlegm and some of us are low producers of phlegm. It changes with season. It's a genetic predisposition. We really don't have much understanding as to the amount of phlegm we produce in different seasons. But yes, our natural cilia and clearance mechanism also gets adjusted with the environmental changes. And only when the adjustment doesn't happen, there is an increased production or some cause for an impaired clearance, is when we have a lot of phlegm which gets accumulated. A simple infection can also transiently reduce the mucociliary clearance by inactivating the cilia to a certain extent. We've got some articles which do tell us that the mucociliary clearance gets impaired with infections as well. Discuss the production and secretion of polymeric mucins in healthy individuals. That's the first slide. Got a pointer. There's multiplication of the goblet cells, the secretory and ciliated cells, which eventually increase the production, and you have degranulation of these cells, which cause a thick layer over the airway. Now, why it's so important? What is the prevalence of excessive mucus? Now, a retrospective analysis was done in 2022 and a CT scan was observed and done to find out there's actually how much airway involvement and mucus production in our asthmatics and COPDs, how much retained secretions is what we would call them, and about 60% asthmatics, 65% ACOS patients and 40% of COPD patients had excessive mucus production and retained secretions. Now this is very confounding because we've generally not associated asthma with mucus production. We've always thought that the chronic bronchitis variety and the bronchiectasis are the ones who retain secretions, but an intrinsic perspective that asthmatics do produce a lot of phlegm and it can cause a rapid decline in lung function as well. Coming to the much important discussion which preceded my talk about small airways is that mucus production also results in a reduced forced vital capacity and the resonating frequency, which is very, very intrinsic in the development and progression of a small airway disorder as well. The pathophysiology of small airways, when we studied, mucus plugging, mucus impaction, and progression of mucus involvement causes a rapid decline in the lung function and increases the symptomatology in patients with small airway disease as well. Asthmatics, ACOS patients have a positive correlation between Ig levels and FeNO. This really doesn't tell us that a low FeNO and a low Ig means that the patients don't produce phlegm. It just tells us that high Ig and high FeNO levels, there's a higher inflammation which is happening in the airways. As a result, probably the cells are multiplying more and producing more phlegm. COPD patients, because of noxious exposure to toxins, chemicals, whether it's biomass or smoke, results in hyperplasia and multiplication of the cells and excessive production. Small airway dysfunction is also associated with mucus plugging and eventually causes a rapid decline in the forced vital capacity. Now, asthmatics genetically have a higher level of MUC5AC, which is the main gel-forming mucin. The 5B component is also marginally elevated as compared to healthy individuals, but it's the MUC5AC which is responsible for high levels of mucus production. The raised mucus levels in asthmatics are because of goblet cell hyperplasia as well as a constant inflammatory process which is happening due to exposure. There's eventually hypertrophy of the cells and it impairs the ability for absorption of this. Interleukin 13 and to a certain level interleukin 4 has also been postulated to help, which is why dupilumab, the study which was done, it also showed that patients had lesser exacerbations because of lesser production of phlegm. This was one of the reasons why dupilumab was considered superior in those studies. Mucus in COPD, the pathophysiology of mucus in COPD is because of an inflammatory cascade as a result of your exposure. There's an increase in the EGFR which causes mucus production as well as goblet cell hyperplasia. Tumor necrosis factor alpha in COPD asthmatics, in COPD smokers also causes an increase in mucus production. Now, this is an interesting graphical representation. Now, if you can just understand this at the end of today's discussion, it is, I would be very, very happy as to what happens in a basic individual. Now, in a normal person, there is mucus production, the plasma proteins are normally present, and there are some amount of inflammatory cells. But there's no bacteria, there's no stasis, there's no pooling, the airways are clear. In asthmatics, there's excessive mucin, there's excessive proteins, there's excessive inflammation which is happening, but there's no bacteria. Now, there's no bacteria initially, but if these mucus and mucus plugs and retained secretions persist for a period of time, then they'll get infected. Now, you see the airway lumen is partially narrowed as a result of this mucus layer which is formed, which worsens the obstruction. Coming to COPD, exactly similar to asthma, but the amount of proteins present are lesser and the bacteria is present. And when we come to cystic fibrosis, just multiply that bacteria by tenfold. Cystic fibrosis and bronchiectasis have a very similar picture in the quality of sputum and the bacteria content of the sputum or the mucus which is there in the airways. Now, how do we treat this? We've all spoken about mucus production, airways accumulating mucus. Now, how do we treat it? The most important factor is reducing the production of the mucus. Glucocorticoids have been essentially the most important drugs which have been used in asthma management, which reduces inflammation and thereby reduces mucus production. The role of glucocorticoids in COPD and bronchiectasis is only restricted to severe group E COPD patients and recurrent exacerbators of bronchiectasis which are non-infective by reducing the amount of mucus production. Certain products which are in trial, that's MARC5 inhibitors and Botox, there are still studies underway which tell us that these are potentially good factors which will reduce mucin secretion by acting on MUC5A and B and thereby help in the amount of mucus production to a lesser level. The more common agents which are used in practice are physiotherapy. I strongly feel that physiotherapy is a very neglected field in asthmatics. We often stress the need for a rehabilitation in our COPD bronchiectasis patients. But even our chronic asthmatics, if taught a couple of sessions of good airway clearance and postural drainage with PEP devices, tend to benefit a lot and have lesser exacerbations as compared to the counterparts who have not received some amount of physiotherapy. Bronchodilators are the cornerstone of treatment of any airway disorder being symptomatic. It's a very simple thing. The airway is narrow, so the amount of phlegm is same. The expectoration of the phlegm will become more difficult from a narrow airway. So if the airway lumen is broad, it's large, there's no bronchoconstriction, it's easier for the mucus to be cleared. Inhale alpha was used in the past, but we don't use it anymore. There are studies which tell us that it really doesn't help. Inhaled hypertonic saline should be used cautiously. It's used quite a bit in cystic fibrosis patients and it helps in reducing the amount of mucus which gets stuck to the airways and helps in expectoration. But there's a catch with hypertonic saline as it can sometimes precipitate an exacerbation. So we need to be really careful with that. Now, one of the my favorite products is N-acetylcysteine. I've used it quite a bit in bronchiectasis and COPD patients. What it does is it basically breaks down your disulfide bonds, makes the phlegm thinner and easier to expectorate. So what we routinely practice in our rehab OPD is we nebulize the patient with N-acetylcysteine, have a positive pressure device and an ACBT, and eventually at the end of the session the patient coughs out a lot of phlegm and feels much better, and then we encourage the same practice at home. So N-acetylcysteine in cystic fibrosis, bronchiectasis is already well documented. Even in COPD and asthma, it does help in expectorating and reducing the amount of phlegm in the airways. But again, we must be careful about a reflex bronchospasm which could be initiated. Inhale antibiotics only and only if you're suspecting colonization of the mucus with bacteria. The inhaled antibiotics which we commonly use are tobramycin and colistin, in that too in only bronchiectasis and cystic fibrosis patients to eliminate Pseudomonas. And to a certain extent, oral antibiotics such as azithromycin as a long-term therapy, thrice a week therapy, has known to be an anti-inflammatory effect in COPD patients, and thereby it partially helps in reducing mucus production. Thank you.
Thank you, Dr. Avia, for crisp and really insightful talk. Next is pulmonary rehab, specifically in COPD, and the topic is perception to organization and translation practice. I would like to invite my teacher, Dr. Alpa Dalal. She's coming all the way from Mumbai to deliver this talk.
Good evening, all of you. Let me, at the outset, thank Dr. Bhattacharya and the Pulmocon team for inviting me here. We've had extensive session today and a lot of work for the left brain. So today I'm not going to use the left brain at all. It's just about, there is enough evidence that pulmonary rehab is very, very useful and all of us are actually convinced. But it's just that we are not able to develop the program because there are so many challenges. So today I'm not going to discuss about any evidence or any theory aspect of it. Neither am I going to present any cases, but it's just that how do you actually bring about to develop a pulmonary rehab department and a very good pulmonary rehab program, and what challenges we face while doing that, and how did we overcome that. So I would like to know how many of you have access to a good pulmonary rehab department in your hospitals. Yeah, from Mumbai locally. So I think here maybe 2 or 3, not many. Okay. So apart from not having a pulmonary rehab, do you have a smaller setup where you actually, to a lesser extent, you've been able to do pulmonary rehab? Okay. So the topic given to me by Dr. Bhattacharya is perception to organization and translation. Okay. So when you want to develop any program for that matter, let's talk about pulmonary rehab. You need 3 things coming together. First of all, you should have a strong will, a strong intention, and that's of course very important. Unless you have a strong will, you'll not go about it. The second aspect is skills and knowledge, and that's very important. Having a good rehab team, they know how to work with the patient, what skills are required, what equipments are required, pulmonologists knowing their skills, all that is very important. So the second part is very important, that's skills and knowledge. But the third part, that's action and implementation, and that's usually the bottleneck, and that's what we feel that in spite of having a strong will, in spite of having skills and knowledge, what we are not able to do is action and implementation, because action and implementation does not just involve you, but it involves the patient, it involves the system, it involves the administrative support. So how do you get all the 3 things together to develop a good program? And it's about a teamwork, especially the rehab part, because as individuals you can develop your practice, but when you want to develop a rehab program, it's a teamwork. And we all know, and we have seen our patient doing so well with rehabilitation. Literally, they start flying high when they complete their good rehab program. But we are able to do this in very few patients because we are not able to overcome the challenges. So the pulmonology team, the administration team is very important. They have to get convinced about it. Cardiopulmonary rehab team, patient and the caregivers. So all have to come together. When do we get the result? The intention of all the stakeholders, the knowledge and action, when it comes together, then we are able to get the result. And of course, everybody will look at this from a different perspective, but there has to be some common goals. And if everybody is on the same page, some common goal, then it can be developed as a great team and we can get fantastic results. So whenever you are trying to develop a program, so there are many trainees I see that few years down the line, you will start your own setup or you will join some organization, an institute, and you may not have all the facility available that you are having now as students in well-developed department. So you can start very small, okay? And whatever resources you have small space, equipment or human resource, you can start small. And that is how we started, I wanted to develop this rehab program for a very, very long time, but somehow my management and administration was not convinced about it. But it so happened that luckily they were very much interested in developing a transplant program, and having a pulmonary rehab department was a must to have a transplant program. And that's how I was able to get a good rehab specialist. So she started as part of the general physiotherapy department, which usually you shouldn't do. And she started working with whatever equipments were available. Okay. Then over a period of time, we really started doing well. We started getting great results, and the department started growing. So 8 years down the line, now we have 4 physiotherapists, cardiopulmonary rehab. So out of them, 3 are cardiopulmonary rehab specialists. One is a BPT. We have around 2,000 square feet of area which is developed for general rehab, which includes neuro rehab also, and we have all the equipment, and they are doing extremely well in this. We have also published papers. So starting small is very important. Don't wait for the ideal thing to happen and then only start the department. Whatever resources you are available, you can start doing things. So this is what we have. And I'm so glad our management at Jupiter Hospital, Milind is also here, he is in Jupiter Indore. They are very much pro rehabilitation. They are very passionate about rehabilitation, and that's a very great thing to have. So minimum space that you would need is 500 square feet. What equipments do you need? You need a cycle, you need treadmill, telemetry, especially when you want to do patients who have cardiac issues or who have pulmonary hypertension. Then you need telemetry. You need some weights, therabands, one exercise ball, BP apparatus, pulse oximeter. If you have staircase, that's good enough. If you don't have staircase, then a stepper. So these are the basic requirements that you need to have. Okay. What kind of human resource do you need? A cardiopulmonary rehab specialist is a must, and she should be heading the program. And that program should be separate from your general physiotherapy, because many times I see that they are made to join the general physiotherapy, and they are also, when the numbers are not there, they are made to do general physiotherapy work, which it should not be, because it dilutes the entire program. Associate could be BPT, and you need a nurse. So nurse, a BPT, associate, and cardiopulmonary rehab specialist, they should be full-time. Nutritionist can be part-time, a psychologist can be part-time. Many times a rehab specialist herself ends up doing counseling. What different kind of pulmonary rehab interventions can you do? And as we know, and the evidence says, the institutional based outpatient department rehab is the best thing that you can do patient. They will be working on their breath retraining, they'll be doing upper arm training, they'll be doing lower limb training, developing endurance, aerobic exercises, and that's the ideal kind of scenario. And the ideal number of sessions should be at least 36, that's spanning over 3 months. But if that's not possible, minimum 12. It should not be less than 12 sessions. Inpatients also, we start doing inpatient rehabilitation many times. The patient, when they are in the hospital, they are sensitized and introduced to this concept, and then they end up continuing in OPD basis. Hybrid model. Now many times, many of the clinicians I have talked to, and they say that biggest challenge is that they are training to a big area and patients are coming from periphery, from far off distances, and they don't want to come and travel and do the exercise, and that's the biggest challenge. So for these patients, we create a hybrid model. So let them do one session at least a week, sometimes 2 sessions a week, and rest of the session they do it at home. Now here I would say the clinician's role is very important. How do you make your patient realize the value of pulmonary rehab? So if you have diagnosed your patient with lung cancer, and if you tell them that you have to come and take 25 cycles of radiotherapy, do they ever question you? Oh doctor, I'm staying so far away and I cannot come. They will never tell you. If you ask them to do weekly chemotherapy, they will never say no. This is how, if you make them realize the importance of pulmonary rehab is as important as a chemotherapy for cancer patient or radiotherapy, then they would end up doing it. So that's very important. But if the distance is a challenge, then you can develop a hybrid model. Home-based rehab can be developed, especially for your patients who are mild or moderate, not very severe patients, COPD patient, you can do home-based. You can also arrange for home visits. Now some of the pharma companies have taken the initiative and they have developed the rehab program where the rehab specialist goes and visits at home. So that can also be done. Tele-rehabilitation is something which we tried during COVID times. Again, here there are limitations. Patient should be well versed with the technology. Patient should not be very unstable, maybe mild or moderate disease, not being oxygen dependent, able to have a net connectivity, able to understand the instructions in these situations. Then you can definitely offer tele-rehab, and that works. And if not anything, if patient is not able to do anything, then even a single consultation for about 1 hour, 1.5 hours would be a great idea to start off with. Okay. So what do you do in a single consultation? So many of our patients, when they come from faraway places. We also get patients coming from other states also. So we make sure that our rehab specialist, she takes walk-in patients, and we have one long consultation for this patient. So what is taught in this single consultation? breath retraining is a very important aspect, and we think is pretty easy, but all our patients of COPD and ILDs, they have completely changed breathing pattern. So breath retraining is very important. Just now Dr. Avia talked about the mucus clearance, so autogenic drainage and other techniques. We make them use instruments like a cappella or aerobica and make them do the mucus clearance, and that's also very, very helpful. Breath pacing is something where patients are to how to pace their breath with activities, and that does a great deal to improve their activity levels. Planning their activity. So many patients, they are not aware how to plan their activity, and for doing one single or two tasks, they end up wasting so much of their energy. So activity planning and energy conservation techniques. Exercise planning. So we have had some of the severe COPD patient, elderly patients who are not able to come to the center, and simple exercise planning like every 2 hours just to sitting up and down on the chair, every few hours making 10-15 rounds around the house. Doing that much also makes almost 25-30% improvement in their symptoms. Okay, and most importantly, correcting the wrong practices. This is pretty common. Many of our patients are doing some yoga exercises from somebody who claims to solve all their problem by just doing yoga. Many of them have learned from some other places and they are doing wrong breathing practices. So this is very important. For example, using incentive spirometry is such a common thing, and in COPD patient that's absolutely contraindicated. So these things also done in a single consultation will go a long way to improve your patient's outcome. What has been our experience? So a monthly enrollment for central-based rehab is 20 to 25 patients for cardiac and pulmonary both. Out of that, pulmonary rehab is about 50%. So 11 to 12% patients in a month get enrolled for the rehab program. Highest so far we have had 25 patients enrolling for the month and almost 90% of them completing 1 month 12 sessions. Okay. Patient doing center-based PR, 60% of our total PR referral patients are doing center-based pulmonary rehab, and dropout rate is less than 5%, which I would say is really very good. Remaining 40% will do some form of hybrid model, and 50% of them will at least follow up. So this is very important. So you have to negotiate with the patient. If they are not doing full, then it is come once a week. Saturday is usually off day for their caregivers, and they are able to get the patient at least once a week. So this you have to work out. What do we offer? We offer center-based pulmonary rehab, home program. We now have good number of, we have 4 therapists, so they go home, visit the patient. We also teach them yoga and meditation. In fact, from 2012 to 2019, we ran a rehab yoga and meditation program. Unfortunately, during COVID time, it stopped, and now we are going to revive again. We do something innovative called sound therapy. We use some Tibetan bowls to do a group session for them, and all this really helps them to have a good follow-up, and their compliance is good. So this is our rehab area. So at times when I go to visit, I see all my patients, 3-4 of them wearing the shoes and doing the exercises very enthusiastically, and it feels so nice to see them doing that and then following them up to see their outcome. So this is the big area that we have now got after 4-5 years, and see the different thing they've been doing. This patient is a post-COVID. He was admitted in ICU for 2 weeks, a severe post-COVID fibrosis. Now he's been rehabilitated and back to work. Okay. This is our yoga program, breathing exercise, Kriya Yoga, meditation, group counseling, also spiritual counseling, sound therapy, all these different things we do. The sound therapy we use for OPD patients in endoscopy, daycare, ICU. Patient really connect well to this. They're very happy. These are online sessions. Sometimes we do group sessions. This is a study we had done in COPD patients. So 15 patients of COPD in control arm and intervention arm. And the intervention that we gave was breathing exercises, meditation, and sound therapy. And we checked their SGRQ scores, HAT score, and PFT. And what we found that the group that received the yoga, breathing exercise, and meditation, their 6-minute walk distance remained stable, while the control group, their 6-minute walk distance dropped. And SGRQ scores improved in the patient who received the yoga and meditation. So common challenges that we have, an assessment in public and private sector pulmonary rehab centers in India. So our therapists had visited quite a few centers in public sector and PR center, private sector, and they found that lack of trained manpower is a big challenge. You know, majority of the time you don't find a trained cardiopulmonary rehab specialist. During their training also they have challenge. Those who do training in public sector hospitals, many times patients don't come back and end up completing 12 sessions. So they don't get that experience of managing this patient, you know, having a complete center-based PR. And in private sector, again, very few hospitals are investing into developing them, so they don't get trained. So that's the issue. Patient compliance and conversion rate is usually very poor in most of the center. We saw just 10 to 15% of the patients who are referred, they end up getting converted. Administrative will is a problem. Communication gap between pulmonologists and rehab specialists. You know, sometimes patients are just referred to the rehab, say, जाके एक session करके आओ, or you just do it, and no counseling is done, and these patients are never going to get converted. So communication between the rehab team and clinicians is extremely important. Independent PR departments are not there, and lack of awareness among clinicians, among patients, it's again very common. So let's talk about the administrative perspective. If you're working in a multi-specialty hospital, a corporate hospital, how do you convince your administration that it's very useful? And I interviewed actually my administrative, chief as to how do you look at it? You know, so she said that 3 things they will look at: investment in space, investment in manpower, and revenue generation. How this is going to be, and it's your thing how you can convince them. So what are the administrative perspective? So it said that if department starts becoming self-sustained in 2 to 3 years time, that's good enough. But having said that, these are about direct benefits, but it does give them lot of collateral benefits, and that's what it happened with us. So it is a big value addition, and it helped create a niche. You know, nowadays many patients just search on the net before they will come to you, or they will come visit a hospital. So having a well-developed pulmonary rehab will actually give a lot of goodwill and lot of credibility to your institute. He said it helps you to position your institute in the competitive market, that here is an institute which is offering some intervention which is actually going to make them less dependent on the healthcare resources. Then their credibility amongst the patient really goes up. It helped to create branding, goodwill, and trust, and also patient retention and referrals. In fact, so many times patients prefer to come and get, enrolled in the pulmonary department because the rehab facilities are available. Many center who are having transplant program, now they are referring the patient to us because you go to this hospital because pulmonary rehab is available. So your institute has to have a long-term vision that yes, this rehab department will give you a lot of collateral benefits. What is going to be clinician perspective? What will make them happy? See, if I'll be very happy with diagnostic and rehabilitation is available under one roof. Again, like what advantage the institute has, it will also help me to develop my practice better, patient retention, patient referral, creating goodwill, and it gives so much of satisfaction to have the improved outcome. No? So a lot of collateral benefits of rehab is there. Just recently, I had a patient, young patient who had post-TB OAD, and she just about visited many hospitals in city of Mumbai. And this young lady of 35 having 3 kids with severe post-TB OAD just could not do her normal activities. We couldn't change much of pharmacotherapy, but we enrolled her for pulmonary rehab, and after 12 sessions, she came one day very happy. She said, after years, I could play with my kids. And the kids were so excited, they told father that she's able to play with us, and that is such a big thing. She could go and do shopping for 4 hours, And she was so happy that so many years I lost, and why was I not suggested ever to undergo pulmonary rehab? These are the kind of feedbacks we get, and this is how a great difference rehab can make. What would be the patient's and caregiver's perspective? So if a patient is able to do independent functioning, start having social participation, get control of symptoms, and is able to prevent the exacerbation, it ultimately that's a financial benefit also. It will be reduced burden on finances and manpower. So this is the patient's perspective. So you need to create the awareness among the clinician and patient that what is the right time to refer the patient. Don't wait till the patient becomes so breathless that they're not able to do the routine activity or they are put on oxygen. The right time to refer would be when the patient start to limit their leisure activities. Now that is the right time to start referring a patient to prevent them worsening. And what would be the rehab team perspective? A cardiopulmonary rehab team would like to have independent functioning. So don't make them part of the general physiotherapy. They would like a lot of mentoring from you, a lot of communication, interaction from you. Respect and communication is very important. Many times that is also lacking because we don't understand their aspect and we would just say, you go and refer the patient without having any much expectation from that. So that should not be there. And you together should be having realistic goal setting. What is the patient condition? What is the severity? What are the expectations of the patient? And as a clinician and as rehab specialist, you have to sit together and have a realistic goal and work together. And after completing 12 session, patient comes back to us, we assess, we review, do pulmonary function tests. It so happens that many times rehab may not be working the way it should be, then change our strategy. All these things have to happen. So what's the pulmonologist's role? Very important. Counseling the patient and the family, and that is what I do. Many times I tell them that, look, more than me, this rehab specialist give you much more happiness. It will make you independent, and this is much more useful than what the clinician role is now. And good counseling, it makes a lot of difference. And my rehab specialist says that when the patient is counseled by the relative, the chances of conversion increases 3 times, and that's very important. Optimize your treatment. Many times you haven't really optimized your patient, and as a last resort, if abhi kuch nahi ho raha hai, refer to the rehab specialist, then they'll take care. So that should not be there. Early referral when the leisure activities start getting limited. Communication. So we specifically write what they want, or we communicate with them. We go and talk. We are actually in the same cluster. So every day she would come and give us feedback. We spend about 15-20 minutes discussing all our patients. Okay, setting up realistic goal and assessment. Okay, so this is my last 1 or 2 slide. Perception to translation. How do we align 3 things? Your intention, will, skills and knowledge, and action. So create awareness. We need to create awareness, and these kind of sessions are actually required. Create a center of excellence, which we have done now with 8 years of good work. And then these models can be replicated. Okay, teaching and training is very important. So online training, case discussion, all that has to be done. Some center which has developed well, they can help in training other centers and developing teams and document and create research and publication. Okay, thank you so much for your patient hearing. If I've been able to motivate few of you to start a good PR program, I'll be very happy.
Thank you, ma'am. Not only few, all of us who are sitting here, I'm sure are motivated to go back and start. That was really inspiring. I would like to invite the next speaker, Dr. Rick, who's a faculty from IPCR, for sharing IPCR experience of COPD rehab.
Actually, there has been a slight change. Sir, I will take over. So we will take up the industry symposium first. It will be just a 15 to 20 minutes talk by Dr. P.R. Mohapatra, P.N. Mohapatra. Can I have the slide, please? Ah, they have. There is a industry symposium on medical oncology. For this, we have amongst us Dr. P.N. Mohapatra. Sir, he is the Director of Medical Oncology at the Apollo Cancer Center, Kolkata, and he has an experience of nearly 28 years in the field of medical oncology. He has been a very part of various national and global clinical trials in medical oncology. So, may I now invite Dr. P.N. Mohapatra, sir, to please start his session.
Thank you, Dr. Bhattacharya. Actually, I've got some common cold, that's why I sore throat. Actually, this is about the management of lung cancer. Just basic slides. I'm not going into detail. What data we have actually, this is Globacon 2020. Actually, if you see worldwide, lung cancer is actually the most deadly cancer actually. If you see the number of cancer, male and female, breast actually is the most common, but lung cancer is the most deadly. But if you see India, actually we have breast cancers, we have breast cancer diagnosed very late. Western countries they are diagnosed early. So breast is the most common cause of cancer and cancer death also. Lip and oral cavity or head and neck cancer is the second, and cervix, which is very uncommon in Western countries, is very common, third common. Then fourth, lung is the first common cause of cancer and cancer death. So actually, I think pulmonologist must be our, what we see actually is more advanced lung cancer than early lung cancer actually. In India, actually, if you see the males, actually only 14%, in females only 15 to 17%, they are actually operable early breast cancer, I mean, early lung cancer. But others are actually metastatic or stage 3. Now are getting more stage 3 patients. So, but stage 3 still the prognosis is not that good as stage 1 and stage 2 patient. This is the lung cancer actually survival. If you see stage 1, we hardly see any stage 1 patient. But if you see stage 1, you do surgery, you have a good survival. But we hardly see any stage 1 patient actually. What we see more is advanced stage lung cancer. This is the risk factor actually. Is smoking, radon gas actually, mainly in the newly built houses. This is smokeless. You cannot detect newly built houses. Radon gas actually. Pollution, asbestos is nowadays very less common, but other diesel, nickel, chromium, these are the pollutants actually. Family history, what we are seeing, more lung cancer, somebody have a lung cancer. It is actually not proven genetically which gene causes the lung cancer, but if somebody has a lung cancer, there are more chance to have a lung cancer. Radiation, especially childhood radiation, breast cancer radiation, childhood radiation for lymphoma actually, then those patients can develop lung cancer in long run. If you see lung cancer, actually, we divide it as a non-small cell lung cancer and small cell actually. Non-small cell is actually most common, 85%, and small cell is 15%. So now more adenocarcinoma around 40%,
And actually large cell adenocarcinoma actually it's a pathological diagnosis. We hardly see any large cell carcinoma. We see more adenocarcinoma diagnosis. It's squamous actually. And others like sarcomatous carcinoma uh, and adenosquamous actually. Adenosquamous are more treated like adenocarcinoma. This is the small cell carcinoma. Lung cancer itself is very bad, but if you tell which is the worst, it is the small cell carcinoma because they don't have the mutation, the treatment, whatever the best you give with immunotherapy. Till now, there is only 2, 3 immunotherapy which are approved with chemotherapy. If you give the immunotherapy, also you have a survival of only 1 year, medial survival. But some patient, 15% of the patient may be doing well post 3 years. Actually, if you combine immunotherapy, chemotherapy, only chemotherapy, they recover very fast. But very few patients do well. We recently had a patient of Arunachal Pradesh, extensive small cell carcinoma. We treated with chemotherapy. They were taking home, but we treated with 80 years. We treated with chemotherapy, then gave radiation, just giving oral etoposide. Last 3 years, he is doing well. This is the small cell carcinoma. We use chemotherapy, cisplatin, etoposide, irinotecan, and we have 2 immunotherapy drugs, atezolizumab and durvalumab actually. Recently, another immunotherapy got approved. Everybody same result actually. This is the non-small cell carcinoma actually. What you in the beginning, what we were doing, any lung cancer, we are giving chemotherapy. Then we learned slowly this is a histological based chemotherapy. It is if it is a adenocarcinoma, different chemotherapy. If it is squamous cell carcinoma, different chemotherapy. Now what we do molecular profiling. Actually 50% of the patient have some mutation and a mutation we give treatment actually. Recently one lung cancer very poor patient he was having a exon 14 beta skipping mutation. Actually the drugs are capmatinib and tepotinib. Actually, they are costly more than 1 lakhs. Actually, he is not. He took chemotherapy in Swasthya Sati. Disease progressed. Then there is second generation inhibitors. Actually, cabozantinib. Patient was very bad. We gave cabozantinib. That is cost Indian brands around 5,000 rupees. And patient came after 20 days. Patient walking. Patient came like that. That's how the modern medicine is. Treating the oncology patients. This you can see the mutations actually, and every mutation, 50% of the lung cancer will have a mutation. And we have drugs actually for mutation. Some are in India, some we are managing, somehow we are managing the patient for something we are managing. If you go deep, we will have some drugs, some patients, some treatments. Actually, lung cancer, you need a pulmonologist, you need a rehab team actually. It is a multidisciplinary team. You need pulmonologist, you need medical oncologist, radiation oncologist, surgeon, everybody you need. This is the staging of the lung cancer. Everybody know it is a stage 1 to stage 2 early. You have lymph nodes in the same side in the lung cancer. Stage 3 is opposite side of the lung, you have lymph nodes. Stage 4 is actually spreaded. Either stage 3 is opposite side or scalene or supraclavicular nodes actually. The treatment staging is done at the baseline when you start the diagnosis and evaluate the patient. This is the standard of care. If somebody is operable, actually you do a tumor board, there must be surgeon, radiation oncologist, pulmonologist. You do a tumor board, basic resectability. If there is no money, if it's resectable, we are resecting, giving chemotherapy. But things are little changing here actually. Nowadays, immunotherapy with chemotherapy combination will come on the front line. You start with immunochemotherapy, do surgery, then continue immunotherapy. Nowadays, what we are doing actually, during surgery, the biopsy, we are doing EGFR because if EGFR is positive, post surgery, we can give targeted drugs for 3 years with excellent result. or we are doing PDL1. If PDL1 is positive, we are giving immunotherapy, or at least affording immunotherapy to the patients. This is the surgical resection actually. We can do lobectomy. A standard of the surgery is lobectomy. Pneumonectomy, good patient. Opposite lung is very good. Proximal tumors, where the if you remove the lung, actually one lung, then opposite lung he can carry over, he or she can carry over. That is. But some old patient, very localized disease, towards segmental resections. This is the early stage lung cancer. If you do surgery, then you have to give chemotherapy. What are the analysis of chemotherapy? Whatever chemotherapy you use, there's a platinum based. The survival they increase by 5%. But what happens if you give chemotherapy also? There is high recurrence. In stage 1B, 45%, stage 2, around 60%, and stage 3 around 3A is around 75%. So maximum patient will recur post surgery and post chemotherapy. This is the actually trial which changed how you manage lung cancer actually. In lung cancer, adenocarcinoma is more common, and adenocarcinoma in India, actually 30% patient may have a mutation, EGFR mutation. If somebody, in the baseline we are doing EGFR mutation, if somebody is operable, recently one patient came, actually we did lung surgery and we sent the biopsy, and biopsy got EGFR mutation. So what we are doing, we are giving chemotherapy, very young patient from Mizoram, and we will give osimertinib for 3 years. Why? You can see actually this trial actually. If you see this trial, you can see the difference actually. Median PFS is more than 5 years, where you get 2 years in placebo if you give surgery and chemotherapy. And this is stage 1B, stage 2, stage 3A. But if you 1B is good stage actually. If it's 2, 3A, if you remove 1B, the osimertinib is better actually, more helpful. And recently the OS has also come, and OS hazard ratio is around 0.49 actually. So it is very effective with the hazard ratio in 0.49 in lung cancer. This is very good. This is the stage 3 actually. Till 3A it may be operable, but 3B, 3C it's not operable. So what we do, we discuss pulmonary function test is go okay. We give chemoradiation actually, whether it is a chemoradiation concurrent or sequential. This is actually we either do discuss in a tumor board, but or individually we discuss. We send the patient for individual discussion, and we see with the, whether the chemoradiation is possible or not. With chemoradiation, actually outcome is very poor. Actually, what we give weekly chemotherapy with radiation and 2 chemotherapy. Till we get actually immunotherapy, that is durvalumab actually. We can see 3 year actually OS is by only 9% if you give only chemoradiation. But what we see with if you give immunotherapy, because if you give radiation, it is become immune hot. So give immunotherapy, 3 year you have 57% will be surviving. And if you go to 5 years actually, it is 43%. So more patient not dying, but they are surviving, and the graph is actually better. So this is the stage for lung cancer actually. What we get usually, our main intention of treating a stage for lung cancer is quality then quantity. Main is quality then quantity. What we see more of a quality. This is actually what we do actually. Patient come to us with a stage for lung cancer. We get the tissue first. Tissue is the issue actually. Tissue first. And actually if a central tumor, pulmonologist, if it is a peripheral tumor, then radiologist, we get a tissue. If patient is symptomatic, we start chemotherapy. If the patient not symptomatic, we send the mutation report actually. And once the mutation report comes, there is mutation, we don't give chemotherapy. If there is no mutation, then we discuss about chemotherapy plus immunotherapy. We send one tissue for PDL1 testing. If PD-L1 high, then chemoimmunotherapy will be better. If no mutation, PD-L1 high, chemoimmunotherapy is better. If PD-L1 is more than 50%, you can go give only immunotherapy. This is the targeted drugs actually. Once cancer develops, they develop mutations actually, and we are now having every mutations one drug actually. And these drugs will be now some drugs are available in India, some not available in India, but maybe with time everything will be available in India, and 50% of the patient will be treated with targetable drugs. This is when I was a DM doing DM in AIMS, just gefitinib came. One patient was a female, got intubated, and we didn't do EGFR testing. We gave gefitinib IRSA that time 1 lakh, and the patient actually came out of the ventilator within 7 days. Patient was very well actually. They miracle you cannot give with chemotherapy. Allotinib, one Bangladeshi patient, nothing, everywhere cancer, and there is no chance to do test, and they were taking home. They called me, you are admitted under surgeon, called me. I just wrote allotinib. That lady came after 1 year. There is no malignancy actually. So what happens? Cancer actually, this is cancer. They suppress the immunity. Actually, they have a PDL1 in the cancer cells. The the immunity in NK cells or T cells, they have PD1. So what they do, they crosstalk and they grow if there is no immunity. So we have the now the PDL1 inhibitor or PD1 inhibitors, which will break this chain and increases the own immunity to fight cancer. So this is the, I think will not help, but interest you much. But what we do if somebody doesn't have a mutation, we give chemotherapy with immunotherapy combinations. So I will summarize actually. Lung cancer is very bad actually. If you have a early stage, maximum they recur unless they have a EGFR mutation actually where we give osimertinib. So mainly stage 4 and maximum in stage 1, 2, 3A they will recur. So maximum patient will come to the medical oncologist actually. So if somebody have a mutation, we treat according to mutation. Adjuvant osimertinib actually we are giving. Maybe with time we will see all the mutations will have adjuvant treatment actually. So what is the unmet need actually? Lung cancer literacy and awareness. I think it has increased. What was previously it has increased. Access to the medicines actually. The World Cancer theme was actually accessibility of the medicine. All the medicines is not available to everybody. So accessibility of the medicines. What in India we are getting generic medicine, we are getting more accessibility. Patient support actually, how to increase the patient support. Actually, how Madam told, rehabilitation, everything is very important in lung cancer management. Early diagnosis, we don't have any early diagnosis screening methods actually. We don't have the radiologist, we don't have the screening methods, so we don't have patient who are early diagnosis. So general physician is very important actually. The patient will go for the general physician. Before actually we are seeing most patients started with ATT. Nowadays they are being referred very early to the pulmonologist, and the pulmonologist do the diagnosis and they immediately they send to the medical oncologist. So that is very important. And the general physician, actually patient once treated any complication, they will go to the general physician. During recurrence also they will go first to general physician. They must be very aware. Any problems they must do at least a CT scan or refer back to oncologist and follow up. Thank you.
So we will, with that, we will close the session for today, and we will again rejoin tomorrow morning at 10 a.m. Thank you.
কালকে হবে এদেরটা কালকে আধ ঘন্টা টাইম আছে ঠিক গুড মানে এরা পরিশ্রম করেছে প্রেজেন্টেশন উইদাউট প্রেজেন্টেশন